increased creatinine and increased blood nitrogen. LFT showed increased SGOT and SGPT, decreased total protein and albumin. Further tests showed that serum hemoglobin was positive, urine tox screen was positive for benzodiazepine, CPK was elevated more than 98,000 and NDH was 3321. Radiological examination showed that USG abdomen showed that borderline hepatomegaly and fatty liver was present, echo and MRI brain was within normal limits. So we have a patient with myoglobinuria and AKI, raised CPK, NDH, and raised liver enzymes AST and ALT. The likely diagnosis is rhabdomyolysis. So the final diagnosis of the patient is likely to be serotonin syndrome with rhabdomyolysis, acute benzodiazepine toxicity, major depressive disorder. The treatment during the hospital stay was he was put on empirical antibiotics. The dose were registered according to creatinine clearance. Intensive antibiotics rehydration. The patient was started on bromocriptine, cyproheptadine, and triaxpinidine for serotonin syndrome and pain tremors, respectively. The patient was finally extubated and discharged after 18 days of admission. He was counseled regarding the need for care, support, and supervision, and also the importance of proper neuropsychiatric counseling. Thank you. Now, a little bit about serotonin syndrome. Serotonin syndrome is a potentially life-threatening condition resulting from increased serotonergic activity in CNS. It is characterized by the tribe of symptoms of neuromuscular excitation, autonomic instability, and altered mental status. Hunter's criteria can be used to diagnose serotonin syndrome, which basically tells that if there is a history of exposure to some drugs which increase serotonergic activity, and the patient has presence of either spontaneous tremors or inducible tremors or occular tremors and hyperreflexia, we can consider the patient as having serotonin syndrome. There is no lab criteria as such, it is basically a clinical diagnosis. The causes of serotonin syndrome could be drug-related causes or non-drug-related causes. The drugs which cause serotonin syndromes are SSRIs and SRRIs, which decrease the uptake of serotonin from synapse. Monoamine oxidase and MAO inhibitors, which decrease the degradation of serotonin from synapse. Drugs like tramadol, linezolid, MDMA, dextromethorphan. Serotonin precursors, which increase the synthesis of serotonin, and some drug interactions like serotonin reuptake inhibitors plus MAO inhibitors. Non-drug causes can be carcinoid tumors which secrete serotonin, CNS lesions, tryptophan-rich food, and serotonin supplements. The treatment basically involves supportive treatment and medications. Supportive treatment, we need to monitor vitals frequently. We need to check for complications like muscle damage, IV rehydration, cooling measures for hypothermia, and oxygen supplementation. Medications primarily include discontinuation of serotonin agents, benzodiazepines, cyproheptadine, and antihypertensives. The indications for ICU stay might be if the patient develops seizure, if he develops decreased urine output of AKI, if he develops myoglobinuria, then ICU admissions can be considered. Thank you. So, in this case, serotonin syndrome and rhabdomyolysis occur together. And it is a very common syndrome when we are specifically when we are dealing with psychiatric patients who are on SSRIs. And SSRIs and SNRIs are one of the most commonly prescribed drugs for any kind of mental psychiatric disorder, especially depression, which is quite common these days. So we need to be on a watch for our patients who might present to us with these symptoms. And we need to check for those triad of symptoms, altered metals in sodium and autonomic instability, etc. So that we need to diagnose this syndrome early, and hence we need to treat this early as well.
So it is also maybe
Yes.
Part of serotonin syndrome.
So it can happen as a part of serotonin syndrome, but in serotonin syndrome there might be sustained clonus, which might cause muscle damage.
We are talking about elevation of enzymes and rhabdomyolysis. What is the possible cause of rhabdomyolysis as well as these elevation of LFT?
So concurrent muscle damage due to hypothermia, due to increased tone of muscles, which might lead to muscle damage, and hence AST and ALT might increase. They might not actually be due to liver damages as such, but might increase due to the ongoing muscle damage, and hence myoglobinuria might also present.
Did you get the serotonin level checked in your patient? Confirmation diagnosis. Confirmation diagnosis by doing the level of serotonin.
So we did not. There was actually cost constraints of the patient, so we did not actually go to. But sir, basically, clinically we were quite sure that he was having serotonin syndrome because, so that's why we did not actually went for serotonin levels. Ma'am, we can go for blood serotonin levels, but serotonin syndrome primarily is clinically also, and ma'am, clinically also we can primarily make a diagnosis of serotonin syndrome if we have a history of prior serotonergic drugs and the patient presents with either pronus or sustained pronus, inducible pronus or ocular pronus. So in this case, we made the diagnosis clinically, ma'am, but we could have gone for a better test of serum serotonin.
Invite the next speaker, Dr. Saurabh.
Done.
Good morning, everybody. I'm Dr. Saurabh Gupta, first year DNB trainee at Sir Gangaram Hospital. My topic is ocular window to neurological disease, diagnosing neurosyphilis through fundus examination. So basically, we recently had two patients who presented with ocular symptoms, and we suspected syphilis in those patients, and they were positive for neurosyphilis. So let's start with the introduction of syphilis and neurosyphilis. So syphilis is a sexually and vertically transmitted infection caused by Treponema pallidum, a slender spoiled spirochete that remained a significant global health concern, particularly among people living with HIV and AIDS. The classical progression, as you all know, involves primary childcare at the inoculation site, secondary rash, which develops over weeks, latent period, which can be of variable duration, and finally tertiary syphilis, which affects CNS or cardiovascular system. Neurosyphilis can manifest at any stage of syphilis infection, presenting with a wide spectrum of neurological and ophthalmological manifestation, often making diagnosis challenging without proper clinical suspicion. So this is the first case. We'll be discussing both the cases under three headings: patient presentation, ophthalmic findings, and diagnostic result. So the first patient is a 66-year-old male with 7 months history of decreased vision in right eye. The complaints was associated with white oral patches and ulcers and malaise. On ophthalmic findings, it was found that the patient had granulomatous anterior uveitis with mutton fat keratic precipitates. There was significant vitritis and active retinitis. The fundus examination, as you can see, the posterior uvea is pretty hazy, most probably due to vitritis. On further examination, actually after this fundus picture, the initial ophthalmological diagnosis that came out was CMV retinitis, not typical CMV retinitis as the present eye appearance, but we did CMV RT-PCR to confirm the diagnosis, and CMV RT-PCR turned out to be negative. On further examination, HIV antibodies were reactive. Serum rapid plasma reagent was reactive in a titer 1:4, and we proceeded with CSF analysis that showed pleurositis. VDRL was non-reactive and TPHA was positive. So a diagnosis of neurosyphilis was made. The next patient that we had was a 29-year-old male who presented with blurring of vision in left eye, intermittent floaters for past 3 months with no history of previous ocular pathology. On ophthalmological examination, the patient had retinal vasculitis, past lenitis with snow banking and vitritis. On fundus examination, as you can see, there is a old healed lesion in the retina, and the white streak that you see that has been labeled is vasculitis. We could not delineate whether it was active or not because the patient refused for further fundus fluorescent angiography. On further workup, HIV antibodies were yet again reactive. Serum RPL was highly reactive with a titer of 1:64. CSF showed similar picture of pleocytosis, VDRL non-reactive, and TPH weakly positive. So, how do we perform neurosyphilis? With a classical triad of pleocytosis, elevated protein, and reactive VDRL. But VDRL has limitations that it may be non-reactive in up to 30% of neurosyphilis cases. FDA ABS can be done. It has high sensitivity, but non-reactivity effectively excludes neurosyphilis. But it can be falsely positive due to translocation of antibodies from serum to CSF in some cases. DPHA has even higher sensitivity than FDA ABS, but does not differentiate between active and past infection. So what are the indications for CSF analysis in neurosyphilis? As you can see in this flow chart, it has been very nicely delineated. Any patient with syphilis who has a neurological signs or symptoms should undergo a CSF examination. Any person with a cardiovascular or comatose syphilis, any person with syphilis who has sustained increase in titers more than equal to 4-fold without reinfection will undergo CSF examination. And any person with syphilis who has received stage adequate treatment for adequate duration of time without reinfection and there is inadequate serological response. So therapeutic management of neurosyphilis, both the patients received the gold standard therapy. They were treated with IV aqueous penicillin G 24 million units per day administered in 6 divided doses for a total duration of 14 days. Antiretroviral therapy was initiated concurrently. The clinical response was pretty good, treatment outcomes were favorable, symptomatic improvement in both patients was seen and objective improvement in fundus examination with progressive resolution of inflammatory signs. So the take-home message is all HIV diagnosed patients should undergo syphilis screening and all syphilis patients should be tested for HIV due to high co-infection rates. Patients with ocular syphilis should undergo CSF analysis to rule out neurosyphilis even with asymptomatic neurological presentation. Persons living with HIV/AIDS have increased risk of asymptomatic neurosyphilis. Therefore, the threshold for CSF examination should be lower in this population. IV aqueous penicillin 24 million units per day for 14 days is the definitive therapy and there is no need for repeat CSF examination after completion of treatment. Ophthalmologists have a crucial role in early diagnosis of neurosyphilis as ocular manifestations may precede other neurological symptoms. Fundus examination provides a valuable window into potential CNS involvement. Thank you.
In your presentation, the history part में sequestration missing. You have done after examination, you have done HIV test. I think you have taken history prior to examining diagnosis of HIV. You have mentioned you have taken all aspects of the history, suspicion, and then testing, and then diagnosing.
Yes.
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 Ocular syphilis is a documented ocular syphilis side is definitely supplied.
Sir, actually, ocular syphilis there have been cases where ocular syphilis have coexisted with normal CSF analysis without any reactivity to VDRL.
In the rare ulcer ocular syphilis, it is considered a manifestation of syphilis, right?
Yes, sir, but according to
Very much it is proven that you have ocular syphilis and it is so ocular syphilis already established fact.
yes, sir, but according to the CDC 2024 guidelines, sir, all patients with presenting with ocular syphilis should have a CSF analysis. So to look for neurosyphilis, ma'am. It is. Yes.
Once you have diagnosed the ocular syphilis, I take a test and fundus finding. It means that in the case of neurosyphilis, and you can treat as per the neurosyphilis straight away.
Yes, sir.
Is CSF findings make any difference to the treatment? None. That's why. Thank you very much.
Thank you.
Next is
फ्रीज करो वो लगा दूँ
चेंज करना है मुझे
आपको देने दूँगा उठाना है
Good morning.
क्या हुआ है भाई
Yes, and I am Dr. Shiri. I am postgraduate
एक्सक्यूज मी
at Lady Harding Medical
क्या हो
College.
गया?
So I will be presenting my thesis case.
फ्रीज टाइम सर 1 मिनट
सर छोड़ पीडीएफ वाला देना है या कौन सा PPT दे दीजिए।
यही है ना इनकी?
So I will be presenting my thesis case regarding etiological profile of uninvestigated dyspepsia in patient without alarm symptoms. So my question would be, why would we investigate for dyspepsia, as it is a common complaint which is often treated symptomatically, and many a times it is incompletely treated, and sometimes it can be a manifestation of a easily treatable condition, example worm infestation, or even gallstone disease, or a more sinister cause could be there, especially if patient having alarm symptoms like malignancy. So, and study regarding these etiological factors of dyspepsia have been limited in, especially in the Indian settings. So, the objective of my study was to evaluate the identifiable causes of dyspepsia without alarm symptoms, which is non-investigated by UGI endoscopy, stool examination, or USG abdomen at all. And patients were on proton pump inhibitor therapy for the past 3 months. So, they were non-dilute on medications. So it was an observational cross-sectional study design, and patients were defined by room 4 criteria for dyspepsia and were not previously evaluated by UGI endoscopy, stool examination, or USG abdomen, even after 3 months of proton pump inhibitor therapy, and sample size was 85. So these were the investigations that we did. They were thyroid function test, stool examination for ovarian cyst, USG whole abdomen, upper GI endoscopy, and rapid urea kit from biopsy sample taken from endoscopy and endoscopic biopsy for tissue diagnosis. So results. So age and gender distribution were there, and the mean age was 35.5 years, and with a standard deviation of 9.87 years. And the gender distribution was of having 2:3, with 61% patient being male and 38% being female. We can see the age distribution that in this study the most common age group was 30 to 40 years patient. There were the different causes that we evaluated, and on history taking, food habits were contributory in about 71% of the patients, and other drugs other than proton pump inhibitor, they constituted 10%. Some patients even had addiction history like smoking or alcohol, which constituted 21%. Cholelithiasis was found in 2.4, that is 2 patients, Barrett's esophagus in 1 patient, hypothyroidism in 1, and esophagitis in 52 patients, hiatus hernia in 41, gastroesophageal reflux disease in 48 patients, and gastritis in 81%, almost all the patients, and H. pylori in 26, and 2 patients were diagnosed with celiac disease. Endoscopy findings revealed esophagitis in 52 patients, and hiatus hernia in 48, gastritis in 81, and esophageal nodules were also present in these patients. Gastroesophageal reflux was present in 48, and some patients even had blood loss on this disease. Many of the findings were overlapping in a single patient, so they might have multiple etiologies regarding this complaint. Also, grading of esophagitis was done, in which majority of the patient had grade A esophagitis, and approximately 7.1% had grade B, and 13% grade C. Regarding the stomach findings, most patients had mild and moderate enteral gastritis, which mild constituting about 46% of the patients. Histopathological report regarding endoscopic biopsy, in which almost 66% of the patient, that is 56 patients, did not have any significant histological abnormality, while 26 were tested positive for H. pylori on biopsy. And even though we had 20 esophageal nodules in endoscopy, only one of them had Barrett's esophagus, and 2 were celiac disease. Regarding the investigative modalities which identified the cause, UGI endoscopy remained the best out of them, in which it identified approximately 95% of the patients having some etiological factors, which was followed by endoscopic guided biopsy or cytology, and then stool investigation, USG and PFT repeat. Patients having probable treatable causes involved gastritis most commonly, and then GRD and esophagitis. Some rare causes included cholelithiasis, celiac disease, and hypothyroidism. So, conclusion of this study was almost all the patients with dyspepsia without alarmism not responding to medication. The cause of dyspepsia was identified in approx 95 of the patient. In 4.7%, no cause could be identified. So probably we could label them as functional dyspepsia. The most common findings were gastritis, esophagitis, and GERD and hiatus hernia. And multiple overlying etiologies were present even in single patient. No malignancies were detected in any of the patients. Among probable treatable causes, most common were esophagitis, gastritis, and GERD, and cholelithiasis, celiac disease, and hypothyroidism constituted minority of the patient, and 1/3 of the patient of dyspepsia were associated with H1. Thank you.
Wonderful presentation, Dr. Sushil. Few things I would like to ask you. Why PFT is banned?
Sir, according to text, that it has been known as a risk, as a cause of dyspepsia. Sir? Sir, actually we had excluded the previously known patient who were hypothyroid, but these patients who were not previously tested for it, we included.
Have test in all patients?
Yes, sir, we did it every patient, and patient who were already known case of hypothyroidism, we excluded them from the studies. Yes, sir.
So your next thing, food habit, you have mentioned 60% of the causes.
Yes.
You have not mentioned what your food habit.
Yes, sir. No, sir. Yes, sir. We actually asked regarding the dietary habit, the food habits that triggered these symptoms. Sir, most commonly it was associated with tea. Approximately 60% of the patients, it was tea. Yes, sir.
Tea is a common thing.
Yes, sir.
What food habits comes out in your study?
Yes, sir. We should have evaluated more, but I could not. But
Actually, hiatus hernia is very high, 41%.
yes, sir. Sir, actually, no, sir. Actually, according to some study, it is not that common. It is approximately 20 to 30% only. So the reason for we having these increased number was probably because the patient that we selected. These patients were young patients, and they were patients who had persistent symptoms even after 3 months of therapy. So probability of having these cases might have been more, because as if they wouldn't have these symptoms or they would have been treated earlier, so we wouldn't have included them in our study. So possibility of anatomical abnormality would be more as they had persistent symptoms.
How did they define dyspepsia?
They have taken room 4 criteria.
Room 4 criteria.
Actually,
Yes, sir.
But you also said these are cases of functional dyspepsia. All these cases of functional dyspepsia.
No, sir.
Functional dyspepsia, upper GI endoscopy should be normal. Other criteria.
Yes, sir.
These are not cases of functional dyspepsia.
No, sir. These are not cases of functional dyspepsia.
That once.
आप जो स्टडी कर रहे हो, when you are doing a study, you need to standardize so that there is no subjective. As sir has rightly said, if you are using a wrong for criteria, it is for functional dyspepsia.
Yes, sir. Yes.
For that endoscopy means there is no organic cause.
Yes.
Then it is still functional. So what was the definition of dyspepsia you took?
Sir, we took definition of dyspepsia as having 4 symptoms: epigastric fullness, postprandial epigastric pain or burning sensation in abdomen, and
Any, all, one or
sir, any of these symptoms for which patient has been presenting for at least 3 months.
particular duration, किसी को एक बार हुआ तो भी हुआ.
नहीं sir, at least 3 months. At least 3 months.
Explain it properly कि आपने ली.
Yes.
दूसरा अभी है डॉक्टर अशोक has said, food habit again is a very subjective thing.
Yes.
So I don't think you have any sanitization in these 4 food habits you have taken. what kind of food have you considered as a trigger for a defect?
Yes, sir. Actually,
Again with the drugs, you have written the drugs are none other than PPI and H2RH.
yes, sir.
So how they are the cause of dyspepsia?
So they are not the cause of dyspepsia, but we have taken drug history and excluded patient who did not have use medication.
And cause are very two different things.
Yes,
You
sir.
should not be confusing that in a study. Something is acidic doesn't make it automatically a causation of it.
Yes, sir.
So having some other drugs, maybe taking a statin alone.
Yes, sir.
That doesn't become a cause of dyspepsia for it. So you have to make it very clear what is the case. Now coming to this, go to the other slide. So don't say that is the causes, then you should use the word that these are the acidic findings you are finding. Again, you establish it.
I want to add one thing here. Most of the literature does not endoscopic findings of the endoscopic finding of esophagitis do not correlate with the blood. So there is no direct correlation between
यहाँ
the
पे जो था।
blood and endoscopy.
अरे
माइक
दे
ऑन कर
दिया,
दो,
ऑन
दे दिया।
करो।
So another thing, you have written the proportion of patients having probable treatable cause.
Yes, sir.
And the first thing you have written is gastritis. Is gastritis a cause
दे
or
दिया, दे दिया।
manifestation of the underlying?
So it can be probably a cause as
मेरा question वही है, polylithiasis can be a cause, but is gastritis a cause or is gastritis a manifestation of something which is causing gastritis? And the cause is not gastritis, the cause is something which is causing gastritis. You are missing a lot of things over here.
Blood clotting and non-luminescent and related gastritis also. So that clot what do you mean by that?
ma'am, blood clot were found in patient having gastritis, like in the grading of gastritis, severe gastritis and
Exactly. So it is a part of the
Part of
gastritis,
gastritis.
not a different finding.
yes,
So it should be included in that. And secondly, blood clot is relatively severe.
Yes,
Here
ma'am.
you have mentioned that mild to moderate was the maximum patient.
Yes,
And
ma'am.
there was no severe gastritis, that's the good report. But if clots are there, then
They
we
did
should
the-
Alarming symptoms क्या कहते हैं?
Sir?
Alarming symptoms क्या कहते हैं?
So alarming symptoms, new onset dyspepsia in more than 60 years, dyspepsia associated with iron deficiency, dyspepsia associated with weight loss or any family history of the patient having any malignancy.
तो आपने सबको screen किया है इसमें?
Yes sir, history पे इन सब चीज़ों को screen किया था investigation के लिए।
History पे आपने iron deficiency कैसे screen किया?
जी सर,
History पे आपने iron deficiency कैसे screen किया?
सर एनीमिया की हिस्ट्री पूछी थी कि Yes, sir.
Your population has only younger patients. Why it is so? Have you excluded older patients?
सर
All, well, if you are not excluded, then everybody should be included with the symptoms of dyspepsia as per the criteria you mentioned. So your population.
आपने age distribution दिखाया है उसमें?
yes sir,
अब आपका एक अलार्मिंग सिम्टम क्या है, वो 60 प्लस के बाद आपका होता है, इसमें तो 60 पे आपकी गाड़ी रुक गई है, एक अलार्मिंग सिम्टम ने वैसे एक्सक्लूड कर दिया जिसमें एक्चुअली जरूरत है। इस स्टडी से तो निकला कि जिसमें अलार्मिंग सिम्टम नहीं है उसके अंदर कोई अलार्मिंग फाइंडिंग नहीं निकली है।
Yes,
ये
sir.
बात ये होती है ना that somebody doesn't have a red flag then he doesn't need a required to get alarm। हाईकोर्ट क्राइटेरिया बता सकते
सर
हो? हाईकोर्ट बता सकते हो?
Thank you, appreciate your presentation. Thank you so much. I thank over to the Ram Babu for the.
Thank you, judges, for conducting this beautiful session, and thank you all the participant candidates beautifully present their papers. Result will be announced in later on. Just please. So now I want invite to on dais Dr. Richard Dewan, Professor Richard Dewan, to felicitate the chair judges. Please, Richard Dewan. So I want to. Dr. Amtesh, Dr. Ashok, Dr. Lakshmi, please come on. Richa madam.
ऊपर चढ़ा रहे नीचे कर दो यार।
कोई नहीं मैडम, अभी तो
अभी तो नहीं।
अशोक,
ये रैपिड से।
नाउ मैं बता।
आगे आगे आगे। Loud enough. Shiva. वो खराब हो रही है पिक्चर SMS में क्या सबको बैग नीचे देना रामा को
So, we will move on next session, that is. So, next session is we have a wonderful doctor as a human being and quiz master Dr. Mukesh Bhatia. So next session is will be the quiz for the PG students. So please come on, rise to Dr. Mukesh Bhatia. And for this session, I will request to share Dr. Hemant Sharma, Dr. Manoj Arora, and Dr. Amit Sharma. Dr. Amit Sharma. So now, my hand over to the chairpersons.
Good morning all. So we are into a much awaited interesting session on quiz by quiz master Dr. Mukesh Bhatia. So without wasting time, I request you to start the proceeding and schedule for the rules and regulations of the presence. Thank you.
थैंक यू डॉक्टर हेमंत चेयरपर्सन। जो पोस्ट ग्रेजुएट आगे आ जाएंगे तो भी टीमें नहीं बन पाई हैं तो विल हैव अ सिंपल डिस्कशन। सवाल प्लीज कम इन द फ्रंट सीट्स।
नहीं मत करने से
Please about the front seat, please.
All postgraduate, please come to the front seats. Sir, sir. लेटर पॉइंट
पीपीटी देखे गए हैं
कौन देखे
इन्हीं की पीपीटी है पूछना किन नाम से दूसरे पॉइंट दे दो पूछ लेना
हाँ चेंज करते हैं
स्लाइड चेंजर का
सिलेक्शन दिया
तो आप लोग करोगे
नो नो
स्लाइड चेंजर
जस्ट अ सेकंड
पॉइंटर वाला लगा
आप चेंज कर दो चेंज कर दो
ठीक है
हाँ हाँ ऑन कर दो
फर्स्ट स्लाइड
या फर्स्ट साइड सर जस्ट
मुकेश एक मिनट रुकना लोगों को पता नहीं है हॉल की भी है
एक्चुअली हर बार एक ही हॉल में होता है इस बार वो हॉल में कर दिया डिवाइड हो
Can you call them? Very important session. We should do it.
टाइमिंग
30 मिनट्स 30 मिनट
10 में 3 सेशन है सर
नहीं नहीं 30 मिनट्स का
10 मिनट का ना
नहीं नहीं चेंज कर रहे हैं
अच्छा 30 मिनट्स का सेशन तो 11:30 हमारा शो राइट
या प्रॉब्लम
अगर इन्होंने टाइम पे
या
थोड़ा
So
बहुत
as the टीम्स नहीं बन पाई हैं, तो इट विल बी लाइक ए टेस्ट सेशन ओनली, एंड ऑल ऑफ यू आर विल बी अपीलिंग फॉर द टेस्ट ऑल्सो। सारे क्वेश्चन हैं और काफ़ी सारे क्वेश्चंस वो एडीपीएफ की कॉन्फ्रेंस के लिए, बट एवरी क्वेश्चन इज फ्रॉम द टेस्ट। With due permission, couple check, can I start?
पेंटर दीजिए उसमें मिलर साथ में
Can I start now?
नेक्स्ट वाला कॉपी कर लेते हैं। भाई वो वाला क्या है भाई? वो वाला टाइमर क्या है? हाँ फ्री काउंटडाउन, हाँ फ्री काउंटडाउन वाला ले रहा हूँ। उसको कॉपी कर लिया। इसमें है
सर ऐसा है, दो टीमों का काम होगा। आई डिस्कस सर, आप डोंट वरी। तीन हो जाएंगे सर, तीन का लगभग बिठा दो। तीन का आइडिया भाई 3 हो जाएंगे सर, इनको डिवाइड होगा 3 हो जाएंगे। ठीक है, इसका बात है क्या बिठा लेंगे ए बी सी का चलो ऐसे करो, 3 की बात है। आप आंसर करते रहना, हम
वन टू
एक टीम ये है और नहीं वो तो मेरी स्टाफ है, मेरी स्टाफ है। आज आप इतना 3 दिन बाद
साउंड क्या खा रहा पहले ये बताइए।
वो एक हो जाएंगे, ये वाली टीम आ जाए, 3 टीम हो जाएगा। चलो ठीक है।
We have 3 teams now. Team A, Team B, Team C.
अब रूल ये रहेगा, अभी क्या है सर, हाँ जी हाँ जी, अपने एक मिनट नाम बताओ और कॉलेज खड़े माइक देंगे, एक माइक देंगे, माइक 2 माइक देंगे और दो माइक को दो, एक माइक दे दो कमरा जी, एक माइक दे दो या जल्दी से बोलिए।
डॉक्टर रवि रेडियोमेडिक मेडिकल कॉलेज
नीरज
तो पहली टीम पेंटर निकाल दीजिए। हाँ आप
डुप्लीकेट ढूंढना।
आर्मी
ये सब दावत कर रहे हैं।
आर्मी टीम 2 आर्मी
डॉक्टर आदित्य संगम
माइक चेंज कर दो।
मुझे कहा गया कि मैं और
स्टैंड माइक भी है।
एंटरटेन करें। चलो जी ऐसा करेंगे, बात सुनो, हमारे पास एक स्टार वार्ड है, इसकी इतनी सुरीली आवाज है, नहीं यार अबे एंटरटेनमेंट की बात कर रहे जी। आपको एंटरटेनिंग क्विज का एक वैसा नहीं, आप आगे कहाँ समझ लेना। अब आदेश आएगा, हम तो खड़े हैं बाबू। चलो एनीवे जब तक वो आते हैं, रूल्स ये हैं कि हर एक क्वेश्चन पे सही करने पे 10 मार्क्स हैं, ना करने पे 0, कोई नेगेटिव मार्किंग नहीं है, कोई पास नहीं।
किसी को वहीं पे दे दो, ये हाल उसका भी ले रखा
20 मिनट
है
है, 20 मिनट तो सारा नहीं मिलता, ठीक है। और जितने भी क्वेश्चन ये सारे नीट एसएस के क्वेश्चन हैं, पर ये आपके बहुत काम आए। तो पर्पस ऑफ कमिंग सॉल्व ये इसमें फायदा हुआ है, ये नहीं यहाँ से सुना, यहाँ से निकाल दिया, नोट लाए।
बड़े मुकेश आपको माइक जस्ट ना
कैसे बोलिए अब ठीक है, आवाज आ रही है पीछे? यस सब ठीक है। यस सर चलो टिप्स दे, टिप्स सबके लिए आपके जो मेरे पीजी दोस्त बैठे हुए हैं, सबसे बड़ा टिप आपके लिए ये है, जब आप अपना एमडी डीएमबी कर रहे हैं, साथ साथ ही आप एमआरसीपी की तैयारी भी कर रहे हैं, क्योंकि एमआरसीपी इज ए वर्ल्ड रिकॉग्नाइज्ड पोस्ट ग्रेजुएट डिग्री है, एमडी नहीं है। और एमडी करके जाओगे तनख्वाह 100 रुपये होगी और एमआरसीपी पे 300 की तनख्वाह होगी। ओके, इंटरनेशनल डिग्री है और वहाँ जाके यूके जाके काम वहाँ का क्या लेकर क्या है ओके, दिस इज ह्यूज डिफरेंस। वहाँ का कल्चर जाके करते हैं, फर्क है, कोई शक नहीं है, डाउट हुआ। ओके, करा मैं आपको नीट एसएससी करा दूंगा, बोल रहा है हम सब करा दूंगा, गाइड कर दूंगा। हम लोगों को पढ़ने के तरीके नहीं आते, याद करने के तरीके नहीं आते, ये मैं सिखा दूंगा। मेरा बड़ा फेमस लेक्चर है, जहाँ मैं जाता हूँ कितने घंटे पाँच घंटे 10 घंटे पता ऐसे 1 आवर एवरीबॉडी लव्स है। हाँ हाँ 1 घंटे तक कौन टॉप करेगा, ये लेक्चर मैंने जब मैंने 1 घंटा पढ़ के सब हल कर दिया। आफ्टर 1 आवर 7 मिनट तक तालीम होती है सर, आप पहले भी पढ़ाई क्या है, सबसे बोरिंग काम दुनिया में पढ़ाई करना है। It should done in the most interesting way का एग्जांपल मैं दूंगा आपको। तो हाँ सर मैं आजाद हूँ, उठा लेंगे आप, तो एडजस्ट कर लेंगे, कोई दिक्कत नहीं। ठीक है, क्वेश्चन आर ओनली फॉर पोस्ट ग्रेजुएट, नॉट फॉर कंसल्टेंट। पहले कह रहा हूँ, ऑफ कोर्स कंसल्टेंट कैन गिव ओपिनियन, बट प्राइमरी फॉर स्टूडेंट्स। और जस्ट टू इन्फॉर्म, डॉक्टर भाटिया अकेडमी और बनाइए, इसके अंदर लैब, एमएलई, एमआरसीपी एसएस करता हूँ, अगेन फॉर योर इंफॉर्मेशन। ये आप सभी लोग इसको स्कैन कर लेंगे, इसमें आपको बहुत सारे फ्री लेक्चर भी मिलेंगे, आपको फ्री लेक्चर। फटाफट कीप योर मोबाइल ऑन, लेकिन साइलेंट मोड। कर लिया? I assure you that it will be a mind-blowing session. You will learn a lot. ये मैं पहले कह रहा हूँ। को हिस्ट्री के बाद हमने रूल आउट कर दिया कि ड्रग इंजरी की हिस्ट्री नहीं है। कॉमन कॉज ऑफ कुशिंग सिंड्रोम इंक्लूडिंग प्रैक्टिसेस हाइड्रोजन। फिर पहले स्क्रीन करें। स्क्रीनिंग में 3 टेस्ट है, 24 आवर यूजली फ्री कॉर्टिसोल विद सेलेवरी और डेक्सामेथासोन ओवरनाइट टेस्ट। इसमें ये वाला जो है मिडनाइट सेलेवरी कॉर्टिसोल का फर्स्ट टू गेट क्योंकि द फर्स्ट फीचर ऑफ कुशिंग सिंड्रोम इज अल्टरेशन ऑफ द सर्केडियन रिदम। नॉर्मली मैक्सिमम स्टेरॉइड इन द मॉर्निंग, मिनिमम रात को। जब रात को भी कॉर्टिसोल आ जाए उसका मतलब डिलेज है, बट ये स्क्रीनिंग टेस्ट है। फिर नाउ टू डिफरेंशिएट बिटवीन कुशिंग एंड सूडो कुशिंग, तब हम करते हैं लो डोज टेस्ट। पहले वाले में था ओवरनाइट टेस्ट था, उसके बाद हम चेक करेंगे ACTH, बिकॉज ACTH इज इंक्रीज इन पिट्यूटरी एंड एटोपिक, so it is reduced in adrenal adenoma. उसके बाद टू डिफरेंशिएट बिटवीन पिट्यूटरी एडेनोमा एंड एटोपिक सेक्रेशन वी डू हाई डोज एक्सा एंड ऑफ कोर्स CRI स्टिमुलेशन। लेकिन कुशिंग डिजीज की जब हम बात करते हैं वेयर वी आर टॉकिंग अबाउट पिट्यूटरी ट्यूमर, द मोस्ट एक्यूरेट टेस्ट इज इंफीरियर पेट्रोनल वीनस सैंपल। आप वहां से सैंपल लेंगे सीटी का और एक सैंपल उससे वो यहां आपका जेल से लेंगे, रेशियो 2:1 इज द डायरेक्ट ऑफ कुशिंग डिजीज। अब एक गोल्डन लाइन सब भूल जाओ, पूरी कॉन्फ्रेंस भूल जाओ, ये लाइन नहीं भूलनी है। In endocrine we never diagnose any disease based on radiology.
लैपटॉप उठा है,
Never.
ये लो ना,
Radiology is supporting it.
माइक्रोफोन डालो ना,
And you always diagnose confirmed by
ये उठा रहा
So I hope क्या सीखा?
माइक्रोफोन डाला है ना आपने, ये वाला माइक्रोफोन डाला है ना, माइक्रोफोन में ये उठा रहा है इधर
चलो
उधर।
टीम 2 कौन सी है? हमारी आर्मी वाली। या
ये देखो माइक्रोफोन में है, भी माइक्रोफोन में है, स्टार्ट हो गया।
टीम 2 माइक दे दो,
माइक देना,
हाइट पर आपने बोला
HDMI केबल
सुन तो दिक्कत हो रहा है इसके में इनपुट में,
ये वाला
का
द आंसर इज
माइक
करेक्ट।
बचाने।
कैप्चर कार्ड
ठीक है 10 मार्क्स।
हाँ कैप्चर कार्ड हो जाएगा,
वो तो
हो जाएगा।
ये
स्प्लिटर
स्प्लिटर
में क्या देखते हैं, एक स्प्लिटर और चाहिए, एक तो अपने इसमें लेगा और
इसके बारे में
जल्दी कह रहे एक बड़ी HDMI दे स्प्लिटर दे।
आ जाओ
देखिए
3-4 कहाँ की है? टीम 4
ये भी कनेक्टर HDMI का।
Give a big hand to Dr. राम बाबू, इनकी पहले टीम 4 भी आई।
इसका रिमोट क्या है?
हाँ जी।
अरे बंद कैसे?
So टीम 3 आपकी है।
बंद कैसे हो गया इसका?
लेकिन फिर
पास जाके
और वो वीडियो नहीं आएगी। अच्छा हाँ इसमें HDMI पावर बंद हो गया। सुन LED पे कौन
छोटी ले लेना, वायरस से छोटी वाली।
एक छोटी HDMI दे
ये रेसो चालू करना, ये पे चालू करना, स्प्लिटर बंद है।
मेरे को एक छोटी HDMI दे फटाफट। अरे रुक जा तू, कोई बात नहीं, प्लाज्मा ही बंद हो गया।
चार कर दिए, चौथी टीम गंगाराम। हाँ जी टीम 3 गंगाराम या
इसको इनपुट में लियो, HDI इसमें डाल और इसको USB में लगा। पहले इसको इनपुट डाल HDMI में।
तो निकाल दो।
ऑटिक्स करेक्ट, आंसर करेक्ट। डॉक्टर राम दोनों क्वेश्चन मैंने NDPF की जो कॉन्फ्रेंस होती है उसमें से लिए हैं।
ये भी DVI कनेक्टर है, इसमें डाल दो, इसको DVI कनेक्टर में डाल देना, कनेक्टर लगाओ नीचे।
आपको नीट टेस्ट पे लिपोप्रोटीन A पे सवाल हर साल आता है, आपको दिया है। लेट्स लर्न LPA is LDL like particle that contain FO lipoprotein 3
सॉरी
नहीं ये तो लूप है, ये कनेक्टर लगाओ ना यहाँ पे, ये कनेक्शन लगाओ।
LPA level are genetically determined family history होगी and are independent receptor for atherosclerosis. It interferes with fibrinolysis
अब तू इसने इसने आउट दे रखा, वही तो ले रखा तूने, जो एलईडी से आउट आ रहा वो ले उठा, लेकिन फिर भी तू एचडीएमआई फिर तुझे
माइक ले लेंगे, माइक लेके बात करेंगे। Louder. A. Ferritin. Ferritin is a UG question. इतना आसान नहीं पूछूंगा आपसे. Don't forget you are going to write DM exam. आंसर के ये क्या चीज है? ये आपने सबसे पहली बात यह सब ईमानदारी स्टैंडर्ड फ्री प्रोटोकॉल ये क्या है? ये आंसर इसके लिए आपको बेसिक बायोकेमिस्ट्री बेसिक बायोकेमिस्ट्री जो ही बन रहा है और अल्टीमेटली पूरे स्टेप बनते प्रोटोकॉल फाइल यहाँ पे कहीं भी ब्लॉकेज होगा दैट इज अ बेसिक बायोकेमिस्ट्री ऑफ अब ये बन गया अगेन कि माइटोकॉन्ड्रिया साइटोप्लाज्म माइटोकॉन्ड्रिया आयरन तो इसका मतलब हीम बनने के लिए हमें आयरन भी चाहिए और अब ये बेसिक कंसेप्ट जब का अगर मान लो आयरन की डेफिशिएंसी है ये तो बन रहा है तो क्या होगा आरबीसी में फॉरेन का लेवल बन जाएगा आयरन अब नाउ यू आर गोइंग टू आस्क मी व्हाई नॉट फेरिटिन व्हाई नॉट मोर एक्यूरेट फेरिटिन इज ए मार्कर ऑफ एक्यूट इन्फ्लेमेशन फेरिटिन बढ़ जाता है और एक और क्वेश्चन अगेन वेरी इंपॉर्टेंट पॉइंट वन अगर आपको ये कहा जाए कि यू हैव टू डू ओनली वन इन्वेस्टिगेशन यू गॉट टू पेशेंट ऑफ फैटी लिवर एक अल्कोहलिक है एक नॉन अल्कोहलिक बट इन्वेस्टिगेशन विल ओनली वन टेस्ट आंसर सीरम फेरिटिन अल्कोहलिक लिवर में 20 पे सीरम फेरिटिन बढ़ता है जबकि नॉन अल्कोहलिक में फेरिटिन लेवल नॉर्मल ये नीट इसका लेटेस्ट क्वेश्चन तो नाउ यू अंडरस्टैंड अब सिडोप्लास्टिक एनीमिया में क्या होता है सिडोप्लास्टिक एनीमिया के अंदर आयरन इकट्ठा हो जाता है प्रोटोकॉल नहीं आता है so that's why in sideroblastic anemia excess of iron get deposited in the mitochondria so called sideroblast very brief 2 minute condition तो आपको बताता हूँ basic correlation of biochemistry with sideroblastic anemia so the best most accurate diagnosis iron deficiency anemia is free protoporphyrin तो ये एक समरी है protoporphyrin free हीम तो ये कंडीशन full cardiac output. Doesn't have an effective method to control peripheral volume. But body can very well control blood volume by diabetes. ये जो दोनों चीजें दे आर इंक्रीज ड्यू टू कैटेगरी तो इन पेशेंट में नंबर यूज इंट्रावेस्कल वॉल्यूम नाउ क्वेश्चन ओनली फॉर पोस्ट ग्रेजुएट्स इज लो हाउ यू फाइंड आउट कि बंदे को लो इंट्रावेस्कल वॉल्यूम है क्या क्लिनिकल टेस्ट और एग्जामिनेशन पोस्टल हाइपरटेंशन गिवन इन हैंड या देखो एक गुरु मंत्र से क्यों एनी कंडीशन जहाँ पे इंट्रावेस्कल वॉल्यूम कम होगा इफ यू रियली वांट टू नो ऑफ कोर्स टंग ड्राई होगी ये हो सकती है लेकिन इफ यू वांट टू डॉक्यूमेंट टेक ए बीपी सुपाइन टेक ए बीपी स्टैंडिंग इफ देयर इज अ पोस्टल हाइपरटेंशन इट्स द मोस्ट एक्यूरेट to tell you the reduced intestinal volume. Now in few chromocytoma there is of course a hypertension but there is associated post-terminal hypertension is there. Don't forget this line. अब ये ब्लड वॉल्यूम कम है जब ऑपरेट करते हैं, जब उसको काटते हैं, एकदम से बीपी फॉल करेगा। पीओ इज ए वेरी टीडियस सर्जरी, हर कोई नहीं कर सकता। जब करने जब पूरा उसको बांध देगा तो एनेस्थेटिक रेडी होता है, दे इन्फ्यूज लार्ज अमाउंट ऑफ बॉडी, इमीडिएटली पुश करते हैं, वरना पेशेंट को ना। पीओ के बारे में इसकी पैथोलॉजी की एक खास बात है, इसे हाईली वैस्कुलर पीओ के कभी एफएनएसी नहीं करते। चलिए, तो ये रहा बेसिक। अब थोड़ी सी और फिजियोलॉजी लेट मी कंप्लीट। मैं पूरा हाइपरटेंशन आई स्किल ओनली वन स्लाइड, अगर आपको दो स्लाइड आती है तो यू कैन आंसर एनी क्वेश्चन। बीपी कार्डियक आउटपुट मल्टीप्लाइड बाय पेरिफेरल रेजिस्टेंस, कार्डियक आउटपुट हार्ट रेट स्ट्रोक वॉल्यूम, बीपी इज हार्ट रेट स्ट्रोक वॉल्यूम एंड पेरिफेरल रेजिस्टेंस। तीन ही पैरामीटर कंट्रोल करने हैं। अगर आपको एक बेसिक फिजियोलॉजी आती है तो यू कैन आंसर, यू कैन टैकल एनी पेशेंट। तो लेट मी स्पीक दैट, ये स्लाइड आपको बाद में देखूंगा। This is the prize winning slide है। Let's read the physiology, heart rate, stroke volume, peripheral resistance, BP are controlled by three parameters. Now, drugs which control heart rate, ivermectin, beta blocker, or the stroke volume, beta blocker, diuretic, nitrate, or alpha blocker, peripheral resistance में alpha can check ACI and direct. पूरा hypertension split in one line. Got it? Right? Point to be noted, beta blocker are going to control heart rate, stroke volume, they are going to control cardiac output. Question 9, कौन से की होगी? Yeah.
H0.
0. The most common wrong answer. Answer 7 calories है। और ये बात 90% लोगों को नहीं पता। क्यों नहीं पता? आज तक समझ नहीं आया। अगर अल्कोहल 0 कैलोरी फूड होता तो मैं ये इंस्टीट्यूट नहीं पक्का। तो मैं अपनी ओपीडी में बैठा सुबह 9 बजे, एक दादाजी आते 120 kg वाले, ट्रीटमेंट 1 bottle of Kingfisher beer in the morning and 9 AM। मरीज खड़ा होकर डॉक्टर एक बोतल से क्या होगा? तो मीडिया तो शाम को जवाब भी बनाओ, ठीक है नहीं? सारे ठेके बंद हो गए थे, सारे बियर बार होते, फिर बुलाया इंग्लैंड से आके मुझे आपका कुछ कितना बढ़िया था, टेंडर बना बड़ा बढ़िया करना होता। दोस्तों, can't afford to miss this question at home guys. It's 7 calories. Okay, सर अभी टाइप कर तो याद रहे 7 calories, ठीक है? अब शराब की बात हो और कोई शेरो शायरी ना हो, ये तो शराब की तौहीन है। एक शेर इरशाद बोले यार, आओ तुम्हें बताएं शराब कैसे पिलाई जाती है। आओ तुम्हें बताएं शराब कैसे पिलाई जाती है। खोलने से पहले बोतल फिर आवाज लगाई जाती है, फिर आवाज लगाई जाती है, आ जाओ टूटे दिल वालों, क्या दर्द दिल की दवा पिलाई मजा आना चाहिए पढ़ने से। चलो एनीवे, 2 मार्क्स टीम, नेक्स्ट टीम। हाँ, ये लेटेस्ट मीट असेस का क्वेश्चन है। रेडॉन, ये श्योर रेडॉन गैस, पक्का कॉन्फिडेंट, लॉक किया जाए। यस, आंसर इज रेडॉन गैस, द राइट आंसर। ये रेडॉन लगा शॉक बड़ी दूर का, ये क्या बला है? रेडॉन इज ए रेडियोएक्टिव नोबल गैस, colorless, odorless, tasteless and naturally occurring. Come on, ये अंडरलाइन। It produced from natural radioactive decay of uranium found in soil, rock, water. एक बार अगर आप गूगल करेंगे तो यूरेनियम इज देयर इन ऑल ओवर द वर्ल्ड, मिट्टी में होता है, पानी में होता है, तो यहाँ से भी निकालते हैं। इसकी मात्रा इतनी थोड़ी होती है तो यू कैन नॉट एक्सट्रैक्ट फ्रॉम द अर्थ। Soluble in water can be released from groundwater or within material also. Poorly ventilated homes, especially जो बेसमेंट में बंद रहते हैं, वहाँ पे गैस इकट्ठी होती है। And living in high radon, जो ग्रेनाइट रिच, आजकल ग्रेनाइट का फ्रैक्शन है, वहाँ पे ज़्यादा होती है। Next question. Next thing कौन सी? That is Ganga. Reading. Option? ये वाला? ये. Louder.
C option, thickness of mucous membrane upon thickness of bronchial wall.
ये वाला ना? ये वाला?
Yes.
C.
Yes.
Answer is C, the right answer. अब इसका आंसर हमें तब तक नहीं आना जब तक हम इसकी बेसिक हिस्टोरी नहीं आना। इस चीज सीख लो अगर आप यू वांट टू गेट अ वेरी गुड रैंक इन डीएम योर बेसिक कंसेप्शन वेरी क्लियर। लेट्स स्टार्ट विद हिस्टोरी ऑफ द एक कट सेक्शन ऑफ द एयरवेज। ऊपर एपिथेलियम है, बिल्कुल ठीक है, इसके नीचे बेसमेंट मेम्ब्रेन और नीचे लैमिना प्रोपेलिया। एपिथेलियम और लैमिना दे मेक म्यूकोसा। इसके नीचे सब म्यूकोसा है, यहाँ पे ग्लैंड्स है, कनेक्टिव टिश्यू और कार्टिलेज। तो टू समराइज आपका म्यूकोसा में एपिथेलियल और लैमिना प्रोपेलिया और सब म्यूकोसा में मेनली म्यूकस एंड कनेक्टिव टिश्यू। वी ऑल नो इन क्रॉनिक ब्रोंकाइटिस there is a hypertrophy of the three common bacteria are Streptococcus, H. इसका साइज बढ़ेगा तो देखिए रीड में म्यूकस ग्लैंड इसकी हाइट है ये डिवाइड बाय सम म्यूकोसा प्लस लैमिना प्रोपिया आल्सो। आई रिपीट इट, थिकनेस ऑफ द म्यूकस ग्लैंड सम म्यूकोसा एंड लैमिना प्रोपिया। दिस इज रीड। तो chronic bronchitis increase in chronic bronchitis. Hello gentlemen, throw the mobile बंद कर दो। Okay, so this is read index. So increase read index is a classical feature of chronic bronchitis. और ये emphysema में नहीं होता है, emphysema में आप स्टोरेज होगा, acini यहाँ पे सबका टूट जाते हैं, and that lead to enlarged size of the acini. And that's the reason that contribute to barrel shaped chest की ये Next question, Gangara, sorry, that was the ipilimumab का क्या है? ये नई ड्रग है, ये आपको सवाल जरूर आएगा।
Option B, CTLA4.
CTL
नहीं
ये वाला sure confident लॉक किया right answer। अब ये क्या सलाह आई है? जस्ट लर्न ये क्या चीज है? एक नई चीज आई है चेक पॉइंट। ये जस्ट अब इम्यूनोथेरेपी में दे ब्लॉक इम्यून चेक पॉइंट। चेक पॉइंट क्या होते हैं? ये जाकर टी लिम्फोसाइट से जुड़ेंगे और टी लिम्फोसाइट इज अ डिफेंस मैकेनिज्म एंड दे विल डिस्ट्रॉय। शी क्या करेगा? इस चेक पॉइंट को जाके चेक पॉइंट इनहिबिटर तो क्या होगा? T cell will be remain activated और वो आपका immune काम करेगा। So the various checkpoint protein are CTLA4, that is ipilimumab, PD1, A1 है और P लिखा PDL1, other drugs. And we use in following condition like melanoma, non-small cell, RCC, okay, heart or blood cancer. And checkpoint inhibitor are used these types of drugs. But you should know ये सवाल आपको इधर जरूर आएगा, बार-बार नहीं पूछेगा। Question 13 कौन सी थी? बस एक बार लास्ट तो quickly. Now I wind up. I said no more discussion. I wind up in next 2 minutes. 2 मिनट। हाँ जी। Quickly फटाफट। जल्दी।
B membranous fluoride.
ये वाला? ये? No, right answer is MPGL. MPGL. Minimal change में loss of just question from pathology. Minimal change में loss of foot pulses, membrane में spike and dome pattern. FFJ में loss of foot pulses but mesangial deposition or splitting of basal membrane prompt tech appearance occurs in MPGL. Next thing. This one. Quickly. water no, it occurs in civil diet. ये क्या है? Provide resistant metabolic electrolysis referred to as electrolysis that does not get corrected with volume resuscitation and leading chloride remain high. Despite what the loss of chloride from the kidney and एक और चीज everybody should remember. In metabolic electrolysis there is a paradoxical acidity and का mechanism है, time नहीं है. Okay, याद है, despite electrolysis there is acidity. Next, the second last question. Second last question. Quickly. जल्दी जल्दी फटाफट.
These cerebral solvents.
ये वाला? यही? राइट आर्म सेरेब्रल सॉल्वेट सिंड्रोम. यहाँ पे हाइपोवॉल्यूमिक हाइपोनेट्रीमिया होता है. तीन तरीके की हाइपोनेट्रीमिया. एक होता है हाइपर वॉल्यूमिक CHF में, यू वॉल्यूमिक SIADL में, एंड लो वॉल्यूम हाइपोनेट्रीमिया करते हैं. सेरेब्रल सॉल्वेट सिंड्रोम. क्लासिकली बंदा नमक खाता है. तो टाइम का लास्ट क्वेश्चन, लास्ट तीन. हाँ,
Pancreatic cancer option B.
ये नो द राइट आंसर इज पॉजिटिव. ओके, विटामिन ई टॉक्सिसिटी में ब्लीडिंग बहुत होती है एंड कार्सिनोमा पॉजिटिव. ठीक है, चलिए हम एक लास्ट क्वेश्चन. वैसे जस्ट ये नया ये है मलेरिया का वैक्सीन है. ठीक है, ये मलेरिया का वैक्सीन आ गया है. टू इन्फॉर्म यू शुड नो. और चलो, तो हमारा सेशन तो सर्टिफिकेट के लिए यहाँ डाल देंगे वैसे. और ये किताब पढ़ लो. यू आर टॉपर ऑफ MD. वी डू MRCP MLE ऑल्सो. MRCP जरूर करें सबने. आपने करा मैं दूंगा. थैंक यू ऑल टीम जजेस एंड सीनियर फैकल्टी. थैंक यू वेरी मच सर.
Thank you, Dr. Bhatia. Thank you, Dr. Bhatia.
मजा आया? मजा आया? एक ग्रुप फोटो खिंचाएंगे.
Sir, results will be announced during the lunch time.
उसी से प्रेजेंट करो. ठीक है, आपके इससे नहीं करते.
Thank you, Dr. Bhatia, for doing a wonderful job as usual. And all needs always got supervision and all our students also time to time. So please give her. And thank you all the participants, candidates, and congratulations to all have the good job. This is the only just part. And thank you all the chairpersons for chairing this wonderful session by Dr. Bhatia. Now I request to first I will announce the result. Team
Dr. Gunjan. Okay, position.
Team 2, team second.
Number 1 donation, Army and Gangara.
Full screen मत करो.
नहीं नहीं.
But two teams are going. The two teams stand with the top members, RNR and Gangana. The score is ready.
तो जो टाइप से एक टीम से वो से है. अच्छा,
So please wait.
जो टाइप टीम से सवाल पूछे तो जवाब कर दिया. हां से कर दीजिए. हां जी,
कोई नहीं सर, रहने दो. चार
एक सवाल. हां जी, टाइप टीम कौन सी है?
क्या कर रहे हो राजू सर?
फुल स्क्रीन इतना ही होगा. PDF का Adobe का रिलीज फुल स्क्रीन आ रहा होगा. ये कंट्रोल L दबाओ.
What is the most common BD, differential diagnosis of benign prostatic
ईमेल पे मंगा ना. हम मंगा रहे हैं. अरे इनकम क्या है? ये एक्सेल में है भाई. एक्सेल फुल थोड़ी होगी. नया स्विच करना है. हाँ तो एक्सेल फुल ही है. एक्सेल ऐसे ही है. यस सर.
right answer is conus.
Sorry to make you wait.
Sir, ठीक है, it's okay. No problem, no time. So thank you, Dr. Bhatia. And the results are has come. The project B and C team. B means base hospital in Gangara got 30 points. So the team won. So okay. And team D, the Jaipur Golden got the 20 marks, got the second position. And team 1, that is the LHMC, got 10 marks, so got third position. So please stay, and in meantime we will announce the prizes. So we will collect. Okay, brother. And now I request to chairpersons, please facilitate to Dr. Bhatia for a wonderful academic feast. And please.
एक शेर और तस्वीरें खिंचाना भी जरूरी है मेरे दोस्त, तस्वीरें खिंचाना भी जरूरी है मेरे दोस्त, क्योंकि आईना गुजरा हुआ वक्त नहीं दिखा।
Congratulations, Dr. Bhatia. Now I request to Dr. Rajiv Gupta. Now I request Dr. Rajiv Gupta to facilitate our chairpersons. Sir, इनका सेशन कर दोगे?
गुंजन।
So now I request to Dr. Rajiv Gupta to facilitate our chairpersons, Dr. Hemant Sharma, Dr. Manoj Arora, Dr. Manoj Arora, and Dr. Amit Sharma. Thank you, all the chairpersons, doing the wonderful job. So now we'll move for next session, that is the e-poster. And coordinator of this session is Dr. Amit Sharma. And the chairpersons, the chairpersons of this e-poster presentation, Dr. Saurabh Srivastav is not there. Okay. Then Dr. Rakesh Sood, sir, come please forward. Dr. Rajiv Gupta, मेरे बगल में खड़े हैं ऑलवेज हमारे वाइस प्रेसिडेंट्स. Dr. Lovely, senior my and my colleague, Dr. Rajiv Dewan, and Dr. Rupak Badwa. Dear Dr. Rupak Badwa, it's okay. Dr. Rajiv Gupta, Dr. Dewan, Dr. Rakesh Sood will chair this session and moderate by the Dr. Amit Sharma. E-poster, please start.
Good morning everyone. Now we are starting with our e-poster presentation. So first I would like to invite our first speaker, that is Dr. Ravi.
लगा दीजिए, वो लगा दीजिए।
तीनों लगा दो, तीनों
बैकड्रॉप लगा दीजिए, पोडियम लगा दीजिए ना, बस तीनों सारा लगा दीजिए। 10 मिनट 10 मिनट।
स्पेस से स्टार्ट हो जाएगा, स्पेस से स्टार्ट हो जाएगा।
कैसे वैसे
Your name, please. Name.
Good afternoon, sir. I am Dr. Ravi from Indian Medical College.
Yeah, please start.
Good afternoon, everyone. I am presenting a poster on blood too thick to flow, CVT, corticovascular thrombosis in a young male. So, introduction. Cortical venous thrombosis is uncommon but potentially life-threatening cause of stroke, especially in a young individual. We often under-recognizes due to its varied clinical presentation. And polycythemia, whether primary or secondary, can predispose hypercoagulable states, increasing the risk of cerebral venous thrombosis. My case report is a 27-year-old male resident of Tamil Nadu.
Just wait. Clarity नहीं है. पढ़ाई दिया clarity. हाँ. अब तो यहाँ से Yes, continue. Start from the beginning.
Okay, sir. I am presenting a poster on blood too thick to flow, cerebrovascular thrombosis in young male. Sir, introduction, cortical venous thrombosis is uncommon but potentially life-threatening cause of stroke, especially in young individuals. It is often under-recognized due to its varied clinical presentation. Polycythemia, whether primary or secondary, can predispose to hypercoagulable state, increasing the risk of cerebral venous thrombosis. And my case report is a 27-year-old male resident of Tamil Nadu presented with complaints of progressive holocranial headache, dizziness, multiple episodes of projectile vomiting for 4 days, and he had also a history of generalized pruritus after showers and redness of eyes, and he had an occasional history of smoking and alcohol consumption for 4 years. There is no history of head trauma, seizure, or recent infections like ENT infections. Family history of polycythemia is present in uncle. He is his father's brother, who currently is on therapeutic phlebotomy 2 to 3 monthly. On examination, the patient is conscious and oriented. Blood pressure is 130 by 90 millimeters of mercury, and pulse rate is 102 beats per minute. Saturation is 98% under room air. The random blood sugar is 120 milligram per deciliter. The patient had no focal neurological deficits and had grade 2 papillary edema on fundus examination, and rest of his system examination was within normal limits. And laboratory investigation showed that his hemoglobin is 19 gram per deciliter and hematocrit is 57, and the total leukocyte count is 13,800. Platelet is 4.5 lakhs and MCV is 102. And sir, PTINR is 13, and PT is 13, and INR is 1.2, and APTT is 22. pH is 7.4, POT is 98, partial presence of carbon dioxide is 42, and backup is 26 with lactate of 1.1. And sir, based on this, he is having polycythemia, and based on history, we obtained that the patient may have some headache, maybe migraine, and differentially is corticovenous thrombosis. And we have sent JAK to B617 mutation, and along with it, serum EPO levels for the patient, and we have sent the patient for necessary head, and which came to thrombosis in superior sagittal sinus and right sigmoid sinus, and we have done MRI brain with MRI venography, which revealed that the increased caliber and loss of normal flow void in posterior half of superior sinus right transverse, right sigmoid, and proximal 4.5 centimeters of right IJV suggest of urovenous thrombosis with proximal right IJV thrombosis. And these are the images showing there is loss of normal flow void in posterior half of superior sinus and right transverse sinus and right sigmoid sinus and right and proximal right IJV. And we are given treatment as the patient was started on anti-edema measures in the form of Antal and anticoagulant was given in the form of low molecular heparin according to body weight, and later shifted the patient to warfarin and planned for monitoring of anal, which is kept at 2 to 3. Anti-epileptic prophylaxis was started, adequate hydration is given, strict cessation of smoking and alcohol advised, therapeutic phlebotomy was done at setting. And discussion of my posteriors. Sir, if the patient comes to us with headache, prostractor vomiting, nuanced seizure, papilledema, oculomuscular left side, altered mental status, we have to think the patient may have a CVT, and definitive diagnosis for CVT is MRI brain and CCT head. MRI brain में direct signs are hyperintensity in T1, T2 and absence of flow void, and indirect signs are edema, venous infection and hemorrhage secondary to CVT. And CCT head plus empty delta sign may suggest superior sinus thrombosis. And for polycythemia, we have two primary polycythemia and secondary polycythemia. Primary polycythemia, major criteria is all three of the criteria or first two or plus minor criteria. And the criteria were hemoglobin greater than 16.5 gram per deciliter in male and greater than 16 gram per deciliter in female, and hematocrit greater than 49% in men and greater than 48% in female. And if the patient is having a hypercellular marrow with trilingual growth in and presence of JAK2 B617F mutation or JAK2 exon 12 mutation, and the minor criteria is abnormal EPO levels. And treatment given for primary polycythemia is therapeutic phlebotomy done, and where we keep the hematocrit in a male less than 45 and in a female less than 42. And low dose aspirin is started and hydroxyurea is given. And also in interferon alpha in young adult and pregnant women, which increase the cell counts. And if resistant to hydroxyurea, ruxolitinib, which is a JAK1 or JAK2 inhibitor, is used. In secondary polycythemia, elevated hemoglobin or hematocrit is seen, and normal bone marrow morphology will be seen, and no JAK2 mutation, elevated EPO levels, and the patient may be seeing history of smoking, or patient is a diagnosed case of COPD and may be having a sleep apnea or tumors like renal cell carcinoma and chronic hypoxic conditions. And treatment for given for secondary polycythemia is treatment underlying cause, and therapeutic phlebotomy is done for polycythemia in high risk cases keeping target hematocrit less than 45 in males and less than 42 in females. And conclusion to my topic is nuanced headache with features of raised tricycle like papillary high index of suspicion to be kept for urgent evaluation for cerebral venous thrombosis, and early neuroimaging with MRI brain and neurography should be done, which is essential and can make an accurate diagnosis of CVT. And laboratory clues like elevated hemoglobin, hematocrit, and leukocytes and thrombocytosis should be prompt evaluation for myeloproliferative neoplasms like polycythemia vera. Always consider secondary cause of hypercoagulability in patients with new onset neurological manifestations, especially in young adults. Smoking and chronic hypoxia is known for factors for polycythemia and thrombosis and should heighten suspicion in presentation. JAK2 B617 mutation testing is key diagnostic step in suspected polycythemia and should be part of workup in unexplained hyperglycemic states. Prompt anticoagulation is mainstay of treatment, treatment. This case highlights the interplay between hematologic disorders and neurological presentations, emphasizing the need for multidisciplinary approach in both hematology and
Now, if you were to give one line message through your e-poster, what that line would be?
Sir, new onset headache and patient having increased hematocrit. We have to suspect some cerebrovascular corticovenous thrombosis that we have to suspect, and we have to work up in lines of.
No, only one line. See, this is e-poster presentation should have very clear-cut masses, right? So one line presentation would be like any new onset headache. Any new onset headache with signs of raised integral tension, kindly consider CVT. This one line masses.
Projectile vomiting is a very important feature of any raised integral tension. Can you define what is projectile vomiting?
Sir, in patient terms, we have to ask whether the patient has soiled his clothes or where he is where the vomiting
Vomiting without
nausea.
Projectile vomiting is a very important part because mentioning what is projectile vomiting.
Can you show us on unography? Can you show us the classical changes that you see in unography? You put that poster. What classical changes are you seeing? Can you just pinpoint for the benefit of
Sir, there is loss of flow void. There is loss of normal flow void in right transverse and right superior sinus.
Where is the transverse sinus? This is not transverse. This is posterior part of the superior sinus. Transverse has to be transverse. Anyway, thank you.
Can you show the etiology part, etiology of symmetry to the side? Focus on that. Etiology part, this one. So cortical thrombosis is also very common in infections, integral infections. Do not rule out that diagnostic workup.
Recent sir, I have ruled out this recent infections in the form of ENT infections as otitis media and sinusitis, sinus tenderness, and meningitis.
What about pregnancy? Is it a cause? Pregnancy.
So
also important cause, very important cause of practically.
Yes, sir.
Or most common than all the real causes of death in the country. So should I mention? I think not mentioned. These two important things are missed.
You can even see CVT in children because of severe dehydration. Whenever they develop dehydration, one of the complications is CVT. Right? Thank you. Thank you very much.
Thank you.
Now I would like to invite our second speaker. This is Dr. Neeraj.
टाइम कितना है?
सेम.
Good afternoon, sir. Today I am presenting a case of 44 years old male working in a battery manufacturing unit for the last 15 years, presented to the medicine emergency with chief complaints of easy fatigability for 6 months, abdominal pain, nausea and constipation for 3 days, and tremors in hand, lethargy and slowing of speech for 1 day. There is no history of hypertension, diabetes mellitus or thyroid disorder. There is no history of smoking or alcohol consumption. On physical examination, the patient's vitals were BP was 122 by 82 mm mercury, pulse rate was 94 per minute, room air saturation was 99% on room air, and RBS was 180 mg per deciliter. Patient was conscious oriented, but on general examination, pallor was present and fine tremors were present in the hands, and rest of the systemic examination were within normal limits. On laboratory investigations, hemoglobin was found to be 6.6 gram per deciliter, MCV was 78.2 femtoliter, and peripheral blood smear showed normocytic normochromic to microcytic hypochromic RBCs.
Iron study shows normal iron profile with serum ferritin of 81.6 nanogram per ml. Serum sodium was low with a value of 130 milligauge per liter, and serum osmolarity was 242 milliosmol per kg, which was also on lower side. And urinary sodium was 81 milligauge per liter, and urine osmolarity was more than 100 milliosmol per kg. Liver function test, renal function test, and thyroid function test were within normal limits. Given the occupational history of the patient and symptoms of tremors, abdominal pain, and easy fatigability, and also the anemia, we did blood lead levels, which came out to be 103.6 microgram per deciliter, which was significantly raised. Chest X-ray, USG whole abdomen were grossly normal. NCCT had revealed few chronic lacunar infarcts in bilateral gangliocapsular region, and fundus examination was within normal limit. And during the hospital course, we did a diagnosis of lead toxicity along with SIDH given the euvolumic status of the patient. Patient was given correction for hyponatremia and chelation was done for lead toxicity. Patient was chelated with British antiloicide for 3 days and calcium disodium ETA for 5 days. Patient's hyponatremia improved over the course of treatment, and symptoms such as pain abdomen, tremors, lethargy, and slowing of speech also improved gradually. Lead poisoning is a well-recognized occupational hazard, especially in the manufacturing of batteries, paints, ammunition, and construction material. Lead is toxic to hematopoietic, gastrointestinal, renal, cardiovascular, and reproductive system. SIDH, though rare, but can be a manifestation of lead poisoning. Occupational history was a key in the diagnosis of this case. So, through this presentation, I want to highlight that lead toxicity should be considered in patients with vague neuralgia symptoms, especially in those with relevant occupational exposure. And early recognition and prompt chelation can reverse symptoms and prevent long-term complications. Thank you.
Thank you for a very short presentation. Thank you very much. Now, this is a case of lead poisoning induced neurological symptom with the SID.
Yes.
Where else can you look for the clues for lead toxicity? Where else?
Sir, in general examination, sir, we can see the gums. So
What do you see in gums?
So Bartonian's line.
Yes. Blue line there. Any other in the routine examination, lab examination?
Sir, peripheral blood smear may show basophilic stippling of arteries. But here in our case, it was not found.
What is the classical clinical presentation of lead poisoning? Classic.
Sir, abdominal pain, and tremors can be there.
And neurologically, what is classical? You got a drop, you got a wrist drop or a foot drop. They are the most common neurological presentation.
So nerve conduction studies, NCP.
Anything from the audience like to ask? We have some time. Anyone from the audience can ask? No? Okay then. Thank you.
Thank you.
इसका ना बहुत झंझट
Thank you, Dr. Amit, for moderating this wonderful session, and thank you, chairpersons, for moderating the wonderful list. Now I request to our chairpersons to felicitate our moderator, Professor Amit Sharma.
बताया था ना आपको मैंने 1 2 3 4 हाँ करेक्ट 2 3 एंड अगेन हाँ करेक्ट ठीक है यहाँ से शुरू करना
हाँ ये शुरू होनी है आपको उस कंट्रोल होगा
कॉलर माइक दे दो
लगा दो
आपके माइक अप करो ठीक
है चलाना दोस्त माइक ऑन कितना लेट कौन सा चल रहा है कौन चल रहा
पता नहीं किसका नाम है
डॉक्टर को सरफेस बताना करेक्ट हो जाएगी
And now I invite to Dr. Bandra to felicitate our chairpersons. Dr. Bandra. बॉस को भी दिलवाना है।
मतलब जो 12 वाले लेक्चर था कितने बजे? 1 बजे।
मैं बता देता हूँ
I invite Dr. Bandra to felicitate Dr. Rakesh Sood.
अरे आदिल कौन सा चल रहा है अभी? अरे बंद मत कीजिए क्यों आप आइए इधर अच्छा खोल के रखा है क्या
Dr. Aditya.
कौन सा सीक्वेंस बता रहा
And now I request to ask by to facilitate each other.
लैपटॉप कनेक्ट हो जाएगा माइक्रोसॉफ्ट सर्फेस
मैकबुक है
नहीं सर्फेस बुक है माइक्रोसॉफ्ट
So we'll now move for next session.
HDMI है
नहीं हमारे पास नहीं है आप
नहीं HDMI उसमें है क्या
पता नहीं
And thank you for and congratulations to all the candidates for each poster presentation. And prize will be announced post lunch. Okay, so please wait for prize of the
1 2 से 8 दे रखा होगा यार अरे मुझे नहीं दिया है कहाँ गया बैग में डाल अरे हाँ चेयर में भारी हो रहा बैग में डाल ऊपर रख दो
उनके पास है कनेक्टर है उन बेस्ट नहीं होगा
So winner of the e-poster is the first winner is Dr. Neeraj. He got 19 out of the 25.
कॉल भी यही है ना
Very tight competition. Second winner is Dr. Ravi, 18 out of 25. So
इनकी जगह पे ना प्रोफाइल
collect
करनी पड़ेगी
check after the lunch. Congratulations to all of both of you. Thank you.
दूसरे डॉक्टर आ रहे हैं
So now
इनकी जगह पे
we'll move on. Next session is very important for all the aspects, saving as well as the doctor's perspective. Not so to all the doctors, not engage with the property dealer, but contact to Dr. Vimal for next perspective of जो भी सेविंग करनी बचत करनी है हमको I want to invite for the financial planning for doctors, especially young graduates. I want to invite Dr. Manoj Bimal, Senior Consultant and Physician and Director at the My Care. And the chairpersons for this session, the Dr. Yogesh Chhabra, Dr. Navi Mishal, and Dr. Sushil Jain. Dr. Sushil Jain, please. So now, mic to the chairpersons, please.
Thank you, sir.
लगा दूं
PPT, please.
This is one of the important things which we need to learn as a doctor because we are actually not doing anything good regarding our financial planning. And this is something a most important part which we should learn. As a doctor, we are just focusing on our medical practices, but we are not focusing on our future. How to actually go ahead with a good financial planning and to move ahead in a secure way. Dr. Manoj,
Thank you, sir, for the kind introduction. And good morning, first. Good morning. Good morning. Good morning. Are you all with me?
किस किस को पैसा चाहिए? प्लीज रेज योर हैंड्स। किस किस को पैसा चाहिए? किस किस को पैसा चाहिए? किस किस को नहीं चाहिए? थैंक यू डॉक्टर भाटिया फॉर करेक्टिंग मी। किस किस को पैसा नहीं चाहिए? हाथ थोड़ा कर दो। किस सबको चाहिए? वेल, सब कुछ पैसे में चलता है आज की तारीख में। We all know. हम यहाँ बैठे हुए हैं पैसे के लिए, ये कॉन्फ्रेंस हो रहा है पैसे के लिए, we are doing our practice पैसे के लिए. We all doctors are working day and night for earning money, but unfortunately we are not managing our money efficiently. That is a reason over a period of time हमारे पास उतना कॉर्पस या उतना वेल्थ क्रिएट नहीं हो पाता है जितना हमारे कोलीग्स जो अदर प्रोफेशंस में वो बना पाते हैं. So this topic, financial planning for doctors, is close to my heart. So I would spend few minutes to sensitize you towards this topic. And the tagline is adding years to life and life to years. कई बार आपने ना पिक्चर देखा होगा शिल्पा शेट्टी का 52 years और साथ में एक और 52 years. पैसा शक्ल सूरत बदल देता है, सब कुछ बदल देता है, right? So money adds years to life, years to your life. एक टाइम्स ऑफ इंडिया का आर्टिकल था, rich people live a decade more than the poor people. तो पैसा होना बहुत जरूरी है. पैसा years जोड़ता है और उन years में quality जोड़ता है. So with this note, Michael is working this topic. This is very close to my heart. Financial planning for doctors. So now moving ahead, I would like to invite one of my colleague, Mr. Rajit, to take you to this journey few minutes. Over to Mr. Rajit.
Thank you, Dr. Vimal, and thank you to all the So जैसे डॉक्टर साहब ने कहा कि जैसे डॉक्टर it is so important to manage health, क्योंकि that's what the purpose of life. But simultaneously to manage health, if we have good wealth, technically this is the best combination of the life. So with that question of Dr. Vimal, how we can manage health and wealth together, and that ultimately give us the prosperity of life, right? So we as an institution into wealth management for last 14 years. इन 14-15 सालों में हम ना केवल इंडिविजुअल्स का इंस्टीट्यूशन का भी वेल्थ मैनेज करते हैं. और जब हम लोग वेल्थ मैनेजमेंट की बात करते हैं तो वेल्थ मैनेजमेंट इज ए कॉन्सेप्ट कॉल्ड ERGRE. तो ERGRE इज ए वर्ल्ड वाइड यूज कॉन्सेप्ट. तो E स्टैंड फॉर इमरजेंसी प्लानिंग. तो जनरली हम लोग अपनी लाइफ में क्या करते हैं, वी डू प्लानिंग फॉर आवर इमरजेंसी एक्सपेंसेस. जो हम लोग अपने घर का 5-6 महीने का खर्चा होता है उसको हम इमरजेंसी कॉर्पस की तरह रखना चाहते हैं. हम लोग अपनी लाइफ में रिस्क को मिटिगेट करना चाहते हैं. तो वी डू हेल्थ इंश्योरेंस, वी डू टर्म प्लान, वी डू कार इंश्योरेंस, वी डू होम इंश्योरेंस, क्योंकि हम अपने एसेट्स को प्रोटेक्ट करना चाहते हैं. व्हेन वी टॉक अबाउट जी, तो हम लोग काफी कुछ एम्फसाइज करेंगे जी यानी कि गोल प्लानिंग पे. जब हम लोग गोल प्लानिंग की बात करते हैं तो उसको हम 3 पार्ट में डिवाइड करते हैं, जैसे शॉर्ट टर्म, मीडियम टर्म और लॉन्ग टर्म. यानी कि वो पैसा जो विदिन 3 इयर्स मुझे रिक्वायर्ड है, that money that is required for 5 and 6 years, and the money that is required for generation. So as a wealth manager, there are lots of asset options जहाँ पे मैं अपनी वेल्थ को मैनेज कर सकता हूँ. तो वेल्थ को मैनेज करने में 2 कॉन्सेप्ट को यूज किया जाता है, वेल्थ प्रोटेक्शन एंड वेल्थ क्रिएशन. वेल्थ प्रोटेक्शन की जब मैं बात करता हूँ तो मेरी कोशिश होती है कि जो असेट्स मैंने बनाए हैं, जो वेल्थ मेरे पास है, उसको प्रोटेक्ट करने की कोशिश कर रहा हूँ, उसको इन्फ्लेशन बीटिंग लेवल के आसपास में जनरेट करने की कोशिश कर रहा हूँ. और जनरली वेल्थ प्रोटेक्शन शॉर्ट टर्म के लिए किया जाता है, लेकिन जब मैं वेल्थ क्रिएशन की बात कर रहा हूँ तो ये एक लॉन्ग टर्म फिनोमेना है. यानी कि जहाँ मैं अपने पैसे की परचेसिंग पावर को मल्टीफोल्ड करने की कोशिश कर रहा हूँ ताकि वो सर्विसेज, गुड्स और असेट्स जो फ्यूचर में मुझे चाहिए उनकी कैपेसिटी में आज जनरेट कर पाऊँ. और दुनिया में एक ही लड़ाई है, पूरी दुनिया एक ही लड़ाई के लिए लड़ रही है, who will become the most powerful, and the powers come from money itself, right? So there are certain options into wealth management जो हमें लगता है कि apart from normal products, शायद बैंक FD होगी, पोस्ट ऑफिस हो गए, सेविंग अकाउंट्स हो गए, म्यूचुअल फंड्स हो गए, ये सब हम लोग बहुत कॉमनली करते होंगे. But how do millionaires do investments? आज हम वो समझते हैं कि जो बड़ी फैमिली जैसे हम लोग वी डू मैनेज मनी फॉर द धोनी फैमिली ऑफिस, वी डू मैनेज मनी फॉर रितेश अग्रवाल, वी डू मैनेज मनी फॉर द बर्मन फैमिलीज, एंड देयर आर लॉट मोर इंस्टीट्यूशन जिनके लिए हम लोग पैसा मैनेज करते हैं। एंड दे बिलीव कि वेल्थ मैनेजमेंट एक बहुत टेलर मेड एंड पर्सनलाइज सब्जेक्ट है, ये कभी भी ओपन फोरम में या एक थीसिस के बेसिस पे सिर्फ एक्सेप्ट नहीं किया जा सकता। इट इज वेरी सेंसिटाइव और इट इज वेरी पर्सनल। सो आई विल जस्ट गो थ्रू, क्योंकि टाइम हमारे पास लिमिटेड है तो बहुत कुछ जानकर हम यूज नहीं करेंगे। आई विल जस्ट गिव यू द इंट्रोडक्शन ऑफ फ्यू प्रोडक्ट जो एज ए वेल्थ मैनेजर हम लोग मिलेनियर्स के लिए क्या करते हैं, एंड ऑल दिस प्रोडक्ट जो मिलेनियर्स अपनी वेल्थ को एक्यूमुलेट करने के लिए, मल्टीप्लाई करने के लिए करते हैं, वो मैं रिटेल सेटअप में भी यूटिलाइज कर सकता हूं विद द फॉर्म ऑफ माय वेल्थ, राइट। सो मार्केट अपडेट को मैं स्किप कर रहा हूं, राइट, क्योंकि थोड़ा लंबा हो जाएगा। सो आई जस्ट गिव यू सम ऑप्शन। तो जब हम लोग वेल्थ मैनेजमेंट की बात करते हैं तो जनरली 3 एसेट क्लास हमारे जहन में आती हैं। वन इज डेट एसेट क्लास, यानी कि फिक्स इनकम की बात कर रहा हूं, जिसमें बॉन्ड्स आते हैं, एफडीज आती हैं, डेट म्यूचुअल फंड्स आते हैं, तमाम तरह के फिक्स इनकम इंस्ट्रूमेंट आ जाते हैं। तो जनरली हम डेट के बारे में सोचते हैं तो हमें लगता है कि 7-8% के रिटर्न की कुछ बात चल रही है, राइट। और ये 7-8% का रिटर्न भी बड़ा लॉजिकल है, क्योंकि आप में से बहुत सारे लोग मैं यहाँ देख रहा हूँ ऐसे भी होंगे जो 1994, 96 में भी इन्वेस्टमेंट करते होंगे, और उस समय बैंक एफडीओ के रेट भी 12% होते थे, उस समय पीपीएफ के रेट ऑफ इंटरेस्ट भी 12% होते थे, आज 7.1 है। तो हमें समझना पड़ेगा नथिंग इज गारंटीड इन लाइफ, राइट। क्यों? क्योंकि जैसे जैसे आप बढ़ते हैं आपकी इकोनॉमिकल कंडीशन चेंज होती है, आपके रेट ऑफ इंटरेस्ट भी चेंज हो जाते हैं। तो इंडिया में हमें लगता है 6-6.5% की एफडी कम हो गई है, लेकिन मैं बताऊं कि दुनिया में देयर आर सर्टेन कंट्रीज जहां पे बैंक में पैसा रखने का आपको एक फी पे करना पड़ता है। तो जापान में पिछले 50 सालों से कोई इंटरेस्ट रेट नहीं है, वैसे नेगेटिव रेट ऑफ इंटरेस्ट। यूएस in last 20 years is having 2.5 to 3% kind of interest rate। क्यों? क्योंकि इन्फ्लेशन वैसा ही है, और हिंदुस्तान जब डेवलप्ड नेशन की तरफ जा रहा है तो रेट ऑफ इंटरेस्ट भी थोड़े आपको कम देखेंगे। बट क्या 7-8% के ही फिक्स इनकम ऑप्शंस होते हैं? आंसर इज नो। जो मिलियनेयर्स है वो कहते हैं कि नहीं, विद इन फिक्स इनकम, विद इन गारंटेड स्पेस, दे आर द ऑप्शन जहां मैं 12 से 14-18% के भी फिक्स रेगुलर कैश फ्लो जैसे इंस्ट्रूमेंट ले सकता हूं, एंड दोज आर सेबी रेगुलेटेड, राइट। जिसमें से एक ऑप्शन है अल्टरनेट डेट एआईएफ। हाउ मेनी ऑफ यू आर अवेयर ऑफ डेट एआईएफ? सो ये अल्टरनेट इन्वेस्टमेंट कैटेगरी है। 2014 में सेबी ने इसको एक्सेप्ट किया था और रेगुलेशन दिया था। इसका ऑब्जेक्टिव था कि अगर मैं थोड़ा इवॉल्व इन्वेस्टर हूं और थोड़ा सा फाइनेंशियलाइजेशन को समझना चाहता हूं, तो क्या मैं विद इन फिक्स इनकम या एक फिक्स इंस्ट्रूमेंट में भी इक्विटी बेटिंग रिटर्न्स ले सकता हूं या इन्फ्लेशन एडजस्टेड बेहतर रिटर्न ले सकता हूं विद रेगुलर कैश फ्लो? आंसर इज यस। सो जैसे उसी तरह का एक प्रोडक्ट मैं आज डिस्कस कर रहा हूं जो डेट कैटेगरी का प्रोडक्ट है। ऑल्दो जब मैं एआईएफ की बात कर रहा हूं तो टिकट साइज 1 CR हो जाता है, राइट, लेकिन ये 1 गो में नहीं होता है। आप ट्रंचेस में इस इन्वेस्टमेंट को कर सकते हैं, यानी कि 15 लाख के मल्टीपल ट्रंचेस में आपको पेमेंट करना होता है। बट द ब्यूटी इज it will give you 4.5% quarterly interest for next 5 years, यानी कि 5 साल तक अगर मुझे 4.5% क्वार्टरली ब्याज चाहिए, यस आई एम राइट, मैं 18% एनुअलाइज रिटर्न की बात कर रहा हूँ। इट्स इंटरेस्ट इनकम। तो ये प्रोडक्ट मुझे डे 1 से इंटरेस्ट इनकम देता है, ट्रंचेस में मुझसे पैसा लेता है, और ये सेबी ऑथराइज एंटिटी है जो मुझे अलाउ करती है कि मैं आपसे ये ओपन फोरम में डिस्कस कर पाऊं और आपको ये बता पाऊं। तो इफ समबडी इज हैविंग ए कॉर्पस ऑफ 1 CR टू डिप्लॉय नेक्स्ट 1 or 2 years, और उनको एक रेगुलर कैश फ्लो चाहिए जिसमें वो मार्केट की वॉलेटिलिटी, इंडिया, पाक और रशिया और यूक्रेन के वॉर में नहीं पड़ना चाहते, इंडिया के डेमोग्राफिक्स में नहीं जाना चाहते, तो उनके लिए इस तरह के ऑप्शंस भी अवेलेबल हैं जो वो एक रेगुलर 4.5% के क्वार्टरली कैश फ्लो से जनरेट कर सकते हैं। तो अल्टीमेटली होता है क्या है? सिंपल ब्याज का बिजनेस होता है। इंस्टीट्यूशन चलाए बिजनेसेस को पैसा देते हैं, रेगुलर कैश फ्लो के फॉर्मेट में देते हैं। ये हाई कोलेटरल पैसा होता है जिसमें कैपिटल आपकी 100% प्रोटेक्टेड होती है। रीजन भी कि जो भी पैसा आप देते हो इंस्टीट्यूशन को, उनका कोलेटरल 4x to 5x या तो लैंड, प्लांट, मशीनरी और उनके कैश फ्लोज को प्लेस किया जाता है और उसके अगेंस्ट ही पैसा दिया जाता है और लगभग 20 से 25 बिजनेसेस में इसको डिवाइड किया जाता है। तो दिस इज वन इंस्ट्रूमेंट, उसी का ये डिटेल दिया हुआ है। सो इफ आई जस्ट लेट यू नो कि ये प्रोडक्ट बताता है कि 6.5 साल के टेन्योर का प्रोडक्ट है। 5,000 करोड़ जनरली एक इससे रेस करते हैं। 5 से 6 ड्रॉ डाउन ऑप्शन में पैसा लेंगे आपसे 15-20 लाख के मार्जिन में और टारगेटेड 4.5% क्वार्टरली आपको इंटरेस्ट देते हैं। एट द एंड ऑफ टेन्योर आपका प्रिंसिपल आपको वापस आ जाता है। एंड दिस इज द एंटायर हिस्ट्री। चूंकि ये डेट इनकम होती है, इंटरेस्ट इनकम होती है, तो जिस भी टैक्स स्लैब में आप आ रहे होते हैं उसके अकॉर्डिंगली आपको ये आपके इनकम में ऐड हो जाता है। यू हैव टू पे टैक्सेस ऑन दैट। इसी तरह का एक दूसरा और डेट का प्रोडक्ट है जो कहता है कि केवल हम गवर्नमेंट इंस्टीट्यूशंस को पैसा देते हैं लाइक एनएचआई और एनटीपीसी। तो एक छोटा सा एग्जांपल देता हूं विद इन 2 मिनट्स। तो जैसे एनएचआई प्रोजेक्ट बनाता है, एक कंपनी होती है जो टेंडर लेती है, कंपनी टेंडर लेती है, प्रोजेक्ट बनाती है और गवर्नमेंट को हैंड ओवर कर देती है। गवर्नमेंट उसको 40% पेमेंट करते हैं और 60% उसकी एन्युटी बांध देते हैं फॉर लास्ट 10 और 12 इयर्स। अभी ठेकेदार साहब का कोई इंटरेस्ट नहीं है 12 साल उससे एन्युटी कमाने का, तो वो क्या करते हैं, प्रोजेक्ट को सेल कर देते हैं और वहां से गवर्नमेंट से एनएचआई या एनटीपीसी से रेंटल यील्ड आती है 9 से 12%। वो यील्ड जैसे ऑप्शन में भी आप डाल सकते हो जहां से आपको 12 से 14% की एन्युटी इनकम फॉर नेक्स्ट 5 to 6 ईयर आती रहती है। इस तरह के एवेन्यूज भी अवेलेबल है। हाउ मेनी ऑफ यू आर अवेयर अबाउट पीएमएस? हैव यू एवर इन्वेस्टेड और हर्ड अबाउट पीएमएस, पोर्टफोलियो मैनेजमेंट सर्विसेज?
PMS, anybody? Very few.
सुना है। तो सर पीएमएस इज नथिंग, इक्विटी एसेट क्लास पे इन्वेस्टमेंट करने का एक थोड़ा मॉडिफाइड व्हीकल है, एक थोड़ा प्यूरेस्ट फॉर्म ऑफ इन्वेस्टमेंट है, जिसमें सेबी कहती है कि नहीं थोड़े से इवॉल्व, थोड़े से एलीट इन्वेस्टर के लिए प्रोडक्ट बना है। वो इन्वेस्टर जो 3 से 5 साल के इन्वेस्टमेंट जर्नी में जा सकते हैं, जो इक्विटी एज ए एसेट क्लास समझते हैं और जो इंडेक्स और इन्फ्लेशन से एक बेहतर एडजस्टेड रिटर्न चाहते हैं, तो उनके लिए पीएमएस जैसे इन्वेस्टमेंट हो सकते हैं। पीएमएस मिनिमम टिकट साइज पहले 5 लाख होता था, फिर सेबी ने 25 लाख किया। अभी मिनिमम टिकट साइज 50 लाख 50 लाख रुपए का एक वन शॉट इन्वेस्टमेंट होता है। बट द ब्यूटी इज मैंने कुछ 3 पीएमएस आइडेंटिफाई करके यहाँ दिए हैं और उनका ऑलमोस्ट 5 से 10 सालों का इन्वेस्टमेंट का कैगर रिटर्न मैंने आपको दिया है। सीएजीआर, ईयर ऑन ईयर वो रिटर्न्स क्या जनरेट किए हैं। तो अगर मैं पॉइंट की एक बात करता हूँ, देन दिस इज अ स्ट्रेटजी इनटू फ्लेक्सी कैप, जो एक मल्टी कैप स्ट्रेटजी है जिसने लगभग पिछले 5 सालों में 40% का कैगर रिटर्न बना के दिया है। तो अगर आप देखें कि ये अपनी कैटेगरी में किसी म्यूचुअल फंड या इंडेक्स को अराउंड 12 to 13% ईयर ऑन ईयर बीट करके दे रहा है, राइट? तो वो क्या कर रहा है, वो थोड़े सुपीरियर रिटर्न आपको रिस्क एडजस्टेड जनरेट करने की कोशिश कर रहा है। तो अगर मेरे पास 3 से 5 साल का टाइम फ्रेम है तो पीएमएस जैसी स्ट्रेटजी हम लोग आइडेंटिफाई कर सकते हैं। तो दे आर मोर देन 250 पीएमएस ऑप्शन इन द कंट्री। उसमें से कुछ 20-25 बुटीक आइडिया जिस पे हम लोग ड्यू डिलिजेंस करते हैं, रिसर्च करते हैं, एनालिटिक्स करते हैं और उसको आप तक पहुंचाते हैं बेस्ड ऑन योर नीड एंड रिक्वायरमेंट। ये उसी का डिटेल लिटरेचर है। तो मैं आपको जो बता रहा था कि पिछले 5 सालों में उसने बेंचमार्क में अगर 25% रिटर्न दिया इंडिया के इंडेक्स ने, तो दिस फंड हैज डिलीवर ऑलमोस्ट 40% रिटर्न, यानी कि 15% साल दर साल ज्यादा रिटर्न देने की कोशिश इस फंड ने किया है। तो इससे मल्टी बैगर आइडिया, और अगर आप देखेंगे तो लगभग 40% लार्ज कैप में रखता है, 23% स्मॉल कैप में और लगभग 15 से 16% कैश है। अभी होल्डिंग कहीं डिप्लॉय ही नहीं की है। वैसे दूसरा ऑप्शन है कर्मा, मैं उसको डिस्कस नहीं कर रहा हूँ। थर्ड ऑप्शन है वर्मा, जो एक स्मॉल कैप है, दैट हैज डिलीवर ऑलमोस्ट 33 to 34% कैगर रिटर्न, जिसने बेंचमार्क को अगेन 10 से 12% से बीट किया है। देन अगर आप थोड़े से और इवॉल्व इन्वेस्टर हो और एक आप मल्टी बैगर या एक मल्टी मिलियनियर आइडिया देख रहे हैं और आपको लगता है कि इंडिया में जो काम पिछले 75 या 76 सालों में हुआ है, 76 ईयर में जो इंडिया का जीडीपी है वो $3 ट्रिलियन बना। पहला $1 ट्रिलियन बनने में हिंदुस्तान को 68 साल लग गए और अब हर 5 साल में हिंदुस्तान $1 ट्रिलियन की इकोनॉमी पास करता है। दैट मींस कि जितना पैसा हमारी जनरेशन में पिछले 78 ईयर्स में बनाया, उतना पैसा हिंदुस्तान हर 14 साल में बनाता है। एंड दिस इज द ग्रोथ ऑफ इंडिया, और चाहे वो फार्मा हो, चाहे वो आईटी हो, चाहे वो कंस्ट्रक्शन हो, चाहे वो अदर आइडियाज हो। क्यों? क्योंकि इंडिया का डेमोग्राफिक ऐसा है, आपकी मीन एज ऑफ द पॉपुलेशन मीडियन इज अराउंड 28 इयर्स। तो ये 28 साल का जो आदमी है कमाता है और खर्च करता है, एंड दैट्स हाउ द इंडिया इज ग्रोइंग इन दैट मैनर। तो कुछ ऐसे भी एआईएफ ऑप्शंस होते हैं जो कुछ ऐसी कंपनियां हैं तमाम जो फार्मा में भी होंगी, आईटी में भी होंगी, अदर इंस्टीट्यूट में भी होंगी, जिनकी आईपीओ लिस्टिंग नहीं हुई है, यानी कि बाजार में भी लिस्ट नहीं हुई है, बट दे आर मेकिंग ह्यूमंगस प्रॉफिट्स एंड गेन्स, उन कंपनियों को आईपीओ से पहले भी आप अपने पोर्टफोलियो में बाय कर सकते हैं विद द हेल्प ऑफ दीज कैट टू प्री आईपीओ एआईएफ, राइट। उसमें से एक एआईएफ केवल मैं डिस्कस कर रहा हूं, भारत वैल्यू फंड। ये ग्रुप है पेंटामॉथ, और पेंटामॉथ वो ग्रुप है जिसने हिंदुस्तान में पिछले 15 सालों में लगभग 200 कंपनियों के आईपीओ को लिस्ट कराया होगा। ये कंपनी क्या करती है, ऐसी कंपनियों को, ऐसे बिजनेसेस को आइडेंटिफाई करती है जो अगले 2 से 3 साल में लिस्ट होने जाएंगे, जिसमें वैल्यू अनलॉक होगा और उसका जो रियल जूस है वो आईपीओ से पहले इन्वेस्ट करके दे कैन गिव टू द क्लाइंट। तो ऐसा इन्वेस्टर जो अगले 5 साल के लिए इन्वेस्टमेंट करना चाहते हैं और एक 3x to 4x स्ट्रेटेजी देख रहे हैं जहां वो मल्टी मिलियनियर आइडिया ले सकते हैं, क्योंकि वी कांट स्टार्ट अ कंपनी एज इमीडिएटली, बट मैं किसी कंपनी में अपनी पार्टनरशिप या एक्विजिशन ले सकता हूं एज ए इन्वेस्टर। तो ये ऑप्शन के थ्रू भी आप इन्वेस्टमेंट कर सकते हैं। इसमें भी मिनिमम टिकट साइज 1 CR होता है, लेकिन ये अगले 2 साल में स्टैगर्ड वे में आपसे पैसा लेते हैं, अभी 25% लेते हैं। इसका जो पहला फंड आया था दैट केम इन 2021, द करंट वैल्यू दैट फंड हैज क्रिएटेड इज 4x ऑफ 1 करोड़, यानी कि 4 करोड़ की वैल्यू आज लगभग 4.5 करोड़ रुपया है। दिस इज व्हाट द आइडिया। 12 से 14 ऐसी प्री आईपीओ कंपनीज में पैसा डालते हैं, जिसमें से कुछ कंपनीज के मैं नाम लेता हूं। वारी एनर्जीज इज वन ऑफ देम, एसडीवी इज वन ऑफ देम, टीसीएस इज वन ऑफ देम, जिसमें इन्होंने प्री आईपीओ यानी कि 490 रुपए पे वारी एनर्जीज खरीदा, 1600 रुपए पे आईपीओ आया, 2500 रुपए पे लिस्टिंग हुई, 3500 का स्टॉक है और ये जर्नी केवल 2.5 साल में हुआ। देयर नंबर ऑफ ऐसी कंपनीज जो शायद आपको समय से पहले यहाँ दे पाते हैं, कि ये उसी का एक डिटेल है। इसके अलावा आप, अगर आपको लगता है कि नहीं आप एक बड़ा अमाउंट नहीं और एक छोटे अमाउंट से कुछ अनलिस्टेड कंपनीज, ऐसी कंपनी जैसे एसबीआई म्यूचुअल फंड, एनएससी नेशनल स्टॉक एक्सचेंज जो दुनिया का सबसे बड़ा स्टॉक एक्सचेंज है, वो भी आज लिस्टेड नहीं है, उनको आप समय से पहले भी 1,50,000 और 2 लाख के वैल्यूएशन में खरीद सकते हैं और शायद एक बेहतर पोर्टफोलियो या रिस्क एडजस्टेड रिटर्न बना सकते हैं। सो दिस इज हाउ वी एज सेक्टरसिटी एंड माईवेल हम इस तरह से एक पोर्टफोलियो डिप्लॉय करते हैं, जहां पे बेस्ड ऑन योर नीड एंड रिक्वायरमेंट, शॉर्ट टर्म, मीडियम टर्म, लॉन्ग टर्म, आपका एक पोर्टफोलियो डिजाइन करते हैं, एक डिप्लॉयमेंट प्लान बनाते हैं, आपसे डिस्कशन होता है, क्योंकि इन्वेस्टमेंट इज ऑलवेज ए पर्सनलाइज्ड टेलर मेड सॉल्यूशन। ये कभी ओपन फोरम में ये सबके लिए यूनिक स्पेसिफिक नहीं हो सकता है। सो दैट्स हाउ वी आर अवेलेबल एट योर डोर स्टेप। स्टॉल भी अपना लगा हुआ है और डॉक्टर साहब इज अवेलेबल, ही इज कंटिन्यूअसली मैनेजिंग मोर देन 2000 फैमिलीज आई थिंक लास्ट 15 ईयर। सो अगर आपको लगता है कि इस तरह के टेलर मेड पोर्टफोलियो सॉल्यूशन की आपको आवश्यकता है, तो आई थिंक माय केयर इज द बेस्ट पार्टनर अवेलेबल विद यू। सो विद दिस शॉर्टेज ऑफ टाइम आई वुड लाइक टू वाइंड अप द सेशन। थैंक यू। ओवर टू।
Thank you, Richard. Thank you so much for this beautiful presentation.
Again.
मत के है इनका वापस लगाइए।
आपका बहुत बड़ा सीधा।
नहीं मैं करूँ।
कैसा लगा? कैसा लगा? आप सुन पा रहे हैं मुझे? Am I audible?
नहीं यही चलेगा, चेंज होगा इसमें।
नहीं चलेगा।
This is a list of products जिसमें हम लोग करते हैं, and let me quickly tell you what is the solution. अभी रचित ने presentation दी हमारी टीम की तरफ से. Let me make you very sure that we have the most competent team in our country. You name the financial product, we have it, and we customize for you. मैं आपको quickly process बताता हूँ कैसे हम करते हैं. First point is हम आपका एनालिसिस करते हैं, कितना खर्चा है, कितनी इनकम है, क्या लायबिलिटीज हैं, क्या लोन चल रहे हैं। दिस इज एनालिसिस इंक्लूडिंग योर रिस्क असेसमेंट। जैसे मैं 100 रुपए पे रिस्क ले सकता हूँ, डॉक्टर साहब शायद 30 रुपए पे रिस्क ले सकते हैं, डॉक्टर दीवान शायद 40 रुपए पे रिस्क ले सकते हैं। दैट इज रिस्क असेसमेंट। ये करने के बाद देन वी वर्क ऑन फाइनेंशियल गोल्स। हम डॉक्टर्स के गोल्स क्या होते हैं? क्या गोल्स होते हैं सर हम डॉक्टर्स के? दाल-रोटी मिल जाए, क्लिनिक बन जाए, हॉस्पिटल बन जाए, अपना सेटअप बन जाए, शादी हो जाए, अपनी और बच्चों की भी सर। So we actually work on these realistic goals. जैसे हम पीजी करके निकलते हैं, तो तो यूजुअली 5 से 10 साल के अंदर अपना सेटअप बन जाना चाहिए अगर प्रॉपर प्लानिंग है, राइट? अदरवाइज वो बहुत लंबा टाइम लगता है. थर्ड, चूजिंग द राइट फाइनेंशियल प्रोडक्ट फॉर यू. जैसे अभी ये लिस्ट मैंने आपको दिखाई, दिस इज अ लॉन्ग लिस्ट ऑफ प्रोडक्ट्स, जिसमें से नीचे आप देखेंगे 13 नंबर पे AIF, PMS, अनलिस्टेड, ये सब डिस्कस किया मेरी टीम ने आपके साथ. वी शॉर्टलिस्ट द बेस्ट प्रोडक्ट फॉर यू. चूजिंग राइट फाइनेंशियल प्रोडक्ट फॉर यू. आपको म्यूचुअल फंड चाहिए, PMS चाहिए, AIF चाहिए, डेट चाहिए. सो आपके लिए जो बेस्ट प्रोडक्ट है हम आपको गोल के अकॉर्डिंग आपके लिए चूज करेंगे. एंड थर्ड इज फुल एग्जीक्यूशन सपोर्ट. कहीं जाना नहीं है उसके लिए, चाहे वो किसी भी कंपनी से बिलोंग करता है, वी हैव दैट सॉल्यूशन विद अस. वी गिव यू द 100% एग्जीक्यूशन सपोर्ट, और वो सारा ऑनलाइन प्रोसेस है. आज की तारीख में पेपर खत्म हो चुका है. एंड जस्ट 1 मिनट, full monitoring support. ये नहीं कि करके भूल गए. You will get the personalized application and web access. पूरा उसका आप मॉनिटर कर सकते हैं. And regular periodic review. This is very very important. आज हमने अपना बना लिया है, सब कुछ कर लिया है, गोल्स बना दिए, इन्वेस्टमेंट्स कर दिए. And we have an exercise कि उसको साल में एक बार डिटेल्ड पोर्टफोलियो रिव्यू करते हैं, क्योंकि टाइम डायनेमिक है, चीजें बदलती हैं. मे भी शायद अगले साल आपके कोई बेटर ऑप्शन हमारे पास आ गया है, या आपके एग्जिस्टिंग ऑप्शंस थे उसमें और बेहतर कुछ आ गया है. तो we have that practice, full periodic review of your portfolio. And the last is the education जिसकी बहुत कमी है हमारे पास. Basic education. This was just a initiative to sensitize you. हम educate भी करते हैं. We have meetings, videos and interactions on Zoom and Google Meet. So this is the solution for you. ICARE is providing this solution to you. So thank you all for listening. Any questions so far?
Thank you, Dr. Bimal, for nice advice to all the doctors. Nice investment planning and the अपनी फीस तो बता देते हैं सो भाई हाउ टू कैसे करना है, ठीक है, फाइनलाइज कैसे करना है, क्या फीस है आपका, ये सब भी तो आपका कहाँ कांटेक्ट करना, वेयर टू कांटेक्ट यू, कहाँ कांटेक्ट करना है.
एक पर्सनल क्वेश्चन पूछूं आपसे
और कमीशन कितना लोगे
फर्स्ट स्लाइड. सर आपने जो सवाल पूछा फर्स्ट सो दो कर दो.
फर्स्ट स्लाइड.
नीचे नंबर लिखा हुआ है, यू कैन नोट डाउन दिस नंबर. दिस इज नंबर टू कॉन्टैक्ट. सर एक पर्सनल सवाल पूछूं.
श्योर.
सर इज आल्सो इफ आई कैन एसोसिएटेड विद अस, आप अपना पर्सनल एक्सपीरियंस शेयर करेंगे सर?
Right, definitely.
Please.
Very nice. I was initially I have जो दिल्ली आया तो उसमें मैं अपने LIC एजेंट सुना. Then उसने ही एडवाइस और भी LIC में इन्वेस्ट करना है या किसान विकास जो आपका होते हैं उसमें. बट लेकिन then उसके बाद में कोई खास मतलब ऐसा बेनिफिट या कुछ नहीं था. Then जयपुर बोर्ड में विमल को ज्वाइन कराया, विमल के विषय पता चला कि नहीं ये करना होता है. तो दैट डे मैं करीब 2-3 लाख मतलब ऐसे कुछ पैसे लगाने जा रहा था, मतलब इसमें एडवाइजर ने दिया. तो इसने दिखाया अपना डाटा कि सर ये मत करो आप. मैं थोड़ी देर के लिए इंटरेस्ट हुआ, इसने दिखाया कि वो फिगर दिखाया कि दैट इज रॉन्ग, इससे कुछ बेनिफिट नहीं हो रहा. LIC में ऑलरेडी हमारा पैसा ही हमें ही मिलता है, उसका कोई बेनिफिट नहीं होता है आगे. तो गो फॉर द दिस स्कीम, जिस म्यूचुअल फंड में और ये रिटर्न में. सो आई डेफिनेटली आई एम नॉट एनी लॉस. I am getting benefit by the Bimal, so you can trust on Dr. Bimal for all this financial advisor. So thank you, Dr. Bimal, for me and all my colleagues for to advise in this session. So now I request to all the chairpersons to facilitate.
आप अगर आप बेनिफिट की बात करें तो आपका जो एनुअल रिटर्न है CAGR, it is more than 27% per annum.
और अब कम हो गया, पहले 62% था, 60% से कम होकर के
20% on annual basis we are generating profit.
62% ले लेते वापस, कहते नहीं अभी करते तो अब लॉस में रहेगा.
लॉस नहीं है सर. 27% annual compound return we are generating for him.
Thank you, Dr. Bimal. So now I request.
I think it's a very nice presentation, but the only point is that the topic name is financial planning for young people. This is not only for young people, I think this is for everyone. Number one. Number two, apart from these many students, there are other ways of investing also. There are like high frequency trading, you must have heard that today there are traders, those who are doing microseconds trading. So those are also there and they also give very good return. And one more investment format is there, which is angel investing. In angel investing, you basically invest in startups. You must have seen Shark Tank, I mean all those entrepreneurs investing in different startups. But that is high risk, high gain kind of a game. If somebody is interested in that kind of investing, you can always join some angel networks. So there are angel networks. So you guys should also talk to some angel.
Yes, Dr. Nishal, this is a very good. Because of lack of time, we actually could not showcase the whole product list. We have everything you can think of in the financial world. I can say this word. Everything we have. Sir,
So, session is very late, Dr. Sushi and Dr. Chawla. Any comment? So, now I request Dr. Chairperson to facilitate our speaker, Dr. Bimal and Rachit. Please come. Thank you, Chairperson Dr. Bimal. And now I request Dr. Bhatia to facilitate our chairpersons.
10 मिनट
Dr. Chawla, Vivek Chawla.
Next speaker बुलाओ.
Dr. Naveen Nishal and Dr. Sushil Jain. Thank you, Jay.
Thank you, Dr. Saab. Our next topic is transforming AI tools, reshaping healthcare in 2025. And our learned speaker is Avinash Sharma, Director Cardio. Dr. Gunjan Sharma, HOD, Medicine and DNP Coordinator, Hill Heart Hospital. I request him to please come on the stage. And our chairpersons for the session are Dr. Manish Mathur, Dr. Sonia Bakshi,
टाइमर स्टार्ट करना है
and Dr. Pawan Goyal. Please come on the dais, please.
So now this is a session, I think, like the financial management. This is also a topic which we are very important, and let's listen to our speaker. Okay, sorry. So let's listen to our speaker and be wiser in this topic. Yeah, over to you.
Thank you very much, and good to see in the academic sessions. We as a community are evolving, and apart from that, अगर मैं कुछ शब्दों में बयान करूँ तो और भी रंग हैं जमाने में प्रैक्टिस से मोहब्बत के सिवा. तो प्रैक्टिस के साथ में बहुत सारी चीज़ें हैं. फाइनेंशियल लर्निंग हमने सीखी, and now we are heading towards AI. AI is rapidly evolving. So I'll be discussing brief about AI, and I'm Dr. Gunjan. I'm founder of a Meshup AI, which is a B2B application for doctors and pharma communication, and it gives many opportunity for doctors to have an add-on earning. So transformative AI health in 2025, it is very clear that doctors who will be using AI vis-a-vis those who are not, those who are using will outpass those who are not using. And it is evolving very fast. So it is featuring Meshup. So the rise in the clinical practice from diagnostics to documentation, AI is everywhere. 74% of the doctors right now globally are using latest AI-driven tool for their workflow. India is rapidly shifting towards a hyper-local doctor-centric AI platform. So some global example of transformative AI is DeepMind, which is mini Gemini. It is an AI medical reasoning. You just have this application, give anything, any query to it with whatever you are having in your mind. Give an adequate prompt, and in case you are not able to give the prompt, just upload the file, few documents, and it will give you a crisp and precise information and the reasoning why this is happening. Then there is a Quera AI. It's a classical, it's a chest X-ray AI. It is India-made AI. You load any X-ray, it will give you a detailed information. There has been a recent study, or rather there was a mammography which was given to an AI and to a 25-year-old radiologist. That AI picked up the micro level with a micro level precision the calcification and could diagnose better than the 25-year-old doctor. And then we have Watson, this is personalized oncology, and then Path AI, it's precision pathology, and Olive AI, it's a healthcare whole process automation. So AI in healthcare is revolutionizing healthcare in general. So those who will be using it will be definitely outcasting those who are not. So Indian doctors care needs in 2025. So there is a time of, right now we say work-life balance. So you will be surprised to know that in India, doctors have an average life expectancy which is less than 10 to 12 years than their general population. So we are treating people, we are making them longer, to live longer, and we ourselves as a community are not living that long. So it's a bad situation for us as a community. So the work-life balance, we have only work, there is no life, so our life has cut short by God. So we have to have a work-life balance. So better time management, reduction of the admin burden, protection from the medical legal risk. So because normally what happens once we are stuck in any medical legal case, we alone are fighting with the system. We are the only one, and then on the other side there is the system, and system is robust, everybody is against us, and it becomes very, very difficult to fight with the system. And so that's if we form a community where the community fights for you, with you, then it makes a lot of difference. You must have heard there is a High Court judgment on a one doctor, just I think 2 days back, where they have told that small nursing home and doctors have become, for them the patient is an ATM machine. That's what the High Court, Allahabad High Court statement came. So we see the amount of the hostility which system has to you, and when you are up against them, you are the only one fighting. So we should have some close-knit community which works for us, and in case of difficult situation is standing besides us. Though we have many forums and organizations, but majority of the time they are of no help in individual cases. So small smarter patient engagement, fairer professional visibility and networking, and opportunities beyond OPD and ward income. So right now we majority have earnings either from the patients, primarily from the patient. Either we go to hospital, earn money, or we have money from our office. Doesn't, though there are patients who are sitting there in your office, and they are your captive clients. They are sitting there for an hour for waiting for you, and in spite of that, we are not able to utilize that time. So in case if normally you go to any showroom to buy a car, we go with the mindset that we will get insurance from there without knowing that we can have insurance from outside. But majority of the time we calculate that we'll get insurance from the car dealership itself, then why our office cannot be an insurance lead agent? Why we cannot do that? India is an emerging market in the health insurance. Why our office cannot work as an insurance lead generator in our next club? So this is Meshup AI. This is India's first and doctor's first AI platform. This I have developed with my around 20 years of experience into practice, and whatever pain area I have experienced as a physician, I have tried to sort out all those pain areas for the community, so that we as a community evolve and at least add some quality in our life, and we can have a work-life balance. So what we can do with the Meshup AI? So it is digital OPD promotions, primarily for medical representative. Right now, you must be seeing that there is with lot of PG-based company into the field. You will have your office will be crowded by these medical representatives, and you will, in spite of you not wanting to meet them, you have to spend some time. And an average doctor approximately spends 2 hours in a week meeting with the medical representative without anything. So you are losing 2 hours, and you have no control on that. So and obviously anybody can barge into our chamber stating that he's a medical representative. We have no way to ask whether, or we have no way to verify whether the person who is visiting your chamber is an authentic MR, or it's some sting is going to be done on you. There are incidences where Tehelka and other agencies have done sting in the name of being a medical representative into the office. So we have no control. We don't know who the person is coming into our chamber, whether it's a medical representative, what is talking to us. We have no control on that. That app gives you that control. And then obviously I have added, right now we are in tie-up with the 3 top leading, in Delhi, top leading law firms for medical legal help. This app gives a 15 minutes free medical legal help, and you can put your queries. They will give you a call back and give you an advice, and obviously rest is your choice whether you want to go with them or you don't. But 15-minute advice with this application is free, and obviously our office becomes a health insurance lead generator. And then obviously right now this application has approximately 300 doctors and around 1500 medical representatives. And with the 300 doctors on board, right now we normally do post-marketing survey. We are normally doing it for the pharmaceutical companies. We are HNIs. It is not only the pharmaceutical company. You will be surprised to know that it is not only the pharmaceutical company who wants to know about us, about their product. It's Mercedes wants, BMW wants. That means you have all bigger brands apart from the auto, apart from that Apple, many top brands. They want your opinion on their product. So and obviously this PMS ultimately fetch you money. So right now this PMS, what we are doing is only with the pharmaceutical company. We are not involved in the PMS with other companies which are there in the market. So this acts on the revenue to us, and this is all legal. And one pain point which I have experienced in my 20 years of practice is that our office, who is receiving call for appointment, practically you have no control. You don't know what they are doing, what they are talking, how much call they have missed, how much call they have fixed. So this is a big problem. So every call missed is every patient missed. So now what we are in the process of training a bot. In case if you want, we are just training it, because health related discussion by the patient is region centric. Some patient for pain will say something else. Some patient of pain will say something else. So it is taking time to train a bot, but we are training a bot so that the moment the call lands, the bots take the call, and the bot, after taking that call, if it is just for an appointment, it will block the calendar, and even if it will send a payment link to the person, and once the payment is received, and then and whatever discussion has happened, the bot has done with that is recorded. I'll be quick. So what I want to say is that I'm trying to train a bot So that will also, it becomes a virtual reception for you. You need not to pick up the call, you will receive only those calls which is really meant for you. And obviously it creates a close community for the doctors. So these are all features of Mesh app. And so it is primarily MR booked via app, no more crowd outside, pharma control promotion only, legal concerned AI, lawyer support, insurance and PMS, positive income setup, and want visibility. So we push you where it matters. So all calls leading to clinic is answered by AI bot. All these features are there. There are certain evolution. So this is which I have tried making work-life balance for the doctor. So I'm trying to reduce the burden of the doctors which right now they are having in their practice. Thank you very much. So any questions regarding this application?
Okay, so nice presentation. You can go ahead with the questions even after the session. There will be a personal introduction. So
I will request the chairperson to speak. Dr. Avinash Verma is there. Dr. Avinash Verma for the next session is there. Dr. Avinash Verma. Dr. Avinash Verma is not there, so Dr. Kundan is there from Manipal. Avinash Verma. As Dr. Avinash is not there, I will call for next session Dr. Kundan. He is co-chairperson, Manipal Institute of Gastroenterology, Dwarka, and the chairpersons for the session are Dr. Sushil Kumar Gupta, Dr. Satish Tyagi, and Dr. Dipesh. Please come on the stage.
कुंदन सर का पीपीटी नहीं आया सर
भेजिए भाई तेरे के नाम से आइएगा
अच्छा आप इसमें अभी इसके बाद ना हमारा व्हाट्सएप कर दीजिए बताइए सर बताइए अभी डॉक्टर जितेश मंगवानी का है लेक्चर इसके बाद तो वो अपना लैपटॉप लेगा पेन ड्राइव से हो जाएगा पेन ड्राइव से हो जाएगा
व्हाट्सएप कहाँ करना है
78277 कोई उनकी पीपीटी खोल दिया 78277
हाई भेजना
खोल दिया क्या करना है अरे
मैंने दी हुई है मेल कहाँ है
मेल आए नहीं आपको सर
करण के नाम
जो खड़ा है वो हाँ उनका कुंदन नहीं है वो आए नहीं है पीपीटी कौन खड़ा है वो कुंदन है सर
हाँ
उनकी पीपीटी आई नहीं
भेजी हुई है
78277 खोला है नहीं आया ही नहीं है
भेजा हुआ मेल की हुई है
आप भेज रहे हो क्या
मैं आके बैठ के मेल करवा के गया हूँ तरन के नाम से मेल है
श्योर है सर हमारा तो आया नहीं है
कॉल मेल्स पे जाओ ना
कॉल पे ये इनबॉक्स में आ जाए मेल करने के बाद चेक करवाओ
मैंने बिल्कुल भेजा हुआ है दोबारा
सर चेक किया था सर
बस मेल उसके बाद
कौन सी मेल आईडी में भेज रहे मेरी मेल आईडी
ये है ना आ गया बोलो
ये कहाँ की है डाउनलोड करके पोर्टल पे डायरेक्ट डाल 1 बजे वाला किसका है ये खोल दो स्विच कर दो स्विच कर दो मेल ऐसे एक्सेप्ट मत किया कर, अगर मेल करेगा ना तो सर यहाँ पे खड़े होकर मेल भेजो और चेक करो, ठीक है? नहीं तो ऐसे ही होगा। नहीं मिलन में
On behalf of Dr. Kundan, I will present the presentation due to some emergency couldn't attend the conference. So basically the topic for the today is recent advances in oncosurgery and innovation shaping the futures of cancer surgery. So basically, I'm a surgical oncologist, and to begin with, like surgical oncology involves significantly. Basically, we deal with all malignancies, and surgical oncology is a comprehensive cancer care that involves the surgical specialty as well as the medical domain and radiation oncology. Together, we all from all specialties we cater the malignancy and cancer patients. So it involves the integration of technology, improving efficiency and improves the precision and outcomes.
दे रखी थी, पीपीटी दे रखी थी।
So the objective of the presentations are to explore the modern surgical techniques, to highlight the technological innovations, and to discuss the further directions. So what are the scopes of oncosurgery? Basically, all the surgeries that are done in oncosurgery are not. These surgeries could be with the intent of curative intent, or these could be having a palliative support, or these could be diagnostic biopsy to confirm the diagnosis and to proceed with the treatment, and these could be reconstructive efforts. Like in oncosurgery, when we are doing surgery, when we dissect cells, we might need the help of our plastic surgeon to reconstruct for the better functional outcomes and positive results. So one of the modalities that is commonly used is the minimally invasive surgery. That is something people look upon nowadays. Like classically, a decade or even 2 decades back, most of the surgeries that were done were like classically open surgeries with big scars, with poor postoperative outcomes, and with prolonged hospital stay and postoperative pain for the patient. So with laparoscopic and thoracoscopic surgery, we are giving smaller incision with just 10 mm, 8 mm or 5 mm ports. So these help with reduced pain, the patients have quicker recovery, and the patients have shorter hospital stay, thus minimizing the financial burden on the patient as well, with better outcomes, and the oncological aspects are not compromised at all. So the robotic assisted, coming to the robotic assisted surgery, commonly in our center we are using Da Vinci system. It is the most advanced robotic system, not only in India as well as worldwide. So we are using XI system over there. So the advantage with the robotic system is that unlike the laparoscopic instruments and systems, the degree of freedom is higher in the robotic as compared to laparoscopic. In laparoscopic system, the degree of freedom is just 5 degrees of freedom, where in robotic surgery it is 7 degrees of freedom. And in robotic surgery we have a 3D vision. So we can really zoom into the tissues and we can see the capillaries, the minute vessels, we can pulgate them, coagulate them. There is less bleeding, and even you can do major gastrectomies or even colectomy just with hardly 5-10 ml blood loss. Just a single gauze which is sucked in during the procedure. And it basically removes the tremors that are there in open procedure for laparoscopy. So the key robotic application, the commonly used, the use of the robotic surgery, we deal with the prostate cancer, the rectal cancer, cervical cancer, esophageal, all can be done nicely with robotic surgery without compromising the oncological outcomes. Nerve sparing benefits are there in patients with prostate, especially with prostatic surgery in those patients who are going radical prostatectomies. Unlike in open procedure where the patient would end up with having erectile dysfunction and the delayed recovery because of the denervation of the bladder plexus. So with robotic surgery, with enhanced visualization and better coagulation and better surgical and fine dissection, these outcomes are improved in these patients. And again, as I said previously, because of better ergonomics, the better degree of freedom and the removal of these tremors in the surgery, the ergonomics for the surgeon are also improved. Unlike in classic open surgery where we used to stand and we used to operate on patients, and sometimes with these surgeries can last about 5 to 10 hours. So in robotic surgery, the surgeon he sits on the console and comfortably carries out the procedure. Then we can do real time the CT, MRI, intraoperative ultrasound can be done for better tumor localization and just removing only the part that is involved by the tumor, and we can save on the residual tissues.
So these are basically applied in your liver surgeries, and stereotactic veins procedures are carried out with image guided surgeries and for spine tumors as well. So this is a very interesting modality nowadays that is often involved in surgical procedure. It's a fluorescent guided surgery with the help of a fluorescent dye that illuminates with the gamma camera that is there in the robotic surgery. So with the help of the ICG dye, we can localize the lymph node, and unlike if these lymph nodes are not localized, like classically we used to take whole of the lymphatic tissue that could lead to lymphedema for the patients, and postoperative outcomes are delayed, the recovery is delayed. So with visualization of the single affected node, if it is not involved by the tumor, then we may not need to proceed with the proper lymphatic resection. So it improves the accuracy, the outcomes are better, the morbidity is less, the pain is less, and the oncological aspects are not compromised. So coming to the sentinel node biopsy, just to give you an overview, like the sentinel node is basically the first draining node from any area that is affected in the tissue. So this node is identified with the help of a dye or tracer technique. It can be identified with the help of this ICG dye. As you can see in the photograph, you can see a green illuminated area. So this is basically the dye that is there running into the blood vessels, and it drains in the lymphatics, and that lymphatic tissue is identified, and then it is taken out and then sent to the pathologist for evaluation. If the node is negative, then we may not be able to proceed with the complete lymphatic resection. Then it helps with the minimally invasive staging, and it is most commonly used for your breast cancers, your melanoma patients, even in gynecologic cancer like the cervical malignancies, your endometrial cancers. The sentinel lymph node biopsy is a very good modality for such patients who are in their early stage of the disease, who might not need a complete lymphatic resection. Because removal of all of the lymphatic tissue is going to, there is a possibility the patient will develop lymphedema, patient is going to develop lymph swelling, the ambulation is decreased, the morbidity is high, and the functional aspects of the patients are affected. Then intraoperative navigation systems are again used, where with the help of the augmented reality, it helps in the detected tissue visualization, identify the particular area in 3D when the anatomy is such integrated anatomy that you cannot localize the tissue with surgically. So it has the neuronavigation technique is there that is commonly used in especially brain tumors, where because of the complex anatomical relation, it's just not possible at times to localize the area with the complete surgical exploration. Then coming to 3D printing and virtual surgical planning, again, just said in the previous presentation, the use of artificial intelligence and the new techniques that are available, but these techniques are more or less commonly used for your medicinal branches, but in surgical branches they are yet to be used on a larger scale, but they are very promising as of now. As said previously by the previous presenter, that these can be used for for mammogram, for detection of cancers, lesions that could be missed out by human error. And coming to the enhanced recovery after surgery, that is ERAS. Basically, this is a protocol that is commonly used for post-operative management of these patients, where with minimally invasive techniques, because of the pain is less, the morbidity in the patient is less, the outcomes are improved by the patient is started on oral diet immediately on the day of the surgeries, and usually because of less post-operative pain and morbidity, these patients can be discharged earlier as compared to the open classical approaches, thus minimizing the financial burden of the patient, the psychological stress of being in hospital, to being away from your family members. These all can be mitigated by these techniques and protocols. Then coming to the organ preservation techniques like the laryngeal sparing techniques, these all surgical procedures that again have to be personalized depending on the patient's stage and disease burden, and these can be undertaken with the help of the newer techniques only, that helps in improving the quality of the life of the patient, and the oncological aspects again not compromised. Then one of the modalities like TORS, basically it uses robotic surgery for your oral cancers, which cannot be undertaken with the help of open technique, and most of these patients are then forced to undergo either chemotherapy or radiotherapy. With TORS basically stands for Trans-Oral Robotic Surgery, with the help of the robotic system, we can surgically remove the tumors and the patient may not require the chemo radiotherapy, which he has no choice in case if he is going for an open procedure or the course is not available. So cytoreductive surgery with HIPEC again is a procedure that is commonly used for gynec cancers, for colorectal disease. With HIPEC is basically a form of chemotherapy that stands for heated intraperitoneal chemotherapy, where chemotherapy agent is basically used into the abdomen with the help of the treatment after surgery. And again, with the help of these advanced techniques, we basically reduce the morbidity, the outcomes are fine, and the patients are satisfied. Challenges again are there, high cost and training requirements, the cost of the robotic, not all centers are having this system. So, but we are moving forward, and with the help of our support system and with the training, people are getting trained, and definitely these robotic systems are being available now in tier 1, even tier 2 and tier 3 cities. So again, the future directions are like AI-guided surgery, mean personalizing patient care and basically optimizing the patient outcomes as well. Thank you. Thank you.
Any questions from the floor?
Any questions from the audience?
Sir.
Any comments from the chairpersons?
Excuse me, sir.
I think very
Excuse me,
well,
sir. संजय खन्ने का भी आप ही भेज रहे हैं
उनका लैपटॉप continuous advancement and upgradation of the surgical practice also. While it helps in giving the complete surgery, at the same time it spares the issue which we can. It's nice.
Thank you, Dr. Sir. Thank you so much. I request our chairpersons to honor our speaker. Thank you all. Our next session is newer advances in endoscopy, and we have a very learned speaker from Manipal, Dwarka, Dr. Sanjay Khanna. He is Director Department of Gastroenterology, and the chairpersons for this session is Dr. Atul Gupta, Dr. Rajneesh Adam, and Dr. Abhishek Kumar. Please come on the dais.
नहीं अभी लगाया ही नहीं उन्होंने
कनेक्टर ले जाइए सीखा है अपना वाला सीखा है कनेक्टर हमारा वाला कहाँ है नहीं है डायरेक्ट सी कनेक्टर अपना वाला लगा अपना वाला विंडो का लैपटॉप है यार ये तो उठा लेना चाहिए स्विच कर दो अपने कनेक्टर क्यों नहीं लगाता है? अरे उनका लगा हुआ था तो उन्होंने खुद लगा दिया, नहीं लगाया।
10 मिनट
हाँ 10 मिनट। अरे वो माइक ऑफ है क्या? माइक ऑफ आदिल, माइक ऑफ है। आदिल एक सेकंड।
However, it may be very good to put old wine in a new bottle. It implies that in the era of iPhone using
कॉलर माइक ले आना।
in the era of using iPhone 16, it might not be wise enough to use an iPhone 6. iPhone 16 is better both in the make as well as in the technology. So this is what has happened in the past decade about endoscopy also. We got breakthrough innovations in artificial intelligence, robotics, advanced imaging, and also in the technique for performing these procedures. The field of gastrointestinal endoscopy has undergone unprecedented transformation, and it's reshaping the clinicians about how to diagnose, treat, and monitor the GI disorders, whereas providing the patients with more safer, precise, and less invasive options at the moment. So artificial intelligence is one of the most important things. My previous speakers have also mentioned about the same. So it helps in endoscopy in real-time polyp detection and characterization. It all started from Japan and US, where the incidence of malignancy is high, and AI, once it was incorporated into the endoscopy systems, it helped in picking up of early detection of polyps and malignancies with the help of computer-aided detection, CAD-E, and computer-aided diagnosis CAD-X systems. And the algorithms which are based on the computer out here, they have a sensitivity of more than 85% to pick up early polyps and malignancies, and so much so that even H. pylori infection can be picked up without biopsying more than 95% of the patients now. There's another device, CAD-E, which has been granted FDA approval in 2024. Now, interesting is that the previous AI systems were into this system itself. But this is a cloud-based system. So while doing endoscopy, it is linking with the cloud, and it's not only going to pick up the polyp, but also giving an algorithm how to basically manage it now. So that's the interesting part about innovation and technology now. So on this screen, we can see that this is going, once we are doing the colonoscopy in this patient, any abnormal lesion, a box is going to appear on the lesion, and this will tell whether it's a polyp or not. With CAD-E, it's also going to show an algorithm whether it is a benign lesion or a malignant and how to approach about it. So that's the interesting part about it. So AI applications help in lesion detection, diagnosis and support, and this new processing system or the natural language processing systems are being deployed automatically to extract report from the previous, so all the previous data which has been fed, it can basically relate itself and try to make abnormal reports. And also they are important because they are going to be important for large numbers, basically researchers also. There is another interesting EndoAngel AS automatic surveillance system. So once it's crowding and basically linked with the software and the data, so it's going to pick up all the high-risk patients and automatically send them messages that they have to come back and show to the doctor. This is all going to be automated now with the help of AI. So this is how it looks like. You're doing a procedure which is basically loaded with AI, the polyp comes, a box appears, the polyp is mentioned out there or a lesion is mentioned, and finally on the right side you can even have the algorithm whether to cut it, leave it or do something for it. So that's the beauty about this AI system. The second innovation which came was the robotics, which has been used in many systems. In gastro also it started picking up, and basically it's of two types, the master and slave type and the straws type. And out here, the interesting part is that you work at the master and basically the slave or the arms are going to do the dissection for you. It is quite accurate and can be used for endoscopic submucosal dissections also in a very efficient way. The Flex robotic system, it has been approved by the FDA for anal procedures now. For up till 25 centimeters from the anal walls, lesions can be dissected with the help of this robot now. And it's again the same systems. The teleoperated one, this is interesting. A person in Zurich, a doctor, can operate on a person who is in Hong Kong. And this was lively demonstrated and it's waiting for its approval by the FDA now. So basically, you just have to have all the AI-based systems and then you go across with the procedure. The next technological advancement after AI was based on the system itself, on the machine itself. So normal endoscopy is done with the white line. It has got 7 bands on it.
right? And once the light is dissected into the various types, then and the filters are used to basically delineate the lesion. So some lights, some filters will, some wavelengths will basically pick up the blood vessels, some will pick up the surface mucosa, and this is known as a narrowband imaging. This is interesting because it will again, based on the studies, pick up whether the lesion is benign or malignant. Out here, if we see, so out here if we see these lesions, this looks benign, this one. But this one, can we see the vessels, they are all lost out here. This looks malignant. So with the help of this NVI technology, even without a biopsy, we can basically identify that this patient might be having a malignancy. Though we need a biopsy to further treat the patient. Confocal, now this is short of a biopsy. We can actually see the pathology on the computer itself while we do the procedure. It's going to help us picking up the lesions early and effectively. The sensitivity rates to pick up any switch and malignancy may be around 100% in the preliminary studies, and it's basically based on the system, the machine itself, or a probe. We can put in a probe and do the test with it, or we can do it with the endoscope itself. Next is about capsule endoscopy. This was another revolution. This came up around 25 years back, and so it's got a higher resolution, an enhanced battery now, and an enhanced frame rate. So many more pictures, almost 1 lakh pictures in a span of 14 hours it takes. So it all started in 2001, where it was a simpler form of capsule, around 2.5 centimeters is the size, but now it is AI loaded. So what happens is once the AI loaded capsule goes inside, it's going to identify the lesion, correlate with the AI system, and if it's a caddy basically out here, then it will even give the algorithm, it will probably give you a diagnosis rather than, and now the time is coming when it's going to become a capsule surgeon. So we have loaded it with a few devices extra, and these devices, as I mentioned, they can basically perform the procedure itself by AI itself, not even requiring the doctor. Now, that's all about the future. It looks like a science fiction, but possibly it's going to come out very soon and very fast. So these capsules are basically small, simple. They can be easily consumed with water. Person has to be empty stomach. The veins inside traverses from the mouth to the anal area, and basically identified and used to identify lesions of the small bowel. And it picks up around 1 lakh images in a period of around 14 hours. And well, the most important part is now it's coming with AI. So this was about the technology. Now about the techniques, where we are improving. So on the right, we are all aware about ERCP. Most of my surgical friends, surgery friends are basically aware that once we need to take out the stone, then we need to do this procedure. So techniques are improving once we become more versed with it. But with the help of newer advances now and newer machines, even in altered anatomy, we don't have to ask the surgeons to do the procedure. And with the help of AI maybe, it tells us whether we are going in the right direction or the wrong direction to make a cut or something. However, if stones are big, earlier the surgeons would take it out. Now with the help of a spyglass, we are entering inside the bile duct and directly visualize the stones and trying to pulverize it with the help of it. Not only the stones, even malignancies, doubtful indeterminate strictures, we can even take biopsies with it. So that is very interesting because it was not being done earlier, at least 1 decade earlier. And even pancreatic stones, we have been able to pulverize with this. So this is a small video which I'm showing. We are taking out the stone. This is actually we performed in Fortis while we were out there, and this was the last stone. We were not able to take it out with routine endoscopy. We done a spyglass directly visualizing the stone, and here with the help of an EHL, we are basically breaking the stone open and going to take it out. And once it is cleared out, we can see that the sleeve is totally clear now. So that's the beauty of these procedures. But this is basically technique plus technology together. The next important innovation, again it started in 80s, went back because it was a cumbersome machine. We were not aware about the anatomy based on the ultrasound. Then we learned a little bit more, and then the ultrasound has come back again. It's very important tool in the armamentarium of the endoscopist, and basically it has a transducer mounted on a scope which can be linear as the first one I'm showing out here, and a radial one. Radial is a 360-degree picture. We cannot take a tissue with that. With the linear one, we can do therapeutic procedures, the FNAs and the procedures with it. The most important beautiful part about this is that the esophageal or colonic wall, for example, it's around 2-3 mm. With the help of EUS, we can delineate all the layers with it. And this becomes very important once we are going to do further procedures. So apart from mucosa till serosa, we are all able to delineate all the layers out here. We can see it out here. Even one of the important, like interesting procedures like pseudocyst drainage that the surgeons were doing. Earlier we were doing with ERCP in a blind fashion. Now it's under direct vision. We puncture it and place a stent, and that's all. And it's hardly a 5-minute procedure now with the help of a dynamic EOS. So the next advantage out here is the newer technique. I've already told you about the layers. If the third slit endoscopy, the wall is thin, the layers are different. So now with the help of OM or the peripheral endoscopic myopathy, we are able to enter inside, make a tunnel and basically cut across the muscle layers. And this is short of a Heller's myopathy which the surgeons would do. With the help of ESD, we are able to dissect the superficial tumors which are not going through the wall. With the help of ESD, lifting it away from the wall and doing it. Again, this is a technique which has evolved over a period of time, but with the help of more technology and better things. So this is again a very small video. I'm going to skip it fast in view of time. So this is how it goes in lesion, and the patient was symptomatic for it. And out here, so the next innovation or advance is the counterpart of what the surgeons would do for weight reduction surgeries, the metabolic endoscopy out here. So we can place balloons and even do endosuturing out here and narrow down the lumen as the surgeons would do, but without the cut on the abdomen. So that's again a new procedure. So out here we can see that the physicians, the endoscopists are basically acclimatizing themselves to the various procedures with the help of technology. The most rapidly technique which has evolved is the EMR and the NVI, which are simple, and the robotic systems. We are not very tuned to it, but we are coming up fast. And this is just a speculation about the companies are involved who are into it. We can see at now it's around $12 billion market for this AI and other technologies which is out there. And by 2032, it's going to double up. So that's why all the companies are interested in AI and all these robotics. FDA clearances are being given to all these machines and the systems now, and they are going to be there for the patients, the doctors. And this is interesting because from the era of 2000, where only imaging was available, now it's an AI-based imaging and better techniques and technologies out there. Next generation, molecular imaging, targeted probes, augmented reality would come into the picture soon, 5G enabled, and further they would enhance the things. Now, what clinical impact would it have? Modern techniques, they would reduce the procedure time, diagnostic accuracy, they decrease the complication rate and improve the patient outcomes, and this is all with the help of AI. Challenges certainly are there, the learning curve is there, and the cost is there. And finally, the last slide, I'm just summarizing it again, that it's an era which has been come into the picture because of artificial intelligence, robotics, advanced imaging, and innovative therapeutic techniques. All this for the patient in the form of enhanced diagnostic accuracy to expand the therapeutic capabilities and improve the patient outcome. And
I think
over the next 1 decade, we are going to have many new, more advances in the endoscopy stuff. Thank you.
Thank you, Dr. Khanna, for an excellent deliberation. I think you covered all the practical aspects of these innovations. Any questions from the audiences? Yeah.
I really was very impressed with the alternative that you gave, the bariatric open surgery. So what are the studies like? How effective it is? If you can just throw some light, because that's very...
So now we have decent data, and one of the biggest centers in the country is AIG, Asian Institute. And out there they compared the open with this endoscopic one. So they have found that the results are almost similar. The admission rate is slightly shorter. The cost is a factor because we not being able to reduce it because the instruments are costly. The learning curve is there. All endoscopists are not able to do it. Neither all surgeons are able to do the metabolic surgery also. But certainly the rates initially, they are all. Long-term data is very good. Yes, some patients who basically don't do well, they ultimately have to go on for an open surgery. And that's all.
Any more questions? Thank you, Dr. Khanna.
Thank you, Dr. Khanna. Thank you so much. I request our chairpersons to please honor Dr. Khanna. Our next speaker is Dr. Jitesh Manghani.
He is Principal Consultant and Spine Surgeon, Max Hospital. Please come on the stage. And our chairperson for the session are Dr. Sonal Gupta, Fortis, Dr. Jaideep Bansal, and Dr. Sunil Attari. Please come on the dais, please.
I invite Dr. Jitesh to present his talk on recent advances in spine surgery. Over to you.
Good afternoon, everyone. I'm Dr. Jitesh Mangwani, Principal Consultant and Head of Ortho Spine and Max Shalimar Bagh. I would like to thank the organizers and chairpersons for giving me this opportunity. So, what are the recent advances in spine and why are we looking forward to it? Because as we understand as doctors these days that technology is something that is coming up every day. And if ever we, with a new technology, as it rolls over us, we are not a part of the stream roller, we will actually become the part of the road. So hence, I intend to become the part of the stream roller rather than the road. So what are the different state-of-the-art technologies that we have these days? So we have intraoperative CT navigation, robot-assisted surgeries, intraoperative neuromonitoring, microscope, artificial disc replacement, cement augmentation techniques, and spinal cord injury patients, we have baclofen pumps and the electrical stimulation or the epidural stimulation. So now this is a 13-year-old male with such a Broti's deformity, that is a kyphosis, and he now comes to me walking. And now I have to ensure that this particular kid goes back home walking. So with this particular rigid deformity, this is the correction that I achieved, and this was possible with the state-of-the-art technology, that is the navigation. So using the navigation during the surgery, we are able to see where exactly we are putting in the inventory, where exactly we are putting in the probe, the screw, and even the decompression aspect. So what are the indications? In deformity surgeries like scoliosis, kyphosis, in CV junction surgeries, in tumor resections, in complex spine surgeries, congenital anomalies, high-grade prosthesis, and even revision surgeries. So this is the intraoperative image wherein, as I'm trying to show you, this is how the picture looks like, so that we are sure what we are doing, where we are doing, so that we don't cause any harm. 54-year-old male comes to me with a cervical spine compression with myelopathy. This particular patient was planned for a decompression and fixation. Now, literature has already established the patients with cervical myelopathy who get up with deficit after the surgery, they actually get the deficit with the positioning of the patient. So this is a machine called neuromonitoring. As you can see, there are some graphs upside, which are the upper limbs, which you can see are present, and the lower, everything is flat. So as we position this particular patient, all the graphs went down. So this is the importance of using the technology, because as we understood, just by making the patient prone, we lost the graphs. So what we did was we modified it a bit, we did the surgery, and we got everything back. Had I not used this particular machine, I wouldn't have understood with the positioning of the patient we are incurring a tip. 20-year-old male with a bullet injury. Along with this, he was asking for a trial for epidural stimulation. I clearly told him, we are going to try, we will see whether it works or not. So epidural stimulation is a new technique wherein we try to give the ray of hope to the complete spinal cord injury patients. So the way of inserting it is we actually put in the probe and see whether it is stimulatable or not. We did the angio, we removed the bullet, we actually did the trial and it did work out, so we didn't put the stimulation at all. This gentleman with a
failure of conservative management of the slip disc, walking with a painful gait, deficit. A microscope assisted decompression was done, and this patient is walking the very same evening after the surgery. So this is the beauty of keyhole surgeries wherein the patients walk like this. So this particular patient came to us with a slip disc in 23. We told her you should undergo surgery or else this problem is going to increase. The disc increased, she lost the bladder and bowel control. That is when she came back to us. We did a robot assisted fusion in her because this was a very big disc, and this is the patient walking. In young patients, we don't fuse, we do something called as disc replacement so that we ensure that they have the mobility. 23-year-old male, elsewhere diagnosed just with a slip disc, came to me. I showed him that along with the slip disc, what I see is possibly some tumor inside. We went inside, this is the intraoperative image, and what we found was the GCT of the spine. Multiple osteoporotic fractures can be managed beautifully with cement augmentation techniques and the medical management of osteoporosis. Intrathecal backflow pumps for the patients for complete spinal cord injury patients, and epidural stimulation in complete injury patients where the trial succeeds. So I can tell you, I have one patient, 28-year-old female, who just had the sensation present. She was 1 year down the injury. She didn't recover with the epidural stimulation. Now the girl is walking in the house with a walker and she got the bladder and bowel control back. So these are some cases with which we have the ray of hope, where we try to give this particular option to the patient as well. This was a patient who was operated elsewhere for TB spine, infection, implant removal was done, and she came to me with this particular situation. Using the state-of-the-art technology, we did the surgery, a state surgery. This patient was just having sensation present in bladder and bowel. Dysfunction was there. We did a 3-stage surgery. First only traction, second provisional stabilization, third robot-assisted surgery. This is the X-ray after second, and this is after the third. This lady is now walking. She even delivered a kid after this, and she got her bladder and bowel control also back. 11-year-old female, elsewhere operated for TB spine. She comes to me with sinuses, discharge, and a deformity with myelopathy. This was the situation that she came to me with. Because of the stretching of the spinal cord, she had myelopathy, and this is the correction that I achieved. 52-year-old male had the history of trauma when he was 7 years old. He lived the life comfortably with that. Now since 1 month, he's got a difficulty in walking with perianal numbness and urinary straining. Grade 3 PAL with bladder and bowel involvement. This was the X-ray. Robot assisted correction done, and this was a live surgery done by me in the front of Indian audience. 16-year-old female, post-tubercular deformity. This is the correction that we achieved. It was a painful deformity. 15-year-old male with congenital kyphoscoliosis with hemivertebrae. This was the first case of the world wherein robotic D1 screw was inserted, and this is back in the year 2020 I'm talking about. I'm the proctor of robotic spine surgery in India. I have written the SOPs which are followed worldwide on how the surgeries should be done. 10-year-old female with idiopathic scoliosis type 1C. This particular girl, I take pride in telling, is playing golf at national level in India now. 14-year-old male, deformity with bladder and bowel involvement. Now this is one case where I would like to tell you that we don't always aim for a complete correction. As we were going in and trying to do further correction, we were losing the signals on neuromonitoring. So safety comes first. So with this, the child had a significant correction and the patient went home walking and has joined school as well. This kid had a surgery done in the childhood for meningomyocele, came with the deformity. This was the situation. This is the correction that I achieved. Adult deformity, robot assisted correction. Patient with METS, primary was from the intestine. This is the fusion. She went home walking. Further malignancy oncological management was done. Multi-level LCS with spondyloptosis. multi-level LCS in osteoporosis. Robotic MIS T-lift, one level can now be done in less than 1 centimeter incision 2. So robot is not just a surgeon, it is actually a tool. This is an assisted aided surgery wherein we do the surgery together with the robot. We plan and the execution is by the robot. So it helps us to give the precision and accuracy during the surgery because we are aiming for the best possible accuracy. Literature has already shown that the surgical complications are lesser and so is the revision. So robot helps us to predict, plan and also intraoperatively while execution we are able to see what we are doing. We can see the final outcome and deformities also with the planning in the robotic system as it is showed with the construct design. Literature has already shown us that the best possible accuracy on comparison is with robot. Multiple studies have showed, which are standalone studies as well as randomized control trials, that the radiation is lesser and also the complication rate. These are the studies done in international journals as well. So we have the greatest hospitals, the doctors, and we are trying to make them accessible to all the possible population across in India. Quickly, I would like to show you a small video clip on how the robot surgery is done. So this is how the patient is mounted on the table. This is multimodal neuromonitoring, SSCPs and MEPs. So robot is mounted on the side. This is a deformity, hence we have an open surgery. This is how the robot is connected to the patient so that they act as the one unit. This is a safe area of movement of the patient. So that the robot is not going and hitting the patient, which happens in other systems. Intraoperatively, we take the CT scan, we take the images, transfer it to the robotic system. So this is what you see. We are planning on the robotic system. That is the spinal cord. This is the segmentation of the vertebrae. And this is the screw planning, so that we ensure that we don't incur any breach, we don't incur any complication. 1 millimeter cuts, we are able to see how we are going to exactly execute and how it should be. In all the three planes, axial, coronal and sagittal. So this is the execution. During the surgery, as you are seeing on the image on the left, on the top, right for you. So over there, within inbuilt navigation system, we are seeing the execution that we are doing. So this is a drill. We can see the trajectory of the drill. This is the real-time execution. And this is a screw going inside. The yellow is the desired plant track and the pink is what I'm inserting inside. So we are sure we are doing what we planned. After all these screws are inserted, we are going to do laminectomy. Corpectomy was also done. In this case, I will quickly rush you through it. So this is after the laminectomy. The central structure that you are seeing that we are protecting is the spinal cord. A temporary rod was inserted on the other side. We are removing the pars, the facet, and anteriorly we are going basically with the osteotome, the mallet. The body is being removed using the burr also. As you are seeing on the left image, we use the intraoperative burr to confirm how much amount of bone we have removed. The final rod will be inserted on one side. Now we are removing the bone on the other side. Compression to achieve the deformity correction. That is the shingling. Thank you.
Thank you, Dr. For your such a wonderful presentation, and the cases you presented were excellent. And I was really wondered to see the chronic myelopathy, compressive myelopathy improved after correction of spine. That is really a wonder, and thank you for that.
So it's a collaborative effort between the surgeon and the therapist, I would say, because I believe it's a team effort. I alone cannot do this, so along with my team of therapists, we are able to mobilize the patient, we are able to achieve that independence that is required.
That is one part, but the myelopathy is improving after chronic myelopathy with the bowel involvement. That also improved.
Yes, definitely, sir. We have series of patients who improve. Ma'am is agreeing over there that the patients do improve in myelopathy. So timing is important. Now, if the patient is losing the complete power in the sensation and the bladder and bowel is completely gone, they will not recover. If he is coming to me with straining pattern, which is the early onset of bladder, if ever he is coming to me with some constipation, if ever that example that I showed you had grade 3 power, had it become grade 0, he is not going to recover. So the important time for us is when some power is present, sensation is present, and he is not completely lost of bladder and bowel control. Because once this happens, like I received a patient yesterday, dorsal myelopathy, grade 0 power, only some sensation is present, already coming to me with catheter. I told there are hardly any chances of improvement. So the timing of when we intervene is important, sir.
There is a rule of 3 actually taught to us as a neurosurgeon, that if patient comes to you with a bowel and bladder involvement within 3 days, the chances of improvement are 90%. If within 3 weeks, the chances of improvement are less than 50%. And as you correctly said, more than 3 weeks, very less chances. And Dr. Ditesh, thank you very much for spreading all this, because here I just want to say that not only our society is scared of spine surgery, even our colleagues are very scared of spine surgery. So maybe people like you, me, Dr. Jaideep can create more faith in people that when spine surgery, minimally invasive spine surgery, and with all technological advances done at the right time, 90% success rate in rightly selected patient. Excellent work done.
Thank you. Thank you.
Any questions? Anyone? Any comment from your side, please?
Any question from the floor?
Any questions from the audience? No. Thank you, Dr. Jitesh. Thank you so much. Thank you, our chairpersons. I will request our chairperson to honor Dr. Jitesh. Dr. Rajiv Gupta to honor our chairperson. Our next speaker is Dr. Kuldeep Malik. He is Associate Director, Orthopedics and Joints Surgery at Max Hospital, Shalimar Bagh. I request him to please come on the stage. And chairpersons for the session are Dr. Puneet Mishra from Fortis Hospital, Dr. Harinder Agar Kumar, and Dr. Aditya Jham. Dr. Aditya Jham is there. Please come on the dais.
Very good afternoon, everyone. Thank you, Thank you. Thank you to my senior sir, my senior sir, Dr. Puneet Mishra. I was here for this session. Again, in every conference that we go, the answer should be like, what is the recent advances in joint replacement and complex joint replacement surgeries, or what are the advancements? Nobody talks about the primary TPR nowadays. Everybody goes to the revision only. And my topic is the same today. Important for going for any kind of advances, there should be an indication. Without an indication, if you do anything, there is nothing called recent advances. The basic problem issue is the tool. What we as an orthopedic surgeon, we use everything as a tool. They should be taken as a tool only. They are not the recent advances. And if we know our indication, we use the tool to get a proper healthcare for our patients, which is the mandate thing. Total knee replacement, the recent advances so far is newer materials, coating, robotic or 3D navigation assisted, minimally invasive TKRs, expanding indications of UKRs, cementless implants. When you talk about patient counts in the OP, talk about sir, which implant will you use? I say everything is fine. If I make it 5 lakh ka bita wo bhi theek hai. How I am putting it, that is important. So everything works. But important is to take the history of the patient. Not every implant is required for every other patient. Important is the history. patient has metallurgy, patient has other things, patient has other allergic reactions. So we know which implant, which coating should be used per se for that patient to go ahead. The newer materials, it's auxiliary knee implants, are a type of knee replacement using a material called oxidized zirconia. Nothing is doing this, but important was just metallurgy. It protects us from metallurgy and the shape which gives us a 3D. The hardness, the low friction and resistance to scratching and abrasion. Durability for younger and more active patients. A gold knee implant, also known as a gold knee, it has a coating of titanium niobium nitride that gives a golden appearance, that's it. It's not a gold knee per se. Addresses potential allergic reactions, improve biocompatibility and improves durability. Newer advances is ICSI. We do RoboLens nowadays. The RoboLens, it helps us to maintain what we do in the TKR is a conventional TKR, just telling us on the table how much varus, valgus, flexion extension has to be done, including the things. So it's not a properly robotic, but it's a RoboLens which helps us to conclude the surgery faster and better. So lesser blood loss in the robotic knee replacement, what we do. No need to remove implants around knee. Assistance and assessment in ligament balancing and bone cuts. So where are the robotics being used? Nowadays when we say, sir, do you do robotic? We want to get robotic done. For the patient understanding, the robotic is not being used for every patient. It was a tool for us. Again, for the patient who has malaligned tibia, who has been a malaligned femur, who has broken his femur or tibia way back years ago and has been malunited now. So where is the where kinematic alignment to go with it? So the robotic is being used. But nowadays patient asks only for robotic care. So do you do robotic? We want to get a robotic done. So is there a difference and helps in robotic? Definitely yes. Little bit of the blood loss little less. And if you ask me about the patient being faster, movement in mobilization is faster, I think it remains the same. So image-based robotic TKR involves pre-op CT scan exposure to radiation. Can the implant position be accurate? It's a surgeon's role, I believe. Whatever we do with the robotic we play, it's a tool for us. It's not an indication for the patient. Image-based robotic TKRs, real-time sensors for registration. We do all registration for the patient. We do all flexion extension for the patient. We have access and CT scans. We put in the robot. They tell us how much varus valgus we need, and pre-op everything is planned. So that what are the size of implant being used is already planned before the OT. We know which implant is being used and how it has to be used. So unicondylar knee replacement, can it be performed with ACL because or in ACL deficient knee? Mobile bearing UKRs, higher range of motion restricted. The problem is again an indication. Where to use a UKR? In which age group UKR should be used? So it's always a dilemma and it's all about experience. How you do a UKR and what are the indications. If you ask me, even 50 years, 60 years, 70 years, you can go for a TKR, UKR. Rather, if you should know the arthritic level, it's a tri-compartment arthritis or a middle compartment only. But in Indian population, we need to understand that only doing a UKR, financial issues are there with us. Patient cannot go for a revision surgery. उसके लिए revision बहुत बड़ी चीज़ है. अब दोबारा करना पड़ेगा 10 साल के बाद में. So he is always ready to go for a total knee replacement or a UKR. Many less people are there who understand what UKR and how to go about it. So we have patellofemoral arthroplasty, has good outcomes for isolated patellofemoral arthritis. Minimally invasive replacements is all small incisions, causes less pain, less blood loss, less requirements for analysis, faster recovery. This is not for the patient, this is for surgeon who are experienced and who knows what to do, how to do for them patients. And MIS, there is nothing to do with the patient welfare. It's for the surgeon, they are easy, comfortable, they have a learning experience with that. We can easily go for minimally invasive knee replacements. Customized TKRs are there. It can be for instrumentation as well as for implantation. The patient-specific instrumentations, PSIs, and individualized implants. Again, personalized cutting guides, accurate bone resections according to 3D planning. And in individualized implants, we know the anatomy of the knee. So optimize bone involvement, how much bone loss is there, how much wedges we have to use, how the range of motion we can get, how much the tissue loss is there, so we can plan accordingly. Uncemented TKR advantages, breastfed implants have porous surface, have a rough porous surface that encourages new bone growth, thought to last longer compared to cemented implant, no complications from cementing or cement breakdown. TKR is a daycare procedure. Compliant patient should be there, multimodal team, requirement is there, pain management, post-TPA, rehabilitation. So everything depends on the teamwork. It's not only 25% is being done by the surgeon as well, but 75% is patients as well as the rehabilitation team as well as the pain management team is there. The mode of an SA can be GA, average time can be decreased with pre-op planning. Revision need placements, OI needs space, principles of revision and management of bone deficiencies. So there are many factors OI need phase. It can be infection, extensive lag, stiffness, tibial femoral instability, fractures, loose of or femur implants or tibia implants, patellar instability, breakage, pain. There is no diagnosis. So first of all, you have to make the diagnosis, which is very important. Whether it's septic loosening, aseptic loosening, how much old, what are the reasons for being osteoporosis. So please revise, don't repeat the same mistake. For revision, again, the diagnosis is very important. Use revision implants wherever required. Complete revision can be done. Medullary fixation, control alignment. So this is the chart where we mark the patient for making our diagnosis. Is it an infection? When we do all these 9 steps, it can help us out to maintain the integrity for the patient's diagnosis. In infection, standard workup is including blood, aspiration, nuclear scans. We can plan for 2-stage revisions. People do 1-stage revision also. There are many centers in the world using 1-stage revision. But personally, I feel in India, we are not lagging behind, but still we fear for doing a 1-stage revision. We have many factors behind it. We need a good pathology team, microbiology team, on-table cuts. So the frozen section techniques, it takes time. So usually 1-stage revision is little tough for us in Indian category patients. In extensive lag, quad structure, probably best treated with allografts. If superimposed infection, we need an arthrodesis. So tibial femoral instability, again another factor. It can be because of the medial collateral ligament, lateral collateral ligament being torn at the time of the surgery, or maybe patient has refall. There are many other factors. Patients have a fracture, periprosthetic fracture post-operatively. So it can be osteopenic bone, a notching in the anterior femoral cortex, or the pole flexion. Can be successfully reconstructed with redefined techniques or internal fixation. So we have a tibial platform, knee inflection, femoral rotation. There are many other components. How we improvise on it, that what are the implants being required. The pre-op scanning is very important for the patient. So the patient is undergoing a knife again. Going for the revision TKR, we need to understand that this is maybe the last chance for the patient to undergo for a good surgery. So we need to diagnose again. The main motto in every slide will be one, the diagnosis and the proper armamentarium should be there for giving him a new lease of life. Constrained implants are there, as little constraint as possible should be used, but when the patients usually having in the revision that MCL, LCL ligaments are lax or they're not working properly, so we have to go for semi-constrained or constrained knees. If stability cannot be obtained, progressive levels of constraint should be tested and used in the revision construct. These are the constrained knees. If there is a functional loss of medial lateral collateral ligament, if there is an inability to balance the flexion extension gap, a constraining condylar device that provides paracellular stability should be used. There are new implants, rotating hinge implants. This is not new, rather this is an old age implant, worked very successfully, but because of certain factors, that of the spinning of the insert is there, they usually cause a problem. So these are the implants. The RSK design for the short tapered control rotating stem should be used with causing a patient with bone and soft tissue compromise that may allow excessive distraction and implant dislocation. Knee is the one thing, on knee implants patient usually walk. This is the one joint where everything is loaded, from sitting, standing, lying, spine. So we have to very much construct that important musculature should be maintained thoroughly well from day one of the surgery till last. So remember, establish the cause for failure, have revision implants in backup, adequate exposure and removal, build the knee from the tibia, femur controls tissue tension and joint line, use more constraint if needed, rotating hinge for gross instability and bone loss. How to manage bone deficiency in TCAR? It's a very big chapter in the life. So I'm not going into this. We need to know how to successfully denote it. What is the cortical rim? What are the classifications for it? Is type 1, type 2, type 3? What are the sleeves and the bone or wedges being used? So we have to plan accordingly. It's not like patient comes in the OPD and we plan it for the revision TCAR. Tomorrow we are doing a revision TCAR. You cannot go like this. It happened with me alone. When we are not ready, we make mistake again. So the structural bone grafts, screw within the cement, metal wedges, processes, they are all the tools. Again, this is not implant. Implant is what we use inside the body. They are the tools which helps the patient to bring back to the mobilization. So no progression of people reduced resistance was seen over 7 years in 25 in which screw augmented cement was there. This is a Vincent insert technique, how we go about doing for perfect TKR. So I'm just fastly going to the time is over. If the defect cannot be corrected, level the irregular bone surface with a burr to allow minimal graft force bone acquisition. So important how the placement of the implant is being done. It is best to be seen on the OT table. It's easy to say everything here, but it's difficult to produce on the table. So these are metal wedges which is being used in the bone deficiencies inside the tibia whenever the revision is being done. So we should know how much metal has to be done so that less chances of infection should be there. The armamentarium should be there in the OT to maintain, to do a good revision surgical. Revision TKRs using metaphyseal bones and sleeves are the construct nowadays. We are using all these constructs and the bone deficiency is sometimes so large that even the metal wedges are being poured inside and we have to use the same at that time. Many papers have been published so far for this and results are being ultimate and enabling days of life. Most modern total knee systems employ modular wedges and blocks that can be attached to femoral and tibial component to compensate for multiple bone deficiencies. A surgeon can literally build a custom process in the operating room for a given defect or combination of defects. So there is nothing, one thing that you have to do, this is the protocol. In orthopedics, in joint replacements, there is only one rule. Give best to the patient. How you do it, it's your choice. The failed primary TKRs, total replacement in patient with a severe varus deformity was done. This is a 56-year-old male operated with total replacement right side 6 years back in 2016. Everything was fine until December 22, when patient started with pain and swelling in the right knee joint. Looking at the previous X-ray approximately 1 year ago, within 1 year time period, the joint was into varus like this. On imaging of June 23, previous implant failed, completely lost a fight of middle tibial condyle, leading the knee joint to severe varus deformity. If you see, the varus is so much, the implant went into so much of this that the total tibial component went below the tibial tuberosity. And if you cut just like this, so important was the pre-op scanning was not done properly. Then there is a problem that you don't have metal wedges accordingly into the OR room, and you can make a mistake again. But sometimes you have to bail out yourself to do a better thing. So patient evaluated for aseptic losing and septic losing accordingly, whether it's an infection or non-infection, osteopenia, patient had a fall or not fall, because within 6 years of time, the patient had failed with a primary surgery. Pre-op images, the total varus you can see. So this was inside, when I went inside the OR, I could see the tibial was so, taking the tibial component out, the wedge was totally down slope till the tibial tuberosity. So there was no place of wedge to be put on. So I have to take the the lateral side one to that level. When I went in, the joint was totally down. The tibia was going before the tibial tuberosity. So putting a metal wedge there was a good option or not? I'll tell you. So went into this. Hole was definitely not sitting very well onto the tuberosity. It would have failed. Different sizes offset were done accordingly. This was the implant. It was on the backup side, but have to use both the 10 tibia. The stem. The last insert, which we get for 24, in a specific implant was used, and luckily I could bail out myself with this last insert, and patient is happy today, walking nicely. This was the post-op. The very first day, with full range of motion from the insert. After 3 months, so importance of armamentarium. Orthopedics requires tool to use surgeries. It's a planning. Orthopedic country is a planning. So we have to have a good armamentarium, good planning structure inside the OT. Every patient is different. Every knee is different. Every person is different. Every surgeon is different. So it's all about expertise. What you have learned from your masters and your seniors. How to produce on the OT table is really tough. When we talk about we do this, I think we do this. It was everything, every OR, every day is a different option for us. So this is the cone being used with the metal wedges. In the severe deformed knees, patient was immobilized for so many years. But again, the patient will walk or not. I always tell my patients, if the patient will come with a stick, after the TKR, patient will go back with a stick. Coming with a walker, will go back with the walker. If patient is coming in the wheelchair, it has to go in a wheelchair, because rehabilitation is a major role which we don't do, which we don't plan, which we do counsel. So rehabilitation process is a mainstay for any orthopedic procedure to go very well. So learning message, establish the cause of primary failure, meticulous pre-operative planning and availability of revision implant, including augments, constraint, hinge implants if possible, tumor megaprocesses, it should be at the backup. Adequate exposure and remove necrotic tissue. Try to maintain the joint weight as much as possible for the preserve soft tissue. If you ask anything about infection, so I think that's a different role story. We have to tell our patients infection can happen anytime, it's not a naked thing. So how to do our best is to counsel the patient for everything. That counseling makes life very easy. We have recent ones in with hip replacement. Not much people are doing computer navigation in hip replacement. Conventional surgeries are same accordingly. Now there is no difference between computer navigation and hip replacement as well as the conventional surgeries. Revision hip have new advances like multimodular stems in femur, patches in acetabulum, which have given us a new lease of life in doing a total hip replacement accordingly. Dual mobility cuffs, old but a good rescue, improved range of motion. We have navigation in hip replacement based on pre-op imaging, which has the version and inclination of cup sizing of the femur. Specialized femur component for replacement for variable length as there. We can easily get a bailout going for the hip replacements. Wedges for the defect management, and so if we are doing the revision hips, so we should have to see for the acetabulum part whether they have been using correct wedges, it should be implied. We have nowadays the 3D complex for the acetabulum. We get a 3D CT done to rule out how much component can be seated very well or not. So diet and care approach has been used. Thank you.
Thank you, Dr. Kuldeep, for a very enlightening talk. I would say, are there any questions from the audience? Because there's a lot of interest recently in robotic TKRs. Society and even the doctors are confused how the robot is helping in achieving something, whether it is actually achieving something or it is just a marketing tool. So the answer to that, any comments, Dr. Kuldeep, and then I will give some.
So, both the things are correct. It's 50-50. It can be a marketing tool also. It is giving better to the patient also. Importance is indication of using a robot. Wherever required, it should be done.
Yeah. So the basis behind coming of a robot was that when you do a TKR, suppose you do 100 TKRs, out of 100, almost you found that 25 to 30% patient, even they were walking, but they were not happy. So what was the reason behind it? So then the technology came in, it started with navigation, then robots came. So a happy TKR is a well-balanced TKR. And what that balance means that the knee should not be too loose, it will fail very fast, as you have seen some x-rays. And the knee should not be too tight, that is even worse because patient will be too stiff and he will not be able to move around. And again it will fail. So what the robot or any navigation tool is doing is that you are fine-tuning that ligament balance, which are on the sides of your ligament, the collateral balance. So once you accurately balance your ligament, your patient's rehab becomes very less because of the movement. He achieves a pain-free movements earlier, so his pain is less. It is not that robot is creating something which is leading to less pain. It is just the balance which you are ensuring during surgery that leads to less pain post-operatively. The scar size is almost the same. Even there are some risks by doing a robotic TKR which are most of the time not explained to the patient, that you need pain trackers going inside your bones to assess that area of your joint, and that can fracture or cause infections. So you have to be very careful in selecting those patients who are actually ideal candidates for a robotic TKR. There are some absolute indications which Dr. Kuldeep rightly pointed out, that if there are previous implants in the knees, there are deformities in the femur and tibia, there are some issues in the hip. You want to see everything because a robot tracks the hip, the knee and the ankle, gives you the alignment correctly and then tells you what is the right balance in the implant positioning for that patient. But you have to be trained to do a robotic TKR. It is not that if a surgeon has a robot with him and he'll always give a concession repair. And another interesting area which is now coming up, which started late in this country, is the UKR, which he mentioned passingly. Again, it's a very interesting area, but again it needs to have a long learning curve for that surgeons. Because doing a UKR is much more difficult than doing a TKR. And UKR patients, most of us don't realize that at least 30 to 40% patients, they actually are candidates for a UKR, but they are being treated with a TKR. It is just because the procedure of TKR is more standardized, more surgeons are trained for it. But a UKR allows you kind of a rehabilitation which allows you squatting, cross-leg sitting, which is not most of the time possible after a TKR. So there are many perspectives to it. The right procedure for the right patient is I would just conclude by saying that. Thank you.
Thank you, Dr. Kuldeep. Thank you so much. And I thank my chairpersons also. I request my chairpersons to honor Dr. Kuldeep. I request Dr. Parveen Bhatia to come on the stage and honor our chairpersons. our last session before lunch is obesity, so you eat less. And our speaker is none other than Dr. Paradita Pradhan from Max Dwarka. She is a senior consultant and endocrinologist. And the chairpersons are Dr. Praveen Bhatia, Dr. Bhatia will be there, Dr. Dinesh Kumar, and Dr. Vikas Sharma. Please come on the stage.
And let's say
Dr. Prajita is going to talk on the management of obesity, stepping up the management of obesity, semaglutide 2.4 mg. She is senior consultant with the endocrinologist with the Max Hospital, Dwarka. Kindly contact Dr. Prajita.
Thank you, sir, for the very kind introduction, and good afternoon, everyone. So, this is just everybody is talking about this new kit on the block, that is semaglutide for management of obesity. And we need to understand why it is important, not just for the physicians, but for each and everyone in a medical profession, because an obese person actually lands up with a lot of comorbidities to all of our OBDs. They can land with osteoarthritis, they can land with PCOD, to dermatology for infertility, IVF. So obesity is a major problem. It's an epidemic now. And it has been there for long, but now we are discussing more because we now have very strong pharmacotherapy to tackle it. So obesity, is it that simple? Is it just about having less energy and increase in energy expenditure? No, it's not. It's a very complex and a chronic condition, and there are several factors that contributes to it. It has a very strong biological contribution, genetics, psychological, social health, and economic inequalities. So we know that the food that causes obesity is always cheaper than the healthy food. Medication, a lot of antipsychotic and a lot of other medication like steroids can lead to obesity, and environmental unhealthy eating, the pattern, sedentary lifestyle, which is, so there are several factors of obesity, and it's not a very simple condition, and it has to be handled as a chronic condition. And brain forms a very important role in regulating our appetite. If you talk about appetite regulation, there are mostly three important pathways. One is eating for hunger. That means that is a homeostatic mechanism. We feel hungry, we eat it, so that is the homeostatic, and that's very strictly controlled by the endocrine feeding pathways. Second is eating for pleasure. That is regulated by the reward system in the brain, that is hedonic eating. And third is that is a frontal lobe that indicates that behavioral deciding to eat, that is the executive function. That is self-regulatory process that influence the eating. So it is affected by different signals and areas in the brain. And over the years, we now have a pretty good understanding of the biology pertaining to the brain and about the regulation of our appetite, and that had led to development of several molecules as well. So if we talk about the role of brain in regulating the appetite and talk about the homeostatic eating mechanism, so it is governed by several hormones, mostly the GLP-1, PYY, oxymodulin, pancreatic polypeptide, amylin, insulin, leptin. All these hormones, some of them are secreted from the intestines and from the pancreas, and they all help in increasing the satiety, therefore decreasing the appetite. On the other hand, we have ghrelin that increases the hunger, and there is strict balance between these two to regulate our behavior to eating if we are hungry. Second, as I discussed, is hedonic eating. That is eating for pleasure, that is a reward mechanism. It regulates what type of food we choose to eat that makes us happy. And that dopamine controls the wanting and the motivation and the drive to eat. And we have opioid and cannabinoid receptors control the linkings of pleasure associated with food. And they're having several a lot of discovery within this field in which the anti-cannabinoid receptor have been developed for decreasing this controlling our eating for pleasure regulation, but they were actually had very much side effects, so it never showed up. And the third one, that is our executive function, the frontal lobe, what we and how we decide to eat. And therefore, behavioral intervention empower the sustainable behavior control in controlling eating. So some part of behavioral modification is also very important to manage this chronic and complex disease. And if you talk about lifestyle innovation, that of course is the foremost, and it forms the base of any kind of chronic weight management, but how effective it is. So we have very long-term studies that have been going on. So immediate low-calorie diet and increasing the physical activity does help in weight loss, but is that weight loss is maintained over the years? That is not the case. So weight loss following lifestyle intervention is usually not sustainable in long term, and most individuals regain around more than half of the weight within 2 years and around 80% within 5 years. And the lifestyle intervention, as you've seen, it usually results in modest weight loss, not much, and most of the individuals around 5%. But it does stop at some point. So losing and maintaining weight loss with diet and exercise alone is a very constant struggle. A lot of people juggle with it. So they have to count their calories and accordingly increase their physical activity. And there are several, metabolism, hunger hormones, and fullness hormones. They usually form a stagnant point at which further weight loss usually doesn't happen much, and even the weight gain start happening at some point. So despite best efforts, metabolic change to weight loss promote weight regain. Now, this has been recently launched in India, Wegovy 2.4 milligram. It's injectable semaglutide. So semaglutide has been there for a long duration. It was not launched in India, but it has been in US, and it was initially launched for type 2 diabetes in 2017. And later, at a higher dose, injectable semaglutide launched for even weight loss. And we have a very large data for individual who has already been on semaglutide. In India, of course, it has only recently been launched. So Wegovy is a semaglutide in the maximum dose of 2.4, that is the ideal recommended dose for obesity and chronic weight management. And it's a GLP receptor agonist that works in the key areas of the brain to help control the hunger and the craving. So mind you, there are two things that are getting controlled. It's not just the hunger, but also what we decide to eat. So it also regulates the craving. And semaglutide is a human GLP-1 analog. It has around 94% homology with human GLP-1. So we had GLP-1 for around 20 years now in pharmacotherapy. The earliest one was exenatide, but it had less human GLP-1 homology. But this is very close to what we have, and it has long half-life around 1 week. So the dosing is around once a week, and it acts on the GLP-1 receptors in the brain for controlling the appetite, directly activation on the hypothalamus, and also several areas on the hindbrain. So it controls the homeostatic regulation of eating, that it decreases the hunger, increases satiety, therefore makes the patient less hungry. And it also has a hedonic regulation, that it decreases the food craving and preference for certain food. And there have also been a lot of studies that have been going on that it also may contribute to de-addiction of alcohol as well. So that has also been a personal experience in few of the patients. So Wegovy has been assessed in multiple phase 3 trials involving more than 26,000 individuals now, and in worldwide over 8 million people have been prescribed semaglutide containing therapy. And these are the series of trials that has been with the semaglutide. The STEP trial is injectable semaglutide, initially starting for just obesity, starting from step 1 to step 11. We also have step teens, and we should know that semaglutide is approved, injectable semaglutide is approved in US for even adolescent obesity, but not yet approved in India. Now, the SELECT trial is for obesity and cardiovascular outcome. We have heart failure trials, in diabetes, NASH trials, and also higher dose semaglutide as up to 7.5 in obesity and type 2 diabetes. So we have a very, very large data about, if we talk about using this molecule. And it has also been extensively studied in Indian population. So if we talk about all the studies, we had around, the Indian represented around more than 3,500 participants from India. So in step 1, that was the first one in obesity, we had around 117 people represented from India. And here we can see that it's not the case that we don't have Indian data. We do have Indian data and quite good. So this was the initial first step 1 trial that was to compare injectable semaglutide Wegovy 2.4 in people with obesity or overweight as compared to the placebo, and it had around 1,961 participants, and they were started randomized to injectable semaglutide starting with a dose of 0.25 for a month, and it was step of 0.5 for a month, 1 milligram for a month, and 1.7, and the maintenance dose of 2.4, and it was achieved over a duration of 16 weeks. And the primary endpoint was person weight loss, and the responders who had at least 5% weight loss. And they also looked into secondary endpoint, that who were the number of people who achieved weight loss of 10 to 15%, and what was the difference in the waist circumference, systolic blood pressure, the SF36 physical function, and other quality of life parameters. So if we compare to the lifestyle intervention alone, so the lifestyle intervention that was done in this trial was at least 500 negative kilocalorie diet along with guided physical therapy. And what it saw was, at the end of the trial, there was around 16.9% weight reduction with 2.4 milligram of Wegovy. And clinical meaningful weight loss was achieved in majority of the individuals. So around 1/3 of individuals had around more than 20% weight loss. That is very, very significant. And several other health parameters also improved, that several severe risk factors like the waist circumference, systolic blood pressure, the quality of life questionnaire, and HbA1c, diastolic blood pressure, and the C-reactive protein. That is a marker of inflammation in obesity. So this was a step 4 trial, which showed that what will happen when we draw the injectable semaglutide. As compared to individuals who discontinued it, the people who continued it to the end had around 80.2% weight reduction, but there was a weight regain that happened after discontinuation of injectable semaglutide. And if you talk about the long-term maintenance, over 2 years, so there was significant weight loss and maintenance after continuing this therapy over the duration of 2 years. And the second was the SELECT trial that I believe will be discussed later today. That was in individuals for about the cardiovascular CVOT trial that was for the duration of around 4 years. Now, if we talk about the safety profile with the Wegovy, the most common is actually the GI side effects that are mostly mild and moderate, and are mostly transient and usually starts when we start the therapy or we up-titrate the dose. Most common being the nausea, vomiting, less diarrhea, and constipation that actually might be chronic. And the fatal adverse events were actually quite comparable and not much. And to summarize, the STEP trial, it actually helped in achieving more than 20% weight loss in a majority of the individuals who were started with obesity or overweight. And the effect was sustained up till 4 years of the therapy. Thank you.
Thanks. Thank you, Dr. Parita, for such a nice talk. I have one question. Recently, some vision problem side effect has been associated with the semaglutide drugs, NAION. So how many patients you have seen, and what is the prognosis after the patient has this type of problem? And just let me know, have any experience?
So non-arteritic anterior ischemic optic neuropathy has been a risk factor, like a rare side effect of using GLP-1 based therapy. It, diabetes itself is actually a risk factor for that condition, and there have been very few studies that has quoted that because it uses GLP-1, but I haven't seen any case as such.
You haven't seen any?
So FDA is also a very rare side effects.
Is it temporary one or is it permanent after the patient has this fact?
No, it's not a temporary one. It does affect your vision.
I have a small question. One question more. If a patient wants to stop injectable semaglutide, if we shift to oral semaglutide, then what do you say about that?
So it's mostly the effect of the dosing. So if you talk about the injectable semaglutide as compared to the oral, so around 1 milligram of injectable semaglutide is equivalent to 14 milligram of oral semaglutide as a doses. So we really have to do a long-term studies to see when we try to down titrate the injectable semaglutide, can we shift such patients to oral that can help them in sustaining the weight loss once you stop injectable therapy.
We can sustain the weight loss after shifting to oral.
It's a very nice presentation, short and crisp. I just want to know one thing. Obesity is highly prevalent. 5% of US youth are obese. And see the magnitude of disease and how will you offer it to almost each and everyone, which is out of question. Right? This is not primordial prevention or the first stage of prevention. You start giving a very costly drug. We do not know how long to give these all young people. Right? So it's a very, tell me, is there any means, molecular means or otherwise, to know which type of obesity is bad? And which is likely to progress to comorbidities? Is there any molecular way of finding out that this obesity is bad, that I want to treat this as a priority? See, we have to decide priority. We just can't treat obesity left and right. And secondly, I object to this, whether you can achieve 20% weight loss, 25%. Our job is, as a physician, my job is not to achieve 20%, 25% weight loss. My job is to achieve 5% or 10%, depending on what comorbidity patient is having. I go for that. This gives the impression that it is as good as bariatric surgery or otherwise, right? But that kind of magnitude of weight loss, 20%, 25%, is meaningless as far as we physicians are concerned.
So we need to know how we define obesity. The most common criteria used is BMI, but we know it's not the ideal one. We have, now we know that it's actually the adiposity that is worse, rather than just talking about the weight and the BMI. So if you talk about, of course, because we have to think in the long term and the comorbidities as well, we cannot offer it to all individuals, but we have any such individuals who are actually struggling with weight loss. We know that this person will benefit very significantly with just 5% or 10% weight loss. We will be able to stop a lot of his anti-diabetic medication. He can go into remission. He can be off his antihypertensive medication, and the cardiovascular risk factor is going to decrease significantly. Then, of course, we should offer such individuals.
Just wanted to know about molecular basis of any future development of.
I think we should discuss it on lunch. Thank you so much, Dr. Paradita. Thank you so much. And thank our chairperson also. Our chairpersons to honor Dr. Paradita. Dr. Manish, please come and honor our chairpersons. We are all running late. I think we should rejoin in 20 minutes time. 20 मिनट में आप लोग आ जाइए तो आगे का शुरू करेंगे. Thank you. Yeah. We break for lunch, right?
लंच के बाद 4-5 और. फोन दे देना। वो आपने लगाया था, उसका लड़का चला ही गया, चार्ज ही नहीं हो पाया आपका, थोड़ा सा हुआ 3-4। मैं भैया आप जाओगे बाहर खाना खाने? प्रीसेट 1 नंबर पे बैनर है ये, और ये 3 नंबर पे 2 बार प्रेस कर दो, ये आ जाएगा।
अच्छा, पोडियम।
हाँ, ये पोडियम 3 नंबर पे पोडियम है, 1 नंबर पे बैकड्रॉप है बस।
ठीक है।
दिलशाद भाई के पास एक कूपन है, जब ये कूपन में खा लेंगे दोनों। जाए लिया। अच्छा जा रहा हूँ, डाटा उठा इधर क्या है कि पाई जा ये मिला तो है 3 बंदों में एक दोनों सही है लोग। भाई आपको कैसे कैसे लौंडे पसंद आ जाती है। भाई आपको कैसे कैसे मंडिया पसंद है? क्यों खराब है क्या? मैं अपनी 10 आंखों से भी देखूँ ना, मैं अपनी 10 आंखों से भी देखूँ ना, तब भी मुझे एक आंख नहीं भाई। अरे भाई कौन सा मैं भी आता हूँ। चिपले दे दिया। जा रहा था। खाना तो खा लो भाई साहब। वो कूपन सन्नू को पेपर है, तुम्हें खाना नहीं खाना? कूपन तो दिया। अरे आ जाओ जल्दी जाओ। अभी तो होल चल भी था। इस कैनिंग में कौन बैठा? यस ही तो है। यस ज्यादा वहाँ पे वो तो वो दे रहा है ना। क्या बैग अंदर है हॉल में? यस जानता है, आपको चले जाओ। अच्छा है। अबे स्टार्ट हो जाएगा दोबारा। जा बोल रहा हूँ, ले आ जाके जा। अबे कितने रह गए यहाँ? कहाँ है वो? दिलशाद भाई के पास से लेके आन, फिर चलते हैं दोनों खाते लंच।
चल अबे मुझे क्या तेरा चल ना
एक सेकंड बस एक मिनट चलिए हाँ यार भाई पता नहीं कहाँ चले जाते हैं। खाना लेके आऊँ प्रीतम भाई भी। कौन? प्रीतम भाई और क्या?
दो टेबल लगे ना जहाँ पे एक पोस्टर लगा।
हेलो हेलो कहाँ? आ रहा हूँ आ रहा हूँ आ रहा हूँ।
कर रखा है, लॉक कर रखा है। इस वाले उनका पहले खत्म हो गया। ये वाला पॉइंटर भी महंगा आता होगा ना? आजा कोई नहीं है। तो क्या मैं उठ जाऊंगा। टैब जो है M2+। देखो रहा है चीता उठ ये फायर नहीं मैं तो उठ जाता हूँ भाई। पहले कहा था ये चल गया उसके बाद नहीं उठ पाएगा होता रहेगा वो जाऊँगा बिरयानी कुछ भी नहीं संडे आज कोई इशू नहीं।
चलो फिर चल खा लीजिए
संडे एक बिरयानी वाला कर दो बस। जिससे मैंने भटूरे खाए थे ना उसके बिल्कुल सामने खड़ा है। पास ले जी और ये वाला बंद है इधर से निकल जो सामने जो कांच का गेट है ना उसके सामने
पैकेट करा पाएंगे।
क्या आपने जिसमें टाइमर डाला है ये टाइमर अगर कॉपी करके किसी और में डालूंगा डल जाएगा ये?
हाँ हॉल में। ये कौन सा हॉल है? इसके पीछे वाले।
खाली है ना हो गया। हाँ कब स्टार्ट करो। अभी पूरे केबल को टेप कर दिया
क्या? अरे भाई क्या करूं?
अरे ये इसको तो हटा तो दे यार।
हाँ इनके उसमें है लंच ब्रेक
ये सेशन अब किसका है इसका डॉक्टर मुंद्रा
अनार ये 4 प्रेजेंटेशन
अभी कौन
यहाँ से स्टार्ट है
इसके मुंद्रा का हो गया
नहीं अभी यहाँ से स्टार्ट है
यहाँ से स्टार्ट है तो इनकी लगा दो यार फटाफट यार लेकिन स्लाइड तो वो इनका क्या स्लाइड डेस्क तो होगा
हाँ
स्लाइड पे लगा दो
अभी लगा दो
नहीं इतने सही लोगो तो होएगा कुछ इनका स्लाइड डेस्क में इनका सीवी वगैरह तो होएगा
सीवी आप कह रहे हैं
मेरा लैपटॉप मुंद्रा का है
साके इनका अच्छा साके इसके
ये लगाओ पहले
एनालिसिस इनको अनाउंस किया जाएगा तभी हाँ
बोलना मैं याद कर रहा था
Good afternoon. Another 5 minutes we started. Those very frequent. Another 5 minutes. Thank you.
Good afternoon, everyone. I invite everyone to come inside, please. I request everyone to please come inside the hall.
रेडी है ना?
मेरा थर्ड सेशन है, ये लैपटॉप है, इसी को लगा दूँगा डायरेक्ट।
मैं क्या सर?
नहीं, नॉर्मल लैपटॉप है।
विंडो यहाँ लगा देंगे।
कहाँ लगाओगे? वहाँ पे
वहीं पे लगाएंगे। सर अगर आपके पास पेन ड्राइव है तो
पेन ड्राइव नहीं है, एक्चुअली वीडियो है, वो चलते नहीं है सर।
ओके।
एक बार आप चेक कर लो। खोल दूँ मैं? जी NTPF
चल जाएगा सर। चल जाएगा। इसमें चल रहा है ना?
बढ़िया चल रहा है, एक नंबर पर। ये देख, ये देख। चल रहे हैं ना,
ठीक है सर, ये हो जाएगा सर।
तो
आप
ये क्या
साउंड चाहिए
करूँ?
आपको?
हैं?
साउंड भी चाहिए?
साउंड नहीं है इसमें। साउंड नहीं चाहिए, तो ये क्या करूँ मैं? ये आपके पास छोड़ दूँ?
सर आपकी टर्न आएगी तो मैं आपका वो बुला लूँगा, ये ना
हाँ, इंदर मंचू।
अभी चल रहा है स्टार्ट।
तो क्या करूँ इसको, स्केप कर दूँ?
क्या है इसके आप अपने पास रखिए, आपकी टर्न आएगी ना तो आप लैपटॉप लेके आइएगा, हम कनेक्ट करेंगे।
मोतीलाल ये आएगा, इसका पासवर्ड बता दूँ तेरे को?
नहीं नहीं, इनको बता दीजिए।
ये इसको कैसे है, ये तो आता नहीं इसको चलाना, तो तेरे को दे दूँ, कहीं लिख ले।
सर आप खोलेंगे ना?
तो लिख ले 5678 डॉट ए कैपिटल है, लिख ले यार।
क्या है? 5678
डॉट ए कैपिटल,
ओके,
RJ बस ए कैपिटल है, अर्जुन डॉट ए कैपिटल।
Good afternoon to all of you. Post lunch, please. Now start the session. Next session.
ये रख ले। अभी तो मेरे को लगता है 30 मिनट लग जाएंगे, 2 लेक्चर हैं।
Please come inside the halls.
नो सर 20 मिनट्स।
Please come inside the halls.
30 मिनट्स लग जाएंगे क्वेश्चन।
So next session is about to start. Dr. Rajnikant and Shastri, the next speaker.
अभी भी 10-10 मिनट के हैं सारे।
है 15 मिनट का लगा 10 ही मिनट रहा हूँ जानबूझ के। ये स्टार्ट होना था 2:20 पे, 3:30 हो गया।
1 घंटा डिले हो गया, कवर हुआ था 1 घंटा पे डिले हो गया।
लंच के चक्कर में।
Good afternoon to all of you. So post election, now I am about to start the session. Dr. Rajnikant N. Shastri is the speaker of this session, and the chairpersons are Dr. A.K. Sulekha, Dr. B.K. Agarwal, and Dr. Shashank Bharadwaj. Please chair the session. Dr. A.K. Sulekha, Dr. Shashank Bharadwaj, and Dr. B.K. Agarwal. Please. Now, mic over to the chairpersons. Please.
Thank you. It's a real honor. Finally got a chance to talk about the select trial, especially the cardiovascular procedure. So, I'm basically a preventive cardiologist, and my job here is to basically, as I said, you might think that why am I talking about Wegovy over here? So, I will be starting off with exactly explaining that as per 2019, around 71.13 million cases of cardiovascular death were from India. It's around 93 million right now, as per the latest data from Economic Times. Around 28% of the total deaths were contributed by cardiovascular diseases. And right now, current state is that India is the third largest population of obesity in the world, with just behind US and China, as per the WHO estimates. Around 254 million adults generalized obesity, 351 million adults just of abdominal obesity. So 24% of all cause deaths in India are caused because of cardiovascular disease. So what I want to show you in this graphic, you see is that both cardiovascular disease and obesity, 70% of the deaths are caused due to cardiovascular disease. And although the cardiovascular mortality has decreased over the past 2 decades, overweight and obesity related cardiovascular disease have actually increased fourfold, as you can see from the graph over here. So this is a very interesting slide. It is basically showing that obesity
or being overweight is an independent risk factor for cardiovascular disease. So what they've done is they've basically taken up 3 metabolic abnormalities, and that's basically diabetes, hypertension, and dyslipidemia. And they tried to create something known as a metabolic score, a metabolic abnormality score, ranging from 0 with no problems, 1 with only 1 of 3, 2 and 3 as advanced. So if you look at the graph, the weight class on the extreme right side, if you see, they've actually circled in blue the number of metabolic. If you see in the normal weight, overweight and obesity with no risk factors, coronary artery disease, as your weight goes up, it is floating more and more towards the positive side. So whether that is coronary artery disease or cerebral vascular disease or heart failure, after a certain time, once you cross into the obesity zone, it is obviously getting worse. And these are all adjusted hazard ratios. So what I want to tell you is that actually if you decide to define obesity, it is a chronic relapsing disease which is a gateway for a range of other non-communicable diseases. So there is something known as a metabolically healthy obesity where he's not a diabetic, the patient is not a hypertensive, the patient's HbA1c is around 5.7 or less, the pre-diabetic range, and you find out that there is a 38% higher risk in those who are metabolically healthy and who had a normal weight, that is their BMI, as they said, was less than 27. And this was associated in these healthy obesity, almost 65% had an increased risk of heart failure. So that means for every metabolically unhealthy obesity, if you keep that aside, they're almost having a 2 times risk. So if you look at it, metabolically healthy people, that is people who are non-diabetic, non-hypertensive, have normal cholesterol, good HDLs, they still, with obesity, they will have a very high burden of cardiovascular disease. So ideally, that means we should treat obesity as a chronic disease rather as considering it as a byproduct of hypertension, dyslipidemia. It should be treated separately. So now, we know traditionally weight loss does improve traditional factors, but what we have to remember is weight loss is very difficult to achieve. The most common method used by a lot of influencers and nutritionists is to do something known as a caloric deficit. So they try to reduce your calorie requirement by 100 or 200 calories depending upon your weight. The problem with this process is the minute you stop doing it and you try to return to your normal eating habits, you put on weight again. Within a year, you're possibly back to 65% of what you lost. The only gold standard which has been proven to be absolutely, which has allowed people to reduce weight is bariatric surgery-induced weight loss, where, as you know, it is the gold standard. So otherwise, apart from that, there has been no effective strategy to reduce weight for cardiovascular risk reduction. So there have been a lot of trials, I'll not go through them, they will take time. So you had the sibutramine trial, unfortunately, a lot of heart failure disease. You had Crescendo trial, stopped early, and a lot of these ones. The only one which has been successful right now is the Select trial. As the speaker before me did say, around 500 odd patients were actually from India. Otherwise, there were about 17,604 participants. Originally, it was 17,605 as per publication data, but one of them was randomized erroneously twice. So it's down to 17,604, and they all had at least 3.5 years of follow-up in more than 40 countries. So they defined overweight obesity as any kind of BMI more than 27 kilograms per meter square, age more than 45 with a history of established cardiovascular disease. So by established, I basically mean that a heart attack within the last 2 months, a stroke within the last 2 months. So, and also they had no prior history of any kind of diabetes. So most of their HbA1c was less than 6.5. You can say they were in the pre-diabetic range. It was a randomized controlled trial, and in which they were giving placebo plus standard of care, followed by Wegovy 2.4 milligrams with standard of care. Standard of care was basically going down. Yeah, standard of care in the Select was basically controlling the lipids using statins, blood pressure. Most ACE inhibitors were used, but in general, the preferred one were ACE inhibitor followed by calcium channel blockers, and then of course beta blockers. In beta blockers, basically it was the vasodilator ones: carvedilol, labetalol, nebivolol. Antiplatelet therapy as needed, and of course glycemic control to those people who develop what you call type 2 diabetes mellitus. Now, the lifestyle guidelines were basically a calorie deficit, advised them to increase physical activity as per WHO. Getting them to stop smoking and getting them to restrict alcohol consumption. So the baseline demographics, if you see the Most of them were male, 70% were male, and they were having an average age of 61 years. Most of them were white, Caucasians, and then after that it was Asians. And by cardiovascular inclusion criteria, majority you can see over here, around 70% were MI, heart attack only. So the clinical characteristics were, as I was saying before, the mean HbA1c was 5.8 and below. So around 66% were actually having pre-diabetes, and the mean BMI was 33.3 kilogram per meter square. So obviously they made sure that you are overweight. Otherwise, most of the distributions was obesity only.
भाई model कौन सा है?
And chronic heart failure obviously is not much of it known because still study has to go on. But 24% of the entire study was based upon chronic heart failure. So I've already. So the drugs they were on are basically, most of them were on 3 types of drugs. They were on platelet inhibitors, aspirin, clopidogrel. They were on statins. They were also, then after that you had beta blockers obviously for cardiovascular disease, ACE inhibitors. If they were not tolerating, then they were switched to ARBs. And then of course finally followed up by calcium channel blockers. Now if you look at the graph over here, this is a very interesting one. You will notice that right from the beginning itself, the Wegovy curve is starting to move away very fast from the placebo curve. So now the question is, right now, this is the only first anti-obesity drug which is showing there is a proven MACE reduction in patients with overweight and cardiovascular disease who do not have diabetes. So you can see the graph is splitting very fast. So ideally, as per the ESC guidelines, they are now suggesting that it should be considered in patients with overweight or obesity and chronic cardiac syndrome without diabetes to reduce the cardiovascular mortality, MI or stroke. So the CDSCO is right now given it a label saying that yes, it should be used to reduce the risk of MACE in adults with established cardiovascular disease or having a BMI of more than 30. Now again, if you see, there is the split between both the lines, you can see it's splitting off pretty fast off, suggesting that before even the maximal weight loss was achieved, cardiovascular proportion is actually coming down. So that means there is an 80% already MACE risk reduction just by Wegovy without considering about weight loss. So what we're coming to think is that possibly the MACE reduction in Wegovy is independent of changes in the body weight. So again, this is the same thing, that there was a composite reduction in heart failure also in Wegovy group as compared to placebo. So then again, this is basically showing the benefit doubts across almost all forms of major adverse cardiovascular events, from cardiovascular death, expanded MACE, all-cause mortality. You can see most of the time it is sticking to the left, which is suggesting that yes, it has a beneficial effect. So if you look at it, as per SELECT trial, there was a 39% reduction in HSCRP. Your good cholesterol, the HDL went up, your total cholesterol, the LDL, and of course the triglycerides and the non-HDL went down. There was a 0.31% reduction in HbA1c. There was almost a 7 centimeter reduction in the waist circumference, and of course there was 11% reduction in weight. On an average, when you start off, there is about a 2 to 5% weight reduction in the first month, and then they're saying that almost up to 15%. It's not common all over the place, but up till 15% of the initial weight is lost at the end of the entire thing. So again, this is the same thing. This is showing again that there was a reduction in HbA1c by the week 104. It's actually come down to normoglycemia. This is on the 2.4 milligram. So as you see, there was a risk reduction of almost 20% by MACE, and it had a conventional. So the question is, what I'm trying to say is that despite the standard of care, the risk of cardiovascular events remains very high in patients with cardiovascular disease obesity. There is an unmet need that we have to find out how to reduce weight in these patients, and currently there is only Wegovy right now, semaglutide in injectable form, which is actually showing a proven reduction of 20% MACE. Thank you.
Thank you. Any questions in the audience regarding semaglutide? The same results, Shastri, the same results of semaglutide in view of reduction of the all MAC cardiovascular. In other studies also, later on any other studies, same results.
This is basically just for weight loss and nothing else. We're trying to prove that Wegovy, if you take weight loss away, it is still having a beneficial effect in reduction of cardiovascular. Non-diabetics, yes.
Any other study except the select study?
Currently, this is the main study which is still going. We don't have anything for heart failure, but we are planning.
Thank you, sir, Dr. Shastri, for delivering a wonderful talk on this topic. And just wait, sir. I request to chairpersons to felicitate the speaker. And now request to Dr. Gitanjali, okay, come to felicitate our chairpersons. Please come. Dr. Gitanjali, please come on dais for felicitate our chairpersons. Thank you, chairpersons and speakers. Now we'll move the next session, that is tackling insulin initiation, hurdle with the premix, Dispro and premix. So speaker for this session is Dr. S.K. Mundra, he is the senior consultant physician and HOD medicine, Saroj Super Specialty Hospital, Rohini. Dr. Mundra, please. And for this session, chairpersons are Dr. Rahul Jain, Dr. Manka Goyal, and Dr. Manish Mathur. And mic over to chairpersons.
Okay, so we have Dr. Mundra here. So we'll be discussing on tackling insulin initiation hurdles with premixes, that is list for premixes, and so we'll enlighten on this topic.
Thank you, Dr. Manish. Good afternoon, friends. I'm going to discuss about insulin, rather premix insulins. What is the role in our country? Type 2 diabetes disease, as you know very well, progressive chronic disease. Most of the time we are treating to failures. As HbA1c goes up, you start one drug, again after some time, again there is a failure, you add up, and finally 30 to 40% of people with type 2 diabetes will require insulin sooner or later. This is disclaimer. So, the delay in insulin initiation in our country. There was a study and it found that almost 8 to 9 years of delay in initiation of insulin. You know it very well. This beta cell function is 50% lost by the time you diagnose type 2 diabetes. And it's hardly beta cells are 25%, 20% when you initiate insulin. So most of the time during the diabetes continuum, the patient is exposed to hyperglycemia for last maybe 10 years, 15 years before we initiate insulin. And initiation of insulin is important because once you control hyperglycemia, what are you going to gain? So you are going to gain lot many things. What are those? Tight glucose control will help in beta cell protection and preservation. and long-term efficacy will be durable. It reduces glucotoxicity and lipotoxicity. Rapid reduction in blood glucose within days, and is effective in achieving maintaining HbA1c, and it has more consistent results in comparison to many OHAs. So it promotes beta cell rest, preserves insulin secreting capacity, and may slow the disease progression as well. So what are the hurdles? Why can't we initiate timely? So the hurdles may be of many types. Either it may be patient-driven or a physician-driven. The patient-driven hurdles, there are so many misconceptions in the society regarding insulin. It causes so many complications, it causes renal failure, it causes weight gain. Of course, there are some of them are not myths, it's the reality. And psychological insulin resistance, very common in our country. The fear of the needle, injectable phobia, then fear of hypoglycemia, it is of course a great concern. There are issues with weight gain, and the stigma. The patient feels that once insulin is initiated, he is a personal failure in managing type 2 diabetes. And complexity of insulin. At times you are giving twice daily, thrice daily, 4 times daily, 2 different types of insulin, basal and bolus therapy. So it is very difficult and incomprehensible for many of the patients. And there are some religious and cultural beliefs as well. On the front of physician, there are so many delay until necessary. We ourselves have to rethink, is it really necessary or is it really essential for our patient? So the clinical inertia is one part of us as well. Negative attitude and lack of confidence to our insulin initiation. Many of the primary physicians have lack of confidence whether they will be able to tell our patient rightly or so. And weight gain, hypoglycemia, of course, but you have to counsel your patient nicely. You have to spend time with your patients to reduce those complications of hypoglycemia and weight gain. And for patient education, we do not have enough support. There are limitations. Each and every healthcare professional does not have the facilities of diabetes counselor who sits with the patient and the family for 10-15 minutes and expresses about hypoglycemia, risk, site rotation, change of place, change of site rotation and all. An absence of diabetes educators and heavy workload of physicians. These are all causes. So failure to initiate or intensify therapy despite uncontrolled hyperglycemia. So Indian setting, there are almost provider-related delays 50%, patient hesitations 30%, and healthcare system barriers again 20%. So median time to intensification leads to around 7 years, which is very high. And you can see the Indian patient, though, they saw higher postprandial glucose levels before insulin initiation. As we know, we have high postprandial blood sugars because of high carb diet. You can see in comparison to other countries, India has a very high postprandial blood sugars on an average. And contribution of postprandial glucose excursions and the fasting blood glucose extent to HbA1c levels in casein type 2 diabetics using CGMs. Now we have CGMs available and we can see what are the variations, what are the variability, and you can see the HbA1c between different quartiles of HbA1c have been studied. What is the contribution of fasting blood sugar? What is the contribution of postprandial blood sugar in the total HbA1c? And here you can see significant contribution from postprandial blood sugars even at higher HbA1c, 8.5, 9, 11, 10, 12. There also, it is the postprandial blood sugar which contributes to a large extent. Otherwise, earlier it was thought that postprandial blood sugar contributes only in the lower range of HbA1c, 7 to 8.5. But here you can see in our Asian Indian population, the postprandial blood sugar contributes significantly to HbA1c levels. This was an improved trial. Indian patients who had poor glycemic control before insulin initiation. The blood indices were studied HbA1c, fasting blood sugar, postprandials were studied breakfast, lunch and dinner, and you can see the levels regarding the north, south, east and west all over India. See the levels of postprandials, 250, 300, 350. So, what are the consequences of delayed insulin therapy? Uncontrolled hyperglycemia will lead to so many complications like microvascular complications, which are well proven. Delayed insulin initiation will lead to so many complications like blindness, damage, amputations, neuropathy, nephropathy, retinopathy, all are increased. And macrovascular complications, there are some complications which have been shown to increase, like stroke, myocardial infarction, and heart failure. So how to address the insulin initiation barriers with the right insulin choice? What are the insulins you are using and how can you address to reduce the barriers of insulin initiation? Postprandial blood sugar is the primary contributor, as I said, in HbA1c with mild to moderate hyperglycemia, and fasting is the main contributor to those with poor glycemic control, more than 80% for HbA1c. So, addressing both fasting as well as postprandial glucose levels will lead to a comprehensive glycemic control. Here comes the role of premix insulins, which targets both fasting as well as postprandial, which is essential for achieving optimal glucose control. So, why premix insulin for initiation? It covers both basal as well as prandial needs. There are fewer injections. One injection can address the glycemic needs, or maybe it can be given twice a day. The same injection can be used twice a day, at times thrice. Also may be used with some patients. And dose adjustment can be personalized based on the glucose monitoring levels. The regimen is simplified, same insulin being used by the patient. And you can give them structured program regarding fasting, postprandial, and the insulin doses also. And what is the efficacy? Let us discuss premix with basal. This was Maloney et al. Trial. It was 32 weeks randomized trial, almost 105 insulin naive patients were studied in this. And what were the results? Let us see. The decrease in HbA1c was less than 7%, good number of patients, less than fasting blood sugar, very well controlled, postprandial control, you can see very well. Risk of hypoglycemia, of course, the risk of hypoglycemia was slightly higher where the twice daily mixed premix insulins were given along with metformin in comparison to glargine metformin, but higher percentage of patients treated with premix insulins attained the target blood sugar levels. So conclusion of the study was they were associated with significantly greater HbA1c reduction, enabled a larger population of patients to reach HbA1c less than 7, and improved glycemic control after breakfast and dinner when you are using twice daily, resulting in a higher overall hypoglycemia rate, but premix 25-75 provides optimal insulin starting regimens for those who seek reduced HbA1c and simplicity to use. So, in comparison, premix insulin to other insulins, you can see here in this chart, they have discussed premix, basal insulin, basal plus 1 basal or plus 1 prandial or 2 prandial, and basal bolus is full, 3 prandial insulins and 1 bolus insulin. The best part with premix insulin is easy to use, comparable to basal bolus. Fasting control is good, and postprandial also to a large extent. Risk of hypoglycemia is same in other places also. Intensification, of course, you can intensify anytime you need. So premix insulin simplifies insulin regimens. Patient's adherence is better. You can see it is good for the patient, and patient profiles best suited for premix are individuals with typically Asian Indian phenotype who respond better to premix, who have high carb diet, and those patients with baseline PPG is high in type 2 diabetes. Patients who have been a delayed starting insulin and the risk of basal failure is high. So patient selection, what are the patient selection? Duration of diabetes, longer duration of diabetes, uncontrolled hyperglycemia often requires basal bolus. Irregular meals, they can give it twice a day. In drug therapy, it can be combined with any class of drug. And next thing is, this is again a trial of durable trial where insulin glargine versus insulin lispro. Here the analog insulin lispro mixed 25-75 was studied, and it was designed almost. It was in 11 countries, 2,000 patients, 6 months initiation period was seen, and you can see the results. A modestly longer durability of glycemic control was achieved with insulin Lispro mix 25-75 compared to Glargine. Here you can see very well. So, overcoming the insulin initiation hurdles with premix, how can you initiate? The post-hoc analysis of durable study again showed that patients who achieved less than 7 HbA1c after 24 weeks entered a 24-week maintenance phase, and this study again concluded that initiating Lispro premixes even in elderly patients, superior long-term glycemic durability, more number of patients on Lispro mix 75-25 maintained HbA1c over time, and greater percentage of patients achieved both standard and stringent HbA1c control. So initiation in patients with high postprandial spikes, sometimes you can use insulin mix, Lispro mix 25-75, even 50-50, who have high postprandial, you can use one time 25-75, other time 50-50. In 50-50, 50% is the short acting, another 50% is the long acting. So you can combine according to the needs of the patient. You have to tailor-made therapy for your patient. Comparison between Lispro mix 25 and Lispro mix 50-50 as a starter insulin type 2 diabetes. Here you can see significantly more number of patients Lispro mix 50-50 achieve target HbA1c than Lispro mix 25. And comparison between Lispro mix 25 and Lispro mix 50 as a starter insulin therapy. So conclusions are incidence of total hypoglycemia and nocturnal insulin were similar in both 25-75 and 50-50. It depends on the need of your patient. Who are the patient where you are going to use 50-50? It is non-inferior to Lispro mix 25-75 and non-inferior to 50-50. So initiation patient with nocturnal hypoglycemia, you have to be careful of those patients who have nocturnal hypoglycemia. There you have to ask your patient about SMBG, you have to counsel your patient, you have to teach your patient early morning 3 a.m. blood sugar sometimes have to be done. And practical strategy will be to use mid or high ratio mixes in patient in the day, like 50-50 in the morning, 25-75 in the evening before dinner, so that you can achieve better glycemic control. And quality of life, it has been studied, and quality of life has been found to be very good with premix insulins, Lispro mix 25-75 and 50-50. And what is the role of diabetes educators? You know, I'm not going into the detail. Diabetes educators, and now we have so many digital tools and frequency contact, so many apps are there where can you train your patients how to do SMPG, when to increase, when to decrease insulin, what doses, what pre-reading, and all. I think that's all from my side. So, that's all. Thank you.
Thanks for the wonderful talk, sir. I think we have all, learned that the biggest hurdle is in initiation of insulin. I think once the patient agrees to start insulin, then we have various options to start with, whether 25-75 or 50-50. Then we have, whole a lot of insulin available with us. So the biggest hurdle is initiation. So we have to counsel several times to start insulin. We have to start early. We don't have to wait till the patient is already having microvascular and macrovascular complications, as informed by Dr. Mundra. Thank you, sir.
Thank you, Dr. Mundra, for delivering a wonderful talk, and thank you, chairpersons. Now I will invite to Dr. Sujita Kumari, Medical Superintendent of Jaipur, to facilitate our speaker as well as chairperson. Please. Chairperson, Dr. Mathur, and Dr. Monica, and Dr. Rahul. ठीक है सर.
So now we have our next session. more of the session. We have Dr. Indra Mohan Chok. Please come on the dais, sir. And he'll be discussing with us the case-based discussion on acute breathlessness. And we have chairperson Dr. Sanjeev Jain. Please come on to the dais. And we have Dr. Ram Babu and Dr. Kamal Karnani. Please come to the stage.
The presentation खोली है?
हाँ खोली हुई है.
Over to the chairperson.
लगा दो बैकड्रॉप नहीं.
About 25% or less, that is that
Respected chairpersons,
that even after initiation, only 20% people are controlled, and then they say insulin real RNA will be controlled. Fact is that the dose has not been increased appropriately. Now, this study only shows that the titration is highly suboptimal. Wherein the global benchmark is around 40,000 units per day of the basal insulin, we were at pathetic 80 units per day. And the fact is, after Bharat will be So, when they say that the basal can be given to 50% of body weight, I feel is that there is no upper limit, and there are so many pictures of mine daily. So one must understand that optimization
The speaker for the program is Dr. Indra Mohan Chok, who is the director of and head of the Department of Pulmonology at Max Hospital, Shalimar Bagh. Over to you, Dr. Chok.
Thank you at the outset. In this post-lunch session, I will be sharing my personal experience and how we practice respiratory medicine in our hospital. So the discussion is included in the cases. So I request the chairpersons to kindly give 20-minute time, including 4 minutes of question and answer session. So we will be discussing how we proceed and how the patient comes and how I practice. So there are no fancy slides. These are simple cases which will be discussed.
Sir, 14 minute level.
Yes, sir.
14 minute level. 20 minute. 14.
It was 16 plus 4. So, sir said 16 minutes for session, 4 minutes for session. So next, I will try to wind up in 15 to 20 minutes. So this is how the patients come to you in your practice or in the hospital. Mr. ABC, 24-year male, he had history of fall and he came with acute breathlessness, E2, V2, M5, pulse rate was 150, BP was 70/50, respiratory rate 50, saturation 75. Patient was intubated, stabilized in ear, chest showed left capital, decreased breath sounds. So how will you proceed? This is an open session, so what will you do next? All of you, this is an open session, so we will have question and answer session in between, so that all of you don't feel sleepy in the post-lunch session. And the chairperson can also participate. Yes, sir. X-ray chest and ABG. So very good. So we will proceed. Patient was stabilized, put on ventilator. So this is the chest X-ray of the patient. So now you all can see the chest X-ray of the patient. So what you can visualize is deep sulcus sign with the bilateral pneumothoraxis. There is blackness, increased blackness, and there is extensive pneumomediastinum and surgical emphysema. So this is all you can see, that there are bilateral extensive rib injuries, bilateral fracture, sternum and spine fracture. So first X-ray test was done and immediately pulmocol was given. This is the CT chest which was done. You can see these are the extensive pneumothoraces, pneumomediastinum, surgical emphysema. So now the diagnosis is confirmed. There is bilateral pneumothorax, and multiple rib fractures and probably hemothorax also. So what will you do next? Yes, sir. All of you should participate. You can speak. So pneumothorax, what will you do? Very simple. Yes, sir.
Physicians come forward.
Your patient is on ventilator in a tertiary
Suraj,
hospital.
Kisan, Mansi, come forward and give the answer to the question.
Yes, sir. You will do bilateral intercostal drainage tube. So that was done for this patient. This is the X-ray post ICD. You can see right side and left side. Patient was on ventilator and he was with us for a long time, approximately 3 to 4 weeks, and all the air drained out, and there was large drainage also, hemothorax also drained out. This is the next chest X-ray on the follow-up, where you can see the right and left drain. Patient was extubated. This is the CT which we got it done on day 3. Pneumothoraxes have resolved, and you can see some basal collapse. This is the chest tube. You can see. So now next question is whether bronchoscopy is required or not. Yes, sir. Patient with chest trauma, will you do bronchoscopy? Chairpersons.
Yes, sir. अगर परफॉर्मेंस करेगा तो ब्रोंकोस्कोपी जरूर है, फीस करेगा नहीं.
No, scientifically bronchoscopy is indicated. In patients of chest trauma, CECT chest is always indicated. Always get a contrast in our CT scan. And bronchoscopy is indicated 100% to rule out airway injury. Patient has to be taken because he had D8 to D12 spinal fractures. So bronchoscopy you must do since he had extensive surgical emphysema, bilateral pneumothoraxis and pneumomediastinum. So bronchoscopy was done to rule out airway injury. There was no airway injury. Many times you get tracheal tears, bronchial tear, or move on. So this is the chest X-ray on discharge. Patient was discharged, the family celebrated, and they were very thankful to us. So diagnosis was bilateral pneumothorax with hemothorax, extensive pneumomediastinum with surgical emphysema, multiple fracture ribs, bilateral ICD drain done, multiple spinal fracture, D8 to D12, patient recovered and discharged. So next case, PQRS, a healthcare worker in our hospital, 21-year-old female presented to ER with breathlessness and cough, right-sided chest pain, right side breath sounds were decreased, left side they were present. So now this is the chest X-ray. Very simple, very common. So you see white out, complete white out. This is known as opaque hemithorax. So what are the DDs of opaque hemithorax? Where there is complete white out on the right side. Yes, sir. All of you can participate. Very common situation. All of you get chest X-ray of your patients done.
And mediastinum also not significantly shifted. Huh?
Yes, sir. Mediastinum is shifted, sir.
Slightly.
You are an expert physician. So what are the details of opaque hemithorax?
Easy. First.
Yes, sir. Massive pleural effusion. Then collapse, consolidation. So, to make things simple, DD of opaque hemithorax, massive pleural effusion, lung collapse due to endobronchial obstruction, like a tumor or foreign body, endotracheal intubation. If you intubate, very common in the ICU, into the right or left main bronchus, consolidation, post-pneumonectomy, pulmonary agenesis or hypoplasia, when by birth one lung is absent, large mass, pulmonary, pleural or chest wall mass. So these are the details. So CT test was done. It was a case of massive pleural effusion. A pigtail drain was put in. So right lung expanded partially. There is basal collapse. Pleural fluid was sent and it came out in favor of tuberculosis. So anti-tubercular therapy was started in this patient. Now you can appreciate now the pigtail will come. It's a small drain you put in the chest to drain the fluid. So this you can see the drain. On day 3, this pigtail drain was removed and lung expanded and patient was sent home. This is the chest X-ray with pigtail drain in situ. This you can see. The pigtail drain and right lung expanded from white to black. So this was a case of right massive pleural effusion, right pigtail drainage, done tuberculosis and ATT is done with. Now the third case. XYZ 62-year female presented with cough, sputum, hemoptysis, HRCT done outside, small lobulated soft tissue mass in the trachea near the carina which was abutting the bronchial wall. So bilateral lung field showed hyperinflation and COPD changes. Patient was in Assam. There was an outstation OPD. She went to the surgical oncologist because of this mass lesion, soft tissue mass lesion in the central airway. This is the chest X-ray. It was done in our hospital. We cannot appreciate much. So what next? What next you will do? How will you proceed with this patient? CT was done. So next? No, before that, colored CT. Golden color.
Would you prefer for color CT or PET scan?
सर पेट स्कैन को ही मैं तो सिंपल भाषा में बोल रहा था सोने की तरह चमकते ना पीला पीला. I was putting words into your mouth so that you all can speak. It is for you. So next step is whenever there is a tumor or suspicion of mass, you will get whole body PET CT scan with contrast, right? So that should be done. This is commonly available and people get it on their own. So this is the PET scan. Yes sir. So central to करेंगे endobronchial ultrasound when there is lymph node or suspicion. So before that we should know the PET scan. Now in this I will restart it because near the trachea you can appreciate a soft tissue mass. एक बार इसको देखना PET CT. Now just 5 to 10 seconds. You see this trachea. This is the FDG uptake image and this is the HRCT. Now this is the soft tissue mass. So PET CT scan was done in this patient, and this is the report: non-FTG, non-enhancing endobronchial lesion with specks of calcification in right main bronchus closely abutting the bronchial wall, just at the level of carina, likely benign. Bronchoscopy, histopathology, and the scan has no other evidence. So we were ready for tumor resection. This is a central airway obstruction, immediate bronchoscopy and all over armamentarium. So bronchoscopy was done in this patient. To our surprise, there was a foreign body in the right upper lobe bronchus. So patient has swallowed this pill, and which has gone, and we took the history. Then she said she had severe headache during sleep and she swallowed a painkiller at night. And this was removed, and she didn't open it up. It was with the wrapper only. Now, as you can appreciate, we have removed this. It was just a 2-minute job. We were thinking that this is a tumor, but it came out to be right upper lobe foreign body, a pill with a wrapper. So this is very uncommon. You get tablets, dentures, pins, etc., but tablet with a wrapper. So this was removed, and patient was discharged in the evening only. So to just sum up the talk, acute breathlessness, what are the respiratory causes? They are acute exacerbation of asthma, COPD, pneumothorax, massive pleural effusion, lung collapse, consolidation, pneumonia, chest trauma, central airway obstruction, tumor foreign body, pulmonary embolism. Again, very common and missed often. Most common causes are asthma, COPD, ILD, acute exacerbations. They are the most common causes of acute breathlessness. So I have just shared 2-3 cases with you. And cardiac causes of acute breathlessness are heart failure and heart attack. All of you are very well aware. And then other causes, these are not miscellaneous causes, rather they are very important causes of acute breathlessness. Acute allergic reaction to any drug, right? It will give rise to laryngeal edema. So allergic reactions, they also lead to acute breathlessness and anxiety and panic attacks. These are also very common in the young generation. I see daily 1 to 2 patients with anxiety and psychiatric symptoms. They have deep-rooted causes and need psychiatric and psychological evaluation. Panic disorder and panic attacks are also very common. So you have to rule out, keep it in mind, you have to rule out the disease process and then only refer the patient. Thank you very much. So if you have any queries or questions, with the permission of chairpersons, we can discuss or one or two short cases.
Thank you, Dr. Jung, for clearing wonderful experience of the multiple cases. Now session is open for round 2 questions. Please, audience. No questions, then do the.
Now I ask the chairperson to please honor Dr. Chok. And Dr. Sakit Khan to honor the chairperson, please.
Thank you, sir. How are you? इधर आ जाओ सेंटर में.
So okay, now we have the next session. Dr. Sakit Khan, please stay on the stage. And we have the chairperson, Dr. Shashil Jain, Dr. Deepak Kothari. Please come to the dais, please.
Guys, welcome Dr. Satwik Khan. He needs no introduction as we all know him. And then over to you, sir, for the talk. Thank you.
All right, thank you very much. What I'll quickly do, in the interest of time, is tailoring insulin regimens for your patients. We know that you've got a lot of insulins available. You've got basal insulin, you've got bolus insulin, you've got pre-mixed insulins, 25-75 or 30-70 or 50-50. You've got a basal plus insulin, and then finally you have the answer in the form of basal bolus regimens. How do you tailor is simple. Whenever you have a patient come to you, you think the patient needs insulin. First of all, patients who need insulin would be insulinogenic. For example, a patient losing weight at diagnosis in a catabolic state, for example, ketosis or ketoacidosis, would need insulin. Patient has tried 3 to 4 OADs. One of them is sulfonylurea or glenide or gliclazide. Again, failing on 3 to 4 drugs was what all guidelines said. 3 drugs is what all guidelines said, but this is bound to change because 3 drugs, one of them was to be a secretagogue. But now what has happened is, because now you target more parts of the pathophysiology of the opening soft heart, so now probably it would be 4 to 5 drugs. If they fail, including one secretagogue, then you can always start insulin for your patients. So whenever you plan to start insulin, first of all is counsel your patient regarding insulin therapy. First injection can be given at the clinic itself, and get a proper SMBG done for your patient. So you can get a pre-post breakfast, pre-post lunch and pre-post dinner glucose levels done for your patient, because that will tell you which is the largest meal of the day. That will tell you the excursion that you have pre and post breakfast, pre and post lunch and pre and post dinner, and that will tell you whether the patient needs a basal plus, whether the patient needs a mixed insulin twice a day, whether the patient needs a 25-75, 50-50, 30-70, or in fact there are some patients who would need a 50-50 once a day and a 25-75 or 30-70 at other time of the day. If the patient is taking a very high carbohydrate meal and you plan to put the patient on a mixed insulin, 150-50 with the largest meal of the day, highest carbohydrate content, 125-75 or 30-70. So, Cipla sponsored this talk, but my views are my own. So, role of insulin in diabetes management, effective glycemic control. The earlier you achieve this glycemic control, you can decrease complications and you have flexibility in treatment. In addition to this, I will add 2 or 3 indications again. When you have a patient who has glucotoxicity, you want to bring down the glucose very quickly, insulin is the best therapy. You want to bring down lipotoxicity very quickly, again insulin is the best therapy. And if you have a patient come to you with very high triglycerides, that is what has happened in the last 1 month. I've got at least 10-12 patients admitted with pancreatitis, triglycerides 7,000, 8,000, 9,000. You want to bring down the triglycerides very quickly. Again, insulin is the therapy. So even if you have a patient with diabetes, very high triglyceride, you can easily give insulin, basal bolus. Non-diabetic, high triglyceride, you can always give a glucose potassium insulin infusion that can get down your triglycerides also. So you have rapid-acting insulins, you have got basal insulin, rapid-acting, ultra-short-acting insulin, combination of these insulins, and I guess basal bolus is one of the best insulin. The pre-mixed insulin, basal bolus is one of the best because it has got only one peak and the other is a basal insulin. Basal bolus, if the patient is taking only one meal, that is a large meal per day, you can always give a basal bolus once a day. So because this basal insulin will cover the fasting glucose levels and the bolus insulin once would cover the largest meal of the day, and the patient would be good to go because the basal part will cover around for 20-24 hours if it is glargine, but the basal bolus that is available has degludec that is acting for 42 hours, so that also decreases the risk of having ketosis and ketoacidosis. So now, premixed insulins are good, basal plus insulin or basal bolus insulin. Basal bolus is the standard, but that will basically mean that you have to give insulin 4 times, because you will give bolus 3 times and 1 basal. If you want to combine, you can always give a bolus in the morning, a bolus in the afternoon, and you can give a basal plus in the evening to decrease the number of injections that you want to give to your patients. In fact, you can give sometimes basal plus can be given twice a day, and you can cover the 3rd meal with a short-acting insulin, depending on how flexible the patient is and how routine the meals are for that patient. You can always choose your regimens. Basal bolus insulins, you can choose Glargine. Detivir, I guess most of us do not use, and you can use Deludac. Bolus insulins are Aspart, Lispro, Glucin, the faster Aspart and the ultra fast acting Lispro. Premixed insulins have fixed proportion of basal and bolus insulin, not very good because the patient may change his carbohydrate content once in a while. The patient may want to have something sweet to eat. If you have a patient on a basal bolus regimen, you can always increase the dose of bolus insulin whenever the patient takes a high carbohydrate load, which is not possible in a premixed insulin, because when you increase the dose of a premixed insulin, you increase both the components. So that would entail a risk of hypoglycemia for your patient. Premixed insulin, once your patient is stable, you know the pattern of insulin and the diet of the patient is pretty stabilized. Then you can always give your patients premixed insulin. That can be, again, as I said, 2 different premixed insulins can be given, or you can give the same premixed insulin twice a day. So it can be a 30-70 twice a day, or 25-75 twice a day, or even you can give a 30-70, 25-75 once, and you can give a 50-50 at other time of the day when the carbohydrate meal is very high in carbohydrates, and you can cover that meal with 50% of the bolus insulin. But be very careful that if you use a 50-50 insulin that has 50% as bolus insulin, the risk of hypoglycemia is going to go high. I am not a very big fan of giving premixed insulins thrice a day, because when you give a premixed insulin thrice a day, what happens is you have 2 peaks with each premix. The intermediate acting of the first insulin that you have given dose would be overlapping with the next bolus dose. This won't happen again when you are giving it the 3rd time. Your bolus insulin given 2nd time of the day, in the afternoon for example, would be overlapping with the intermediate acting of the next insulin or the bolus insulin. The intermediate acting that you give would overlap with the next bolus insulin. So this risk of hypoglycemia is very high. Giving a premixed insulin 3 times means you are having 6 peaks, and 6 peaks are, out of them 3 peaks are overlapping, so you have very high risk of hypoglycemia. So I don't entertain 3 doses of premixed insulin, but you look at the Indian guidelines, they do suggest that you can give premixed insulin twice a day. I would suggest do not give that premixed insulin 3 times a day. Instead, what you can do is you can give a basal plus insulin twice a day, and you can give a bolus insulin once a day. That would be very good, because then you have only 3 peaks. With a basal plus given twice a day in the morning, in the evening, you cover your fasting, and because it's a basal insulin and a bolus insulin, you have only 3 peaks, and you can always modify those peaks, or give a rapid acting insulin in the morning, a rapid acting in the evening, and give a basal plus in the evening. You can choose where to give the basal plus, because basal plus insulin has Deludac. So you can choose what meal you want to give, a shorter 30% bolus where you want to give. That you can choose. It can be afternoon, evening, or even breakfast that you can choose. The commonly used premixed insulins, 30-70. You have the analogs, you have got the older insulins. Analogs are somewhat expensive as compared to the older insulins. But the benefit of analog is that it can be given before, with, or even just after the meal. So it is very good for someone who does not plan to take a full meal, because what will happen with intermediate, with the older insulins, it has to be taken 15 minutes before meal. So you take the meal, your food is on the table, the food is going to get cold, and then you take that food. So it is like waiting for 15-20 minutes before taking your food. With the analogs, the advantage is that you can take it just before the meal. The food served on the table, you take insulin, take your food, or you can take it midway, or even after taking the full meal, you can always have the insulin. Regimen is very important. That is what I was telling you. You have to tailor. No one size fits all will not be happening. So guidelines say that basal insulin should be the first insulin. I don't think you should always you do that. Look at the SMBG. If a patient SMBG on drugs has a fasting of 100, postprandials are 250. I don't think the patient needs basal insulin. The patient needs a bolus insulin, a prandial insulin. Then look at what is the excursion that happens after meals. If the excursion is less than 55, the patient does not need a bolus insulin. If the excursion is more than 55, the patient needs a bolus insulin. So you can then decide what regimen you want to give after you have a SMBG for that patient for the whole day, or you have a staggered SMBG, self-monitoring blood glucose, for all the meals. So that you can decide what is the pre-meal value, what is the post-meal value, and what is the excursion. Whether you want to give a bolus insulin here, Where do you want to give the basal plus? Where do you want to give the long-acting insulin or the basal insulin? Key factors: glycemic goals, lifestyle preferences, health status, risk, comorbid conditions, cost and accessibility, and patient's cognitive and physical activity are important. The important part is no hypoglycemia. One episode of hypoglycemia would mean that the patient would have hypoglycemic unawareness for the next 2 weeks. Second, it is a prothrombotic stage, can also cause arrhythmia, so be very careful. So I guess you have to tailor, so there is no guideline that can tell you what insulin to use first and what insulin to use second. It is your tailoring that needs to be that is very important, and that would depend on the SNBG. Again, I would not take you through guidelines because they don't make any sense for me, and all the insulins would do justice to your patient if you choose the right insulin for the right patient, and then go on to treat those patients. I guess I'll take questions. I will not be taking you through the cases because I didn't find anything very good in the cases, but I can take any questions that you have. Any queries, comments, or most welcome. आपको comment करना है।
I thank you, sir, for such an elaborate and detailed answer. And any questions from the audience, please give me.
So, as always, he's an expert in giving clear messages. So, he has given us the message that how to use insulin and when to use insulin, and we should not delay in using insulin. So, we have one question from Dr. Ramesh.
We see number of prescriptions where oral anti-diabetics are insulin mixed. Number of them, like Mixtard with Glimepiride, Mixtard with something else. How do you say this combination are correct, wrong, or right? Should we prescribe, should not?
I would have somewhat pragmatic answer on that. Whenever you plan to start a premixed insulin for a patient on secretagogues, you will increase the risk of hypoglycemia. It is always wiser to cut down the dose of secretagogues, but don't stop it altogether, because whenever you start insulin, it is exogenous insulin. That insulin would not enter the portal circulation. That is just going into the blood from the subcutaneous tissue. The insulin that is secreted in response to secretagogues, it is from the pancreas. The first thing is, it is from the pancreas cells in a paracrine fashion. That is the only insulin that would decrease your glucagon. In diabetes, you have increase in glucagon. That is the only insulin that is secreted by secretagogues that will enter the portal circulation. That would inhibit the hepatic glucose output. So the insulin that is secreted by secretagogues is the insulin that will decrease hepatic glucose output as also postprandial glucose level. So it can decrease both fasting and postprandials. So my message for starting a premixed insulin, I'm not a very big fan of premixes. I'm a fan of basal insulin. And with the number of drugs that we have for controlling postprandials like secretagogues, you've got Glimepiride, gliclazide, you've got neticlinide, ripaglinide, wonderful drugs, and AGIs. I guess we underutilize AGIs. No hypoglycemia. They do not even enter the circulation. They're just excreted in the stools. So the number of drugs that you have for controlling postprandial hypoglycemia, you're left with fasting. So fasting can easily be fixed with your basal insulin. But if you plan to use a basal plus or a premixed insulin, cut down the dose of postprandial for secretagogues. You can always have AGIs for your patient at this time also. Drugs that can decrease hyperglycemia. But something that secretagogues can do, I guess no other can do, because glucagon goes down, portal circulation, insulin enters, high concentration, that is exogenous insulin cannot do.
So now we have the next chairperson, please. Please hold it. So now I rather request Dr. Saket. Now we have our next session. The Dr. Rakesh Gupta with us, who will enlighten us on electric cardiography. And for that we have is Dr. Amarpreet Raya, last Raya to come on the stage. There. And now Dr. Rakesh, please sir, stay on the stage for the next session. And now we get the Saket also. And the stage please. And all the session chairperson.
We are in for another interesting session by Dr. Rakesh Gupta, well-known echocardiographer in this area. Probably everybody knows him. They must have entered serious stress echo reports. So he's going to enlighten us on the echo. Dr. Rakesh.
Thank you, Dr. Sood. Thank you, everybody. I can only say that, look, echo is not a modality which everybody can understand. What we do every day is what we write is two-dimensional echo. So I'll take you a journey. I'll be very slow. I'm not going to be very fast. I like to present only one or two cases. Take your opinion. How does it change your life completely? And my presentation says, "Ye dil mange wo." That's what in echocardiography is. That's one first patient, hypertensive on irregular medicine. BP appears to be uncontrolled, presented for routine echo evaluation on demand of physicians. He's hypertensive, not in failure, borderline elevated LDL level along with serum cholesterol, XHS was normal, ECG was normal, and on top of that, that is his echo findings, echo R. I'm sure many of you say that we do not know echo. But I'll say, look, his good LV systolic function is present. But only thing is, he has got a large LA size. Very first simple finding of large LA size. He is hypertensive. Second finding is, he has got a concentric LVH. It means to say that person who is hypertensive, whose BP is 200 by 100, his LA size has become bigger and he has got a concentric LVH. Now look at his LV function. Super dynamic LV with hypertrophy with 66% of ejection fractions. And that's what a normal report comes, normal LV size and shape, concentric LVH with left ventricular hypertrophy. When we look after for diastology functions, it is what is his LA pressures. And these are the parameters normally done by everybody, says EA ratio less than 1, grade 1 diastolic dysfunction, and many of the reports says normal LV systolic function with abnormal diastolic functions. And in this JS 2009 guidelines, it's classified into grade 2. So what are the total findings as seen in this report is, patient has got a dilated LA, LVH, normal LV systolic function, grade 2 diastolic dysfunction, mild MR, normal pulmonary arterioles. Are we happy? We are always happy with the same. Can we treat this patient based on report? We do treat this patient based on reports. What else we can do in 2025 to get more information from this echocardiography? So that's what I mean. We need to do more, and that's what more is. This is what the GLS is, global longitudinal function. It detects subclinical LV dysfunction. What does it mean by? Suppose my LV is hypertrophic. All of us understand when it gets hypertrophic, it demands more of oxygen and start working less. Can we get that subclinical LV dysfunction? This is one modality which tells you that this person has got a reduced GLS, and this reduced GLS in this patient is minus 17.7, when normal LV GLS is 20. On top of that, this modality itself tells you, look, there is an apical sparing, and this apical sparing is suggestive or suspecting of amyloidosis. So we went on to do further, and then we did an LV function evaluation based on 2016 guidelines. We classified this patient as grade 1 normal LV volume index, suggesting that his LV pressures are normal. Now my whole focus is changed with this echo. My focus is not on LV hypertrophy, my focus is let me go ahead and investigate further for amyloidosis. Now findings are dilated LA, LVH, concentric LVH with apical sparing suggestive of amyloidosis, normal LV systolic function or reduced LV systolic function based on GLS. It was grade 2 earlier, now it has become grade 1, so we are not bothered as far as LV pressures are concerned. We have a mild MR and normal PA pulmonary artery pressures. Suppose you leave this patient as such over there. Look at this JAC 2021 guidelines. This patient belongs to stage B heart failure. What is stage B heart failure? Stage B heart failure means he is asymptomatic, going to become symptomatic if you don't treat him over a period of time. It is not only the control of blood pressure, it has to be tight control of a blood pressure, which should be there. And this is one picture from a JAC, JACE 2014, talking of apical sparing, looking for amyloidosis. And believe my words, the paper published in Journal of American College of Cardiology, it says aortic stenosis patient has got more than 19% of amyloidosis. I do not know what country. And now this patient is concentric LVH, normal LV systolic function by reduced GLS, grade 1 diastolic dysfunction, and patient is in stage B heart failure. What more? The important thing comes from this importance of LVH, published in again JACE in 2011. This is what somebody has got a significant LVH versus this is almost a normal LV wall thickness. Look at the cumulative mortality of this patient. Dramatically different. So we just can't pass off a hypertrophy which could be concentric, eccentric, hypertrophy or concentric remodeling, which we often report in our reports. This is not the only thing. This echo tells you about cause, it tells you about treatment options, it tells you about prognostication of the patient. And that's what we did in this patient talking of stage B heart failure. When this is just published in Indian Heart Journal, we did about 660 study cases in our center. What was the answer? Prevalence of stage B heart failure in patient undergoing echo in routine clinical practice. And what are the parameters we looked? We looked at LA volume index, we looked at mitral E2A ratio, and this is what GLS we looked at. And we looked at other number of other abnormalities, and believe my words, more than 50% of our population presenting with hypertension, diabetes, they are in stage 4. Very innocuous. We say, no, nothing is abnormal in this patient. It is not true. We have to look more for a proper echo evaluation because this will guide you for a therapy. And those who understand, then only we can treat them better than anybody else. Let's move further for case 2. Hypertensive subjects refer for echo evaluation. Again hypertensive, nothing significant, and majority of time we see aortic knuckle in our XHS. What does this aortic knuckle? Everybody passes that. It is an innocuous finding because calcium is depositing everywhere. Don't we look for a calcium scoring in our CT scan? If the calcium score is present in a CT scan which is high, is not this aortic knuckle is going to be bad for this patient? And that's what we did in this echo. I'll just come down straight to this picture. Look carefully in this picture. This patient has got extensive calcification all along the valves and the walls. What does it mean by? Should I look for a coronary calcium for these subjects? No, I was telling you, look, this is a calcium which is seen on this patient. And when we looked at this calcium, we found that this patient has got a significant calcium scoring, and nowadays we can look at this calcium scoring by echocardiography. Look at the person who has got an absent papillary muscle, absent annular calcium, absent aortic sclerosis, ascending aorta and calcium. And look at this paper says 0 calcium versus more than 0. Look at the cumulative incidence of coronary artery disease or other cardiac mortalities. Just one single thing, one simple finding changes a complete scenario in a clinical practice. And more than 50% of these people, if they put them on stress, they will come out to be positive for stress echocardiography. They are not simple innocuous patients. They are harboring coronary artery disease almost 1 out of 2. So next time you see a calcium, please subject those patients for a stress echocardiography to unearth whether they are carrying a coronary artery disease or not. Last subject, very interesting diabetic subject. Again, a systolic murmur in tricuspid area, patient in congestive heart failure. Nothing significant, but urine albumin is present. What do we importance we give to a urine albumin as of today? We hardly. But this urine albumin itself is a predictor for cardiovascular disease. It's not my work, it's published in a paper. If you happen to see a urine albumin for no cause, we have to take care of definitely. Now, X-ray chest, ECG, nothing significant, but one important thing is we always say LV systolic function. Again, normal. Beautiful imaging quality, good LV systolic function. I'm trying to show the person who has got a normal function but something abnormal. Mild MR, and we look at the most important thing is LA volume index. What is this LA volume index? Anything more than 34 cc per meter body surface area. If I put this LA volume index in the circumstances where it makes a lot of differences, look at this paper published in JACC 2013. What it says, determine the prognostic importance of LA dilatation in patient with type 2 diabetes with no history of cardiovascular disease. And it says that increased LA volume index is an independent incremental predictor for cardiovascular mortality and morbidity in type 2 diabetes. Dr. Saket Khan's topic, which everybody is trying to look for it. And we are the capital of the world, if not the second capital of the world in our diabetes mellitus. Do we ever look for LA volume index in this subset of population? No. And majority of these patients, they come back either with dyspnea or dyspnea with exertion. And echo says normal LV systolic functions. Look at this LA volume index. And again, look at this paper published in JACC 2021. Diabetic cardiomyopathy, enlarged LA, impaired myocardial functions, elevated filling pressure like LA volume index, and impaired yields. And that is a marker for this particular phenomenon. I'll put my talk over here. And before that, I always say, look, we have to look at this subset of population. Doing a treatment is well, it's a good thing to do. But the most important thing in today's circumstances is we have to have something different in our armamentarium, looking at a prevention topic in every one of us is suffering from. 3 important things, hypertension, diabetes and obesity. They are rampant in our country. And that's what my take-home message is. And for the same thing, we are organizing the first cardio-echometabolic symposium on 17th August 2025 in Ashoka Hotel, New Delhi. And quite interesting topic, advances in heart failure. Then most important thing is the advances in atrial fibrillation, heart failure. Third is coronary artery disease. And we are amalgamating echo with clinical cardiology. And we are celebrating 25 years of Jurop establishment in echo teaching. We have more than 5,000 students spread world over as of today. We can see the people coming from UK and USA back to us for learning echocardiography today. And many of these students would be over there. Then a mixed bag of cases. And finally, the most important thing, a new topic which we are putting up is a cardio-obstetric symposium where every obstetrician knows, like patient hypertension in normal pregnancy, hypertension, diabetes in normal pregnancy, echo evaluation, many patients coming with dyspnea, hypertension, other things, and finally peripartum cardiomyopathy. Thank you very much for your patience.
Thank you, Rakesh, for covering up a very interesting topic. I think once you have a report of diastolic dysfunction, it is important to get NT-proBNP done. Because many times on normal echo you may have normal, but raise the NT-proBNP so the patient is into diastolic heart failure and they need diuretic.
I'm just coming by the paper. We are collecting a data of almost 10,000 patients nationally and internationally. Looking at what you said is NT-proBNP, LA size, concentric elevates or LV geometry, GLS, LA stain and RV stain in the susceptible population. Asymptomatic hypertensive diabetic population. And we are combining with not Indian population, we are combining with Bangladesh, Nepal and Sri Lanka along with that. Hopefully in 2 years time we will try to show that paper, and in case everything goes well, we show their follow-ups also. What exactly happened to these subset populations. That's what our aim is.
Thank you, Dr. Rakesh Gupta. Please, sir. Thank you, Dr. Rakesh Gupta, sir. As usual, wonderful talk always and very dynamic. Thank you, chairpersons. Now I invite to Dr. J.K. Sharma. Dr. J.K. Sharma to felicitate our speaker. And I request Dr. J.K. Sharma to felicitate also my chairpersons, Dr. Rakesh Sood and Dr. Sakir Khan. Sir, Rakesh sir. I also request Dr. J.K. Sharma to felicitate Dr. Rakesh Sood, our past president of NDA, and the judge for this session. Dr. Rajiv Dewan, where is Dr. Rajiv Dewan? I also, now I request Dr. Rakesh Gupta. Sir, please come on, guys. Dr. Rakesh. To felicitate Dr. Rajiv Dewan. And now also request Dr. Rakesh Gupta and Dr. J.K. Sharma to felicitate Dr. N.N. Jha.
Now, Sharma sir, now participate with Ram Babu.
So now time for the reward to our dedicated team and our lovely students for doing the wonderful work and morning for the pre-paper presentations, e-poster and the quiz. So for pre-paper category, there are the 3 categories. All the 3 candidates have done wonderful job, but just as per jury's result, first award go to the Dr. Cecil from Lady Harding. Dr. Cecil, है Cecil? Just कोई Lady Harding का कोई है? आ जाओ। So now I request to Dr. J.K. Sharma. 3100, go first. Check it. And the certificate take and certificate from the for second pre-paper category. I invite to Dr. Aditya. For that the prize money is at 2100. And all the candidates please collect the certificate from the registration area. And third prize goes to the Dr. Saurabh. कहाँ से सौरभ? सर गंगाराम हॉस्पिटल. Where is the 1100 third prize?
It looks that all the candidates are present here to receive their checks. इनको पहले ही बता दिया गया था. Congratulations.
Good. For next category of quiz for felicitation, I want to invite Dr. S.K. Mundra as the secretary. And Dr. Sushita. And first prize goes to the is a tie between the R Hospital and Sir Gangaram. Dr. Praveen Pradhan, Dr. Deepan Jyoti Nanda, Dr. Adit Malti, and Dr. Saurabh Gupta.
कितने पैसे हैं?
So this is the first prize. इधर दोनों की टीम थी ना ये. तो टीम के जो दे दिया था 1 and 2 टीम को. That the second and third team got the same numbers. That is 30. So it divided into 2. ठीक है. First prize goes to all of the 4. And prize money is the 3100. That's 50 for money each team. दोनों दो चेक कराना पड़ेगा. दोनों के चेक कराना पड़ेगा. दोनों चेक. ठीक है. आओ चलो. बीच में आ जाओ. आओ सर आगे. अगली बार हम पढ़ा दीजिए. And for quiz second prize going to the Jaipur Golden team, Dr. Kishan, Dr. Mansi and Dr. Marisa. The amount is the 2100. अरे क्या बात कर रहे हो?
बाकी जो बचा है एमएस दे देगी आप लोग. हाँ. एमएस ऑफिस में आके. जो ऑनलाइन तो बनेगी. एमएस.
और अच्छे से करना है. फर्स्ट पोजीशन पे लेके आना है. और थर्ड प्राइज फॉर क्विज. Okay. Goes to the LXMC team. Okay, this is the 1100 and Dr. ये नीरज नारायण बरुआ. Okay, Ravi Sudarshan and the Shishir Khan. Well, third one. Shishir Khan. Okay. अपने नाम अपने आप जिसको all the students collect all the student certificate from the registration account. And for the pre-paper category, we have only 2 candidate entry. So first prize goes to the Dr. Neeraj. कहाँ से? Neeraj from Dr. Lady Harry Hospital. That is at 3100. And the second prize for the e-poster category goes to the Ravi. That is at 2100. Thank you. So, congratulations to all of you, and please collect, please. And collect certificates from the registration count and mention your name, first, second, and third category, and the participation certificate also. Now, all are invited for the high tea. Please come on, enjoy.
Scientific session over in this hall. You can participate in the hall A, and after there is the high tea and two.